सद्गुण वैभवशालिनी सद्गुण वैभवशालिनी त्रिभुवन विख्याता ओम जय सरस्वती माता।
चंद्रवदनी पद्मासिनी द्युति मंगलकारी
मैया द्युति मंगलकारी
सोहि शुभ हंस सवारी सोहि शुभ हंस सवारी अतुल तेज धारी
ओम जय सर
हेलो हेलो ओके ठीक थैंक यू सो मच
And the pointer is be here.
pointer is there
Okay. Hello. কোথায় আছে কোন ফাইল? তুমি ওকে বলো না, আমি খুলে নিচ্ছি। আচ্ছা, হলে হ্যাঁ ঠিক আছে। আপলোড করেছিস?
Sir, he asked me whether it is coming properly or not.
Yes, yes. Let me see. Where is the cursor? Your name?
Dr. Yamuna Ramanathan, sir.
Just running fine.
Yes, sir.
So you are from?
Command Hospital, sir.
Okay. Which year?
It's the second year. Okay, sir. Thank you.
শেয়ার করুন।
চেক হ্যালো চেক
We are about to begin Dr. Shantanu Banerjee Video Award. I request all the participants to come inside the hall. Dr. Devabroto Das, Dr. Divya Sethi, Dr. Yamuna Ranganathan, okay. Dr. Saurabh Gupta, Dr. Sambhavi Shukla? No. नहीं? ओ ओके सामने आ जाइए कितना पीछे बैठे हैं प्लीज कम फॉरवर्ड डॉक्टर सुरजाना विश्वास ओके না আসুক।
Hello.
সুগত দা টাইমার কই টাইমার? আমারটা তাই আছে।
আরে ইন্দ্রনীল যাকে ঢোকা, ইন্দ্রনীল সেন, ডক্টর ইন্দ্রনীল সেন।
মনে হয় বাইরে গল্প করতে লেগে গেছে।
হ্যাঁ বাইরে নেই, ওয়াশরুমে যাবেন। কোথায় ওয়াশরুমে? আচ্ছা ঠিক আছে, দাঁড়া ওয়াশরুমে যেতে। ডক্টর দেবব্রত দাস।
সৌগতদা কোন ফোল্ডারে আছে ওটা?
ভিডিও আবার দেখো, হলে এই যে শান্তনু ব্যানার্জি, হলে শান্তনু ব্যানার্জি, সিএসএফ লিগ এটা। ও এটা তো কি ভিডিও?
হ্যাঁ এটা ভিডিও।
আর প্রেজেন্টেশন আছে এই তো, না এটাই তো ভিডিওই তো, সরি। হ্যাঁ একদম মানে এ করবে, শুরু দেবে। হ্যাঁ ঠিক আছে। So we are starting our first session, Dr. Shantanu Banerjee video session. লাইভ করে দিয়েছিল ইউটিউবে, ইউটিউব লাইভ করেছে। আর এখানে স্ক্রিনে দাও, করা আছে, স্ক্রিনে অন করো। I invite Dr. Our judges, Dr. Somendranath Bandyopadhyay, Dr. Professor Indranil Sen, and Dr. Anandabroto Bose. And our first participant, Dr. Debabrata Das, His topic is CSF leak, various sites and different approaches.
Start Kori. Good morning. Good morning, respected judges. Today is the second day of the conference. So my topic is CSF leak, various sites, different approaches. Kigo, chole na kenon? Yes, so this is usually how a patient of CSF leak usually presents. So from the presentation, it's evident. I'm not going into the biochemical details of this study, but from the presentation, it is evident that the patient is having CSF leak. And then we go for the investigation straight away, the CT cysternography. Somewhere the defect is small, in elsewhere it may be large. To ascertain in these sort of defects whether the defect is having many encephalocele inside it, we do sometimes MRI to detect whether there is encephalocele. So now the approaches to do this kind of leakage repair, we used two approaches. This is the narrow corridor approach, that is, this is the meningocele in between the septum and the middle turbinate, and after detecting the meningocele, we straight away bipolarize the meningocele and start to delineate the skull base defect where from the meningocele comes. So here this one is the defect, and after delineating the defect clearly, we go for layered repair of the defect. So this is another case. So we started our leak repair with the layers of fat. This is the first layer of fat being insinuated into the defect. We try to push it inside the defect so that it get inside and snugly fit. And every time after giving the layer of fats or pushing the fat inside, we place a piece of merocil over it and push it so that it get plastered with the defect. So this is the pushing of the merocil through the layer of the fat legs, and this is the picture after the plastering of that fat layer. So this is the vision again. Now the second layer is the fascia lata being given, or you can say we are carpeting the defect with the fascia lata, and after giving the fascia lata, we pack that area with the Surgicel and Abgels. So this is again pressing that fascia lata with the Surgicel to get plastered with the defect, and this is the packing with the Surgicel, and then closure or packing the nasal cavity with the merocil. So another type of approach is the wide corridor approach. I'm sorry for the quality of video because it was done a year back, long back, but this is the wide corridor approach. So this is the inferior turbinate, this is the cut down part of the middle turbinate attached to the ground lamella, and this is the resected part of the middle turbinate that kept in the nasal cavity or in the nasopharynx. This is the site of the middle turbinate which has been excised sharply and kept it down. And now we do the formal ethmoidectomy to delineate the skull base defect properly when the defect size is more than 5 millimeters. It's a large defect. So after that, we again go for the bipolarization of the defect and pressing and layered repair of the defect by layers of fat and then fascia lata. For the larger defects, in the previous case, we haven't used the tissue glue, but in larger defects, we use the tissue glue. So this is the tissue glue being used over the fascia lata, after which we again layered the defect with Surgicel, and again the tissue glue was used to reinforce the repair. So this is Surgicel placed, now tissue glue again, once again, and finally we try to place the middle turbinate up again, so that this is the middle turbinate being placed upside, so that the whole assembly is get reinforced by the middle turbinate and get stabilized. This is another case. This is the classical teapot sign, and when we go for the CT imaging, the defect was in an unusual location, that is the clival defect. So there is a defect in the clivus that was detected, and the sphenoid sinus get poured over with the CSF, and when the patient assumes his head down, it come out from the nasal cavity. So this is the resection of the middle turbinate. Again, we go for the wide exposure of the, we need wide exposure of the sphenoid sinus. This is the sphenoid sinus filled with CSF, and we do the formal ethmoidectomy and middle metal antostomy to get the anatomical landmarks intact. And this is again the exposure of the sphenoid sinus being done. This is the straightaway entry into the sphenoid sinus, removal of the rostrum to widen the exposure, and this one is the defect 1. This one, I am saying 1 because there is a surprise. This is the defect 1, that is the clival defect. Surprisingly, even after, in spite of having that defect, there is another defect in the optic strut. This is the optic strut area which is having another leakage. These are micro dehiscence. And through that one, the CSF is coming out. So this is the defect 1 being skeletonized. And after skeletonization, both the defects, we go for skull base. With the skull base cauterization, we bipolarize the defects or the area judiciously. This is the micro dehiscence in the optic strut. This one is the defect, this one. And then we again go for the repair of the defect, multi-layer repair of the defect with the fat. This one is the defect in the clivus that is being repaired with the legs of the fat. We always try to insinuate the fat inside the defect so that it get tightly, snugly fit there. And then this is difficult to get inside the defect, but we layered the defect with, these are the 2 sides of the defect being repaired. This is the obliteration of the sphenoid sinus being done. This is the basically tricky area of the lateral recess was obliterated first, and then, sorry, and then the fascia lata is being wrapped or carpeted over both the defects. So both the defects get layered repair with the fat and the fascia lata. These are the 2 defects being repaired, and after that, the entire cavity is packed with fat harvested from thigh. This is the obliteration of the entire cavity. Sagittal packing been done. And again, we follow the same principle that we reposition the middle turbinate back again inside that cavity so that the whole assembly being reinforced by the middle turbinates. And as it is attached with the, along with its attachment, so it has its vascularity intact. So this is another case, the traumatic leak that is in the frontal sinus, posterior trabele of the frontal sinus. The approach here is the external approach. So this is our approach. And then we, after removal of the outer part of the cortex, we bipolarize the defect, bipolarize the meningocele, and then skeletonization of the defect was done. This is the defect. It was a large one, more than 1.5 centimeter, and we decided to repair it with the septal cartilage. This is the skeletonization of the defect being done. And it was so large that we think a piece of cartilage might be short, might come short, and this was actually the scenario. It was repaired by pieces of cartilage hammocked inside the defect. This was cartilage 1, this was cartilage 2 being inserted. Even after that, there is a triangular area here. There is a triangular area here, which was again dehiscent, and which we again reinforced with another small piece of cartilage. And after which we remove the entire frontal sinus mucosa to prevent the recurrence or prevent the complications of mucocele. After that, the repair was again reinforced by the fascia lata. Here again, there is not carpeting. As the defect is large, we insinuated the fascia lata inside the defect. So this is the fascia lata being insinuated into the defect. And after that, the cavity is obliterated with the fat and fascia lata, with fat and sagittal, sorry. And the tissue glue was also applied. These are my post-operative videos, some of cases of the post-operative. Then she was my first case of CSF leak. I hope we will stand without mask with our patients very soon. Thank you.
Thank you. It was a very nice presentation.
Thank you, sir.
For the frontal sinus leak, why did you use this approach? Why not the osteoplastic technique? Because with a defect such big, there would be a defect in the... I'm extremely sorry. There would be a defect in the forehead. So why did you choose to do this?
Yes, you are right, sir. The osteoplastic flap is always an option for the repair, but we assess the defect and we studied the literature that there is equal success rate. If we repair with septal cartilage, the patient having less morbidity. So that's why we chose that approach.
Right. The cosmetic defect still stays.
Yes.
Thank you.
Next, Chola.
Next, there is little alteration in the serial. I request Dr. Divya Shetty. Her presentation is conservation laryngectomy in a patient with carcinoma glottis.
Just a minute, I'm not. No. Charges will be start. Then.
Good morning, sir. May I start? This video describes conservation laryngectomy in a patient with carcinoma glottis. A 63-year-old male, known case of diabetes mellitus, presented with chief complaint of hoarseness since 2 years. Oral cavity, oropharynx and neck examination was normal. Flexible fiber optic laryngoscopy revealed an ulceroproliferative growth involving the anterior commissure, anterior surface of bilateral true vocal cords, extending superiorly up to the ventricle and inferiorly 5 mm into the subglottis. In CCT neck, the lesion was obliterating the right paraglottic fat, anteriorly infiltrating the thyroid cartilage, and there was no significant lymphadenopathy. Emulscopy and biopsy was done. HPE was suggestive of squamous cell carcinoma. Clinical diagnosis was carcinoma glottis, stage 4A. Frontal partial laryngectomy with bilateral SND with elective tracheostomy was done. A horizontal skin incision was given between the thyroid notch and the suprasternal notch. It was extending to the sternocleidomastoid muscle laterally. The subplatysmal flap was raised superiorly up to the level of hyoid. Inferiorly, it was raised up to the clavicles. First, the neck was addressed, so we went ahead with a selective neck dissection. The right anterior border of the sternocleidomastoid was delineated. Following this, the right internal jugular vein was identified and delineated. Subsequently, the right spinal accessory nerve was identified and delineated. Right level 2A, 2B, 3 and 4 lymph nodes were removed. Similar steps were repeated on the left side for the left neck dissection, and bilateral neck dissection was completed. Following this, the primary tumor was addressed. Here we can see the strap muscles are being separated in the midline. After this, the thyroid cartilage was identified. As we can see, the tumor over the thyroid cartilage is being palpated. Exolaryngeal extension of the disease was there, so adequate soft tissue margins were taken around it on the thyroid cartilage. After this, incision was given on the perichondrium. This step shows the elevation of perichondrium. The perichondrium is being elevated here so that it can be repositioned later at the time of closure. In the next step, the perichondrium is elevated further to expose the thyroid cartilage. Here, the thyroid cartilage is exposed. Next, we proceeded with elective tracheostomy. A horizontal skin incision was given between the cricoid and suprasternal notch. The tracheostomy site was circumscribed so that it doesn't communicate with the primary surgical field. After completion of tracheostomy, primary resection was continued. Next, we proceeded by giving horizontal and vertical cuts over the thyroid cartilage. The superior horizontal cut was given 3 mm below the thyroid notch. Moving on to the vertical cuts. The vertical cuts on both the sides were given at the junction of medial 2/3 and lateral 1/3 of the thyroid cartilage. The inferior horizontal cut was given above the superior level of cricoid cartilage. On the inner surface, the cuts were given over paraglottic space, false vocal cords, and on the true vocal cords just anterior to the vocal processes of the arytenoids, preserving both the cricoarytenoid units. In any partial laryngectomy, preservation of at least one cricoarytenoid unit is mandatory. Next, the cartilaginous cuts were joined with the internal mucosal cuts on both sides so that en bloc resection of the tumor and specimen can be done. Here we can see the cuts that were given just anterior to the vocal processes of the arytenoids. The tumor is being resected en bloc. The entire specimen with the tumor is being removed. After resection, we can see the bilateral vocal processes of the arytenoids. The cut edges of the mucosa were sutured laterally to the tissue. Since the defect was small, primary closure was planned. The strap muscles were approximated in the midline for primary closure. In order to cover the primary defect, the strap muscles were sutured in the midline. A 14 French drain was placed in the neck and the wound was closed in layers. Post-op HPR was suggestive of moderately differentiated squamous cell carcinoma with all margins and lymph nodes free of the tumor. Patient also received post-op radiotherapy and is planned for decannulation once post-RT edema settles. His bilateral true vocal cords are mobile. Frontal partial laryngectomy offers good prognostic and functional results with intelligible speech, no breathing and swallowing problems. The overall quality of life is better when compared post-total laryngectomy. Studies show good local control, overall survival and disease-free survival with partial laryngectomy. Through this video, I wanted to demonstrate the technique of frontal partial laryngectomy, which is not so commonly done as total laryngectomy for treating advanced CA larynx. These are my references. Thank you. This video describes conservation laryngectomy in a patient with carcinoma glottis.
Okay, it was a good presentation. It is not so commonly done because we prefer to go for either total or either go for radiotherapy. Now the guideline is completely different. Now the most important thing is, in your video, why didn't you present the voice quality of your patient before and after? Because the most important part, that why do we do this partial laryngectomy, is to preserve the voice. Your video content would have been much better. Don't you think so?
Yes, sir, I agree, but I thought I'll wait for the decannulation first and then incorporate. However, the patient has normal voice. His true vocal cords are mobile. So there is mild hoarseness, which is post-operative and due to post-RT edema. So once he comes for follow-up and we decannulate him, I will take a video of his post-op voice.
When did you operate? How old was this case?
So this was done in December 2021.
Excellent. Thank you. That's all.
Thank you so much, sir.
I would request Dr. Devabrata Das to present the participation certificate to Dr. Divya Sethi. Next, I'd like to call Dr. Yamuna Ranganathan for the topic of autosclerosis and unusual presentation.
This one, sir. This is, can I have the handle mic with me? This is mic. It's okay. Can. Okay, sir.
প্রত্যেকটা
Yes, sir.
সাথে না 10টা টিক আছে কিনা দেখে নিতে হবে। So, Dr. Jamuna Ranganathan?
Yes, sir.
Yeah. Please start.
Myself, Dr. Yamuna. I'll be presenting a video on the topic an unusual finding in an exploratory tympanotomy in a case of conductive hearing loss mimicking clinical otosclerosis. Otosclerosis is defined as an hereditary localized bone disorder in an enchondral layer of otic capsule characterized by the abnormal resorption and deposition of the bone. Actually, in case of the OT capsule, the bone remodeling rate is just approximately 2%. But in case of the otosclerosis, the normal rate of the remodeling will be lost. So leading to the remodeling of the bone, foci of the calcification deposition which happens. This remodeled bone, when it bridges the stapedovestibular joint, it manifests as a conductive hearing loss. That is what the definition of the clinical otosclerosis. Not only the stapedovestibular joint, but when it involves the round window membrane, there also will be a clinical otosclerosis. And in case of when the remodeling of the bone, when it involves the cochlea, it manifests as a SNHL. The classical presentation of otosclerosis will be progressive hearing loss with no associated otological symptoms and no history of trauma, infarction with examination of eardrum will be intact. PTA will be suggestive of a conductive hearing loss. Herein, I'll be presenting a case of 41 years old male who presented with the complaints of decreased hearing bilateral since 24 years of age. On ENT evaluation, his bilateral TM was found to be intact and mobile, and tunic fork 256, 512, 104, 1024 were negative on the right. Weber is lateralized to the right ear. On PTA, right ear is suggestive of AB gap of 40 with left of 20. SRT of right ear is 70 and SDS is 70% of the right ear. Patient was counseled about with the difference, and patient went for the HRCT temporal bone of 0.6 mm thickness, which shows no otosclerotic foci and no ossicular anomaly with foramen spinosum was found to be normal. With the differential diagnosis of otosclerosis, patient was counseled about the patient management options. However, patient elected the exploratory tympanotomy, the surgical option. With all the pre-op instructions and the complications explained to the patient, patient was taken up for surgery, and his middle ear was visualized using the binocular operating microscope with the using a permeatal approach. Rosen's incision and the tympanomeatal flap was elevated. And posterior sufficient meatal bone at the level of posterior wall of the is removed to expose the pyramid and the stapes foot plate and the stapedius tendon. However, we had a surprise that absent pyramidal eminence and the stapedius muscle and the tendon were also found to be absent. Here, from the incus to the pyramid, there should be a stapedius muscle, but here it is absent. Following that, we check for the mobility of the ossicles. Here, incus mobility and foot plate of the stapes mobility was checked, and it was found to be fixed. And posterior crurotomy was done initially using the micro drill burr, following by skeeter, and using 90-degree pick, incurostapedial joint was dislocated. Stapes suprastructure was also removed. And the length from the lower border of the incus to the foot plate was measured using the shear rod. And the mucosa over the foot plate of the stapes was also removed. And we found that annular ligament of the oval window was also absent. Stepidotomy was done by using the serial dilatation using and perforator. We started with the size of 0.4 up to 0.7 mm. Teflon piston prosthesis was inserted of size of 4.5 cross 0.6 centimeter from the footplate of the stapes to the oval window. Hanging and the bending test was done, and the fat which was harvested from the ear lobule was placed over the stepidotomy site, and intra-op earring was assessed and tympanomeated flap was closed. With this surprise finding, we went with the review of radiological imaging, which showed the findings of left absent pyramidal eminence and the stapedial muscle in the radiology, like with the pre-op and the post-op was reviewed, and post-op follow-up at 2 weeks, which confirmed the AB gap of 16 decibel, which showed a closure of 24 decibel of. And coming to the discussion part, congenital middle ear malformations accounts for 1:10,000 births, and it also leads to the severe conductive hearing loss. In that, the most common congenital abnormality is the stapes fixation, followed by the IS joint discontinuity. But there are several other malformations are also reported in the literature as per this, cited the article AOIWBCON congenital malformations. But there is also a recent classification which was given by Tucson and the Creamer. In that, the class 1 is isolated stapes footplate fixation, class 2 is stapes fixation in combination with the congenital anomaly of ossicular chain, class 3 is anomalies plus the mobile foot stapes footplate, and class 4 is with aplasia or severe dysplasia of oval window or round window. But my finding of the absent stapedius muscle and tendon is absent in the classification, because this absent stapedius tendon and the muscle appears to be a rare congenital malformation with approximately 10 to 11 cases has been reported in the literature. However, subtle findings on HRCT scan like absent pyramid and the small oval window can warn a surgeon towards this pathology, and we must also look for it, though it is rare. And in a recent study, it shows an association between absent or hyperplastic pyramidal eminence and absent stapedial tendon aperture, which was identified on CT, and it has correlated with the intraoperative finding also. This is the study which was shown this association. So it will help in the better pre-op counseling of the patient, and they also associate with other congenital anomalies. This pre-op counseling part is important. However, in the primary surgeon experience, he also experienced with stapes footplate, there was also the malformed incus. So in that case, maliovestibular stapedopexy has to be done. So management depends on the congenital ossicular malformation which was present during the middle ear exploration. So my diagnosis changed to bilateral congenital ossicular anomaly with severe conductive hearing loss, right footplate fixation with Creamer type 1 operator. Coming to the conclusion part, the present case highlights the fact that owing to the rarity of the congenital anomalies, surgeon who explores the middle ear for conductive hearing loss may be caught unawares, leading to the inadequate management. Therefore, a thorough and comprehensive knowledge of existing anomalies will keep the surgeon better prepared to management. Although there is an existing classification, there is still scope of expansion to include the newly reported anomalies. Thank you.
Thank you, Dr. Yamuna. It is a very good documentation of surprises that we may encounter after anterior tympanotomy. I have two queries to you. Number one is, though it is a congenital ossicular abnormality, why did the patient present only at the age of 41 years, and he experienced his symptoms from the age of 24 years? And number two will be, when you encounter such ossicular abnormalities, what are the other surprises that you yourself be prepared for?
So for the first question, patient had a hearing loss at this age, mostly like which is more on the right side when compared to the left. So maybe at the young age he might have experienced only unilateral hearing loss. So the person we must have used his other hearing. So that is why maybe the reason for the late presentation. And for the second query, there are associated congenital anomalies like oval window atresia. In that case, the space will be so crowded for the stepidotomy and the insertion of the prosthesis. And there are chances of the facial nerve dehiscence also, as there are embryologically relation, so there are chances of the facial canal cord dehiscence.
Thank you.
Yes, sir.
I would like to request Dr. Ayan Kundu sir, to kindly provide the participation certificate. Next, I would like to call Dr. Saurabh Gupta for the next video presentation on endoscopic tympanoplasty, minimizing morbidity.
A very good morning to respected chairpersons, seniors in the audience, and dear colleagues. Today I'm going to present a video of the endoscopic tympanoplasty, minimizing morbidity. My patient is a 40-year-old male with a central perforation in the left ear, having mild conductive hearing loss. Now, as we are freshening the margins of the perforation, and as we can see, the endoscope provides a very excellent view of the disease. And we can use a sickle or a curved needle to freshen the margins. The margins better taken out in a ring all around, and oozing of the blood should come from the remnant TM. And as we can see, the endoscope is highlighting the main portion on the posterior part. So this is the learning curve of the endoscope. Now, the curved needle is used to make the perforation raw. So now the whole ring of the perforation is being taken out. Now we are giving a radial incision and raising the tympanomeatal flap. We give the incision 4 to 5 mm away from the annulus posteriorly. And we need to make sure that the tympanomeatal flap is separated from the bone cleanly, because the TM flap is worth diamond in case of ear surgeries. We're lifting the flap all around and till the annulus. And separating the fibrous from the tympano-squamous suture line. Now we are entering the middle ear. As we can see, we are lifting the annulus out of the sulcus. The chorda tympani comes into the view, and the middle ear mucosa also comes into the view. We have to carefully elevate from the inferior part so we do not leave any epithelial behind. Now, as we can see, we have to incise the mucosa of the middle ear so that we can raise the TM flap. And the TM flap is adhered to the chorda tympani also. Now, we incise the superior part, and the chorda also is mobilized during this process. Now, we have to very nicely, we can see that the chorda is getting stretched. So we need to separate the chorda from the TM flap. And this view is provided by the endoscope. This is slightly difficult. We cannot see in the microscope. Now the lateral process of the malleus is being separated, and the malleus is being made bare. And now we can see that the chorda tympani nerve is going underneath the malleus. So we need to separate the TM flap from the chorda. And as we do that, we can see that the ossicular chain is intact and the ossicular chain is mobile. We separate the malleus from the TM flap, and we need to make the malleus pair. Now we are checking the anterior ventilation pathway and the middle ear mucosa. There we incise that. There's a hypertrophic mucosa in the anterior part, and we separate the TM flap from the mucosa there. Now we are repositing the flap back to its original position, and we check. Now we are raising the flap anteriorly. Now this is reverse elevation from medial to lateral side. We use a round knife to raise the anterior annulus out of the sulcus. And we raise it 3 to 4 mm from the annulus, away from the annulus. And we raise it all around. We raise the 360 flap so that when we place the graft sits on the bare bone. Now, as we can see, we pass the endoscope in the middle ear and we check the ossicular integrity, we check the Eustachian tube area. And this is the beauty of the endoscope, which I like. This view is not provided by the microscope. We can see the anterior cura and the posterior cura and the stapedius tendon, and even the vascularity of the IS joint and over the promontory is clearly visible. So we have checked, everything is nice, and the anterior and posterior ventilation pathway is very clear, and there is nothing obstructing the ventilation. We now place the graft. It's a dry temporalis fascia graft harvested earlier, and now we place it in the middle ear with the crocodile forceps, and we drape it all around the perforation. Now we need to put this graft on the bare bone underneath the raised flap, and we need to make sure that it touches all around. As we can see, the air is trapped in the middle ear, and it is providing the bed for the fascia. We just need to make sure the inferior part and the anterior part, because these are more prone for residual perforations. As we place the posterior TM flap back, we need to check the anterior TM flap also, and we need to check that the graft is well placed on the anterior part of the canal, and we just mop up the soakage, and just to confirm that our graft placement is all right. Now the anterior TM which we have raised needs to be pushed back to the annulus to avoid the blunting. So we use a dry gel foam to push it anteriorly so that there is no blunting in the post-op time. So this using a dry gel foam is essential, because the wet gel foam will not provide the force. And after this, we pack the ear canal with gel foam and medicated gel foam. And this is how we minimize the morbidity, because the patient can go home without a mastoid bandage and can come back in the OPD later. Thank you. Thank you for the patient listening.
Thank you. Thank you for a wonderful presentation.
Thank you, sir.
What did you want to highlight with this presentation? I mean, what is so different in the technique, or what were you trying to highlight?
So I was highlighting that the patient does not need an end-oral or a post-oral incision for a simple type 1 tympanoplasty, and the patient and the vision which the endoscope provides, other than the microscope. As we are surgeons for the organ, we are not the surgeons of the instrument. So we need to adapt to the endoscope so that we provide better comfort to the patients. So.
Thank you.
Yes, sir. Thank you, sir.
I'd like to request Dr. Dipankar Mukherjee, sir, to kindly provide the participation certificate to the candidate. Next on stage, I would like to call Dr. Shambhavi Shukla for a case of complicated CM, labyrinthitis with lateral semicircular canal fistula.
So I'll start. Good morning, judges and audience. Complications and cases of chronic otitis media are a reality. Labyrinthine fistula forms one of the most common intratemporal complication of chronic otitis media, with lateral semicircular canal being the most affected site, and reported incidences is 4 to 13% in all cases. Here, today I'll be discussing 2 cases of chronic otitis media associated with lateral semicircular canal fistula. My first case is a 33 years old male who had presented with complete myalgia since 3 months, which was in serious progressive leave with medications. Complete epidurals started 2 days before admission, which was in serious mutant copious. He noticed sudden hearing loss on the same day. He also developed a vertigo since 2 days, which was initially unsteadiness, with feeling of being pushed towards the left side. There were no other ENT complaints. On the ENT examination, we saw that the ENT was inflamed. His granulations in anterior superior part of pars tensa, posterior part of pars tensa was bulging, and the pinhole perforation through which mucopollen discharge was seen on the pars tensa. Tuning fork revealed false negative Rene, and PTA was suggestive of left-sided profound sensory neural hearing loss. Otolaryngological examination revealed grade 1 nystagmus towards the left. Head impulse test was done, which was positive on the left. Fistula test was done on the patient, which was negative. Other otoneurological examination, such as facial nerve examination and cerebellar sense Romberg's, was negative, normal. Now on HRCT coronal section, we could see soft tissue density which was involving epitympanum, mesotympanum, hypotympanum. Mastoid was contracted and sclerosed, and we can nicely see a fistula present at the level of lateral semicircular canal. Now 2 days post the patient was admitted, the vertigo became intense. It was rotatory, continuous. It was associated with multiple episodes of nausea and vomiting. And the patient was unable to get off the bed, unable to carry on his daily activities. Based on history, clinical examination, and HRCT findings, we diagnosed him as a case of squamous chronic otitis media left active with labyrinthitis and lateral semicircular canal fistula. And the patient was taken up for emergency OT on the same day. Patient was managed with left canal wall down mastoidectomy, inside out route, with left semicircular canal resurfacing. We used post-auricular wild sensation. Superiorly based musculoperiosteal flap was raised. Meatotomy was done. The cholesteatoma was identified in prosac space involving posterior attic and posterior epitympanum. The sac was excised in toto. Necrosed incus was seen and it was also removed. Head of the malleus was nipped. Transcanal atticoantrostomy was done, so osterization of mastoid cavity was done. Facial ridge was lowered down for adequate exposure. After complete excision of disease clearance, we saw the fistula, which was present over lateral semicircular canal. Now the technique, it was a small fistula, approximately 2.3 by 0.7 mm, which was graded by Dornhofer type 2A. This was repaired by overlay technique temporalis fasciae graft, and it was sealed with a tissue glue. In post-op period, we remove the dressing on day 2. The patient complaints of vertigo had completely resolved by day 4. Intraoperatively, we had sent the tissue sample for Gram-stain, Zeren-stain, which was negative. Post-op, we can see the nystagmus had completely resolved. The head impulse test was repeated, which was normal. And patient was able to walk, carry on his day-to-day functions. This is 2 months follow-up picture where we can see well-healed epithelialized cavity, intact neotympanum, no complaint of otorrhea or hair. However, the PTA was repeated and it did not show any changes from earlier findings. In my second case, I have 44 years old male with complaint of reduced hearing since 1 year. It was insidious, progressive, and non-fluctuating. Complaint of otorrhea since 6 months, which was again insidious, continuous, scanty, purulent, foul-smelling. He gave history of unsteadiness since 1 month with swaying towards left and walking, and no other ENT complaints. On EAC examination on the left side, we can't miss the automastoidectomy. Pars tensa, grade 4 retraction is present. We can see Stapes head. Grade 4 pars flaccida retraction. Posterior superior retraction pocket with keratin debris was present. Fundus was not seen. On right ear examination, there is grade 2 pars tensa retraction. Prominent lateral process. Posterior superiorly, we can see incudostapedial joint. And grade 1 pars flaccida retraction. The tuning fork was suggestive of false negative Rene, and PTA was suggestive of left-sided profound SNHL. Fistula test was negative for this patient also. HRCT, we can see a smooth cavity with hypodense lesion, epicentered in the mesotympanum, eroding the lateral semicircular canal. Based on clinical evidences and HRCT, patient was diagnosed as a case of bilateral squamous COM with left labyrinthine fistula and left profound SNHL. We managed him with left canal wall down mastoidectomy, left labyrinthine fistula plugging this time, and partial mastoid cavity obliteration with tympanoplasty. Now the disease was primarily in mesotympanum. It was excised in toto. The automastoidectomy part was smoothened out. We can see it was a large fistula, and the facial which is completely exposed. Intra-op findings included erosion at various places. The lateral semicircular canal erosion, we saw the cholesteatoma was filling the labyrinthine fistula, and it was Dornhofer type 3 labyrinthine fistula, since it was involving the vestibule, reaching up to the vestibule. Now, this was a large fistula. We decided to go with plugging technique. First, we had filled with the muscle tissue. Over that, we had smoothened with bone plate and sealed with the fibrin glue. Later, secured with muscular periosteal flap. Post-operatively, we saw that there was no facial weakness, even though facial was exposed. Complaint of imbalance resolved by post-op day 2. This is 2 months follow-up picture, and we can see a well-epithelialized cavity. No complaints of otorrhea or... I would like to conclude by saying that Dornhofer and Milewski classified labyrinthine fistula based on involvement of cholesteatoma, which is basically on the degree of osseous and membrane labyrinth erosion. We used 2 different techniques of repair of 2 different fistula, and post-operative outcome was good in both patients. I would like to conclude by saying it goes without saying that surgery has to be done in cases of complicated chronic otitis media. And it is imperative that in the symptomatic cases of labyrinthine fistula, we have to undergo repair to avoid dangerous intracranial complications such as meningitis.
It's a good presentation. It's a known complication, that labyrinthitis with lateral semicircular canal.
So,
now your topic was a case of complicated thing, but you have presented 2 cases.
Yes, sir.
It's okay. The thing is, how was your post-operative monitoring? How long you should monitor this case?
So
ideally.
Now it has been 4 months that patient
and
what
are the armamentarium of post-operative monitoring of this
So
case?
first time PTA we did on after 3 months, because it takes at least 3 months for the cavity to completely settle down. In between, patient will have some otorrhea. Now we'll be regulating patient every monthly, and we'll be seeing if he's having any complaint of otorrhea or any complaint of vertigo. And then we'll monitor patients 6 monthly, sir, for a year.
Do you use routinely any vestibular sedative for a long time?
Sir,
these
no
cases?
vestibular sedative was needed in both our cases. The patient recovered post-surgery by post-op day 2.
Okay, thank you.
I'd like to request Dr. Manoj Guho, sir, to kindly provide a participation certificate to the candidate. So that's all we have in the video session award, because the last candidate has withdrawn from the candidature at the last moment. So we'll shift toward our next program schedule. So the next session that we'll be having is on differential diagnosis and management of cough. Speaker is Dr. Ashish Ghosh, and it will be chaired by Dr. Shamul Ghosh and Dr. Manoj Guha. So please. I once again request Dr. Manoj Guha sir and Dr. Amir Rasid sir to kindly take the chair. Disclaimer.
Good morning all. It's a great pleasure and as honor to present in front of this august audience. I would like to thank AOI West Bengal as well as Dr. Reddy's Laboratories for giving me the opportunity to speak in this platform. Okay. So today I want to highlight some salient points on differential diagnosis and management of cough. So at the end of this presentation, we'll be able to define cough, as well as we'll be able to classify the cough based on duration of symptoms and various etiologies, as well as we come to know how to manage a patient with cough. So cough is a vital protective reflex preventing aspiration, as well as it enhancing airway clearance. But sometimes it is so pathologically excessive and protracted that it is become very disabling complaints, and it will affect the quality of life, sleep, and productivity at workplace. It will sometimes it is so annoying that the patient may feel incontinence of urine, pain in the abdomen, as well as patient may feel of depression. On a typical day, a family physician will see at least one patient presenting with cough. So it is a common symptom, and the prevalence of the cough in India is about 5 to 10%. And on a given day, 30% of the all attendants at a peripheral or primary care setting will have a complaint of cough. The burden is so large, so big, that a large proportion of the patient, about 70% with cough, are treated empirically without any definite diagnosis. And cough is common symptom of tuberculosis at presentation, and the incidence is about 2.7 million. So this is all data. So cough, definitely we all know, it is a vital reflex mechanism of a forceful expiration against a closed glottis. And rapid expulsion of the air helps to clear the airway, preventing the aspiration. So now how to classify the cough depending on the duration. It is classified in acute, subacute, as well as chronic cough. When the duration is less than 3 weeks, it is called as acute cough. Subacute is called 3 to 8 weeks. And chronic, it is when it is more than 8 weeks. So diseases of the lower airway like asthma, aspiration, most common in the child age group, inhalation, intoxication, post-infectious cough, and diseases of the lung and pleura like pneumonia, pleurisy, pulmonary embolism cause acute cough. And in case of the diseases of lower airway or lung parenchyma like diffuse parenchymatous lung disease, RADS, other infectious disease, lung tumor, lung abscess can cause chronic cough that is of more than 8-week duration. So other long lung causes of cough, mainly for the acute cases, the infectious origin as well as allergic origin. And sometimes the cardiac issues may cause acute cough. In case of chronic cough, it is mainly the upper airway cough syndromes, that is due to postnasal drips and gastroesophageal reflux disease, sometimes some medicines, cardiac issues like endocarditis can cause chronic cough. So another classification is productive and non-productive. We all know the word non-productive itself denotes that it does not bring the mucus. So hacking cough reflects in the throat. The causes are postnasal drip, viral infection, GERD, some medications, etc. And in productive category, it typically brings the mucus, that is the phlegm, and chronic bronchitis, pneumonia, air pollutants, irritants, aspiration, lung cancers, and tuberculosis, all are the causes of productive cough. So detailed history taking and proper examination, systemic examination is necessary to classify the cough, identification the etiological factors, and to reach a provisional diagnosis, as well as, if necessary, we have to refer the patient to other specialties. Now, this is very interesting slide. The sound of cough may sometimes tell the diagnosis. In case of narrowed airway, when the medium size airway is involved, like the asthma, patient take one deep breath and followed by 2 to 3 bouts of strong cough. Just hear the quality of cough in case of asthma. In case of stiff lung, that is where the parenchyma is involved. The patient is unable to take deep breath. So multiple bouts of weak cough is there. And the cough sounds will be like this. And cough sounds in COPD is very much characteristics, and anyone on hearing the cough sound, we can gauge the patient may have COPD. And in case of filled field lungs, that is in tuberculosis, and in case of pneumonia, the multiple bouts of cough, and the first cough is very strong, and followed by the weaker cough, and the last one is the least powerful cough. Like this. So, the differential diagnosis of the cough, we already all come to know that PND, that is the postnasal drip syndrome, GERD, cough variant asthma, AC inhibitor medications, part 2C is neurogenic causes, psychogenic causes, foreign bodies, all are the causes of pulmonary and extrapulmonary causes of cough. So now the diagnostic algorithm all are almost same for the acute or chronic cough, but sometimes something is different. In acute cough, in adult patient, when the cough is less than 3 weeks, we will always screen the presence of red flag signs. What are the red flag signs? This is important because presence of hemoptysis and a smoker with 45 years of age with a new onset cough, or change of quality of cough, or any association of coexisting voice change, any presence of hoarseness, presence of fever, weight loss, and sometime weight gain also with peripheral edema, recurrent pneumonia, any patient chronic smoker, that is 55 to 80 years age group, who have 30 pack year smoking history, who quitted smoking within 15 years, that is also important. So any abnormal respiratory examination finding or abnormal X-ray all leads to red flag signs, and we have to screen this patient because this group of patient may have any serious issues, and we have to identify them and we have to treat them accordingly. So routinely assess cough severity and quality of life before and after the treatment is important to measure the effectiveness of the treatment, and routinely follow up the patient at 4 to 6 weeks after the initial visit. So diagnostic algorithm for chronic cough is also same. I'm not going in details, and subacute cough. And for the chronic cough, we have to focus, other than the previous slides, previous issues, we have to consider for the drug history. That is the AC inhibitor intake, history of smoking is also important, and some history suggestive of GERD, as well as upper airway cough syndrome, we have to exclude it. So this is a flow chart where the red flag signs have to identified and treated accordingly. Occupational and environmental issues should be inquired about. Physical examination we already always do, and we have to do a chest radiograph at least. Smoking, if there is, or AC inhibitor intake history, or sitagliptin intake history, that is hypoglycemic drug, we have to stop them and assess them after 4 to 6 weeks. If it is present, we have to go for other investigations. We have to assess for GERD symptoms or diagnosis. 24-hour esophageal pH monitoring, endoscopic video fluoroscopic swallowing evaluation, barium X-ray esophagus, sinus imaging, as well as sinus endoscopies, HRCT thorax, bronchoscopy, cardiac workup, and environmental and occupational assessment is just necessary in some time. So red flag signs we already described. So the next step is to assess the cough objectively by automatic cough detector and cough counter, because it is important for decision making, like we have to go for some intensive investigations further or not. We have to start some aggressive treatment or not. Then it also allows the objective assessment of the response to the treatment, and it is also make us to take decision whether to stop the particular treatment or not. So this is a very important validated cough severity tools, that is Panam ladders and Leicester cough questionnaires. In the left hand side there are 2 ladders, and the horizontal lines with score denotes the severity. The first one is the classification. First one is the cough severity ladder, and the second one is the overall quality of the quality of the patient that is presented in the ladder. The 0 score is no cough, to worst possible cough score is 10. In case of second ladder, there is score 0 for no problem and score 10 for the worst possible problem. And in case of Leicester cough questionnaires, there are 19 questions with each having 7 scores, and we have to assess them. So next, when to use cough suppressants. We have to treat the patient according to the etiology. So we have to identify the etiology first, not only the symptomatic treatment. And sometimes when it becomes very bothering and very disabling, antitussive treatment can be prescribed. So you all know the antitussive medicines are maybe centrally acting or peripherally acting. I'm not going in details, I think you all know this. So there is a comparison studies, various comparison studies between the peripherally acting drugs, that is a peripherally antitussive, levodopa, as well as centrally acting antitussive, that is dextromethorphan, and it is seen that the levodopa is more effective and more safe for the patient, rather in contrast to use of dextromethorphan. And one interesting thing is that levodopa, a new peripheral antitussive drug, does not hinder the positive and useful effect of cough. So cough reflex is present, reflex is not gone. So to conclude, cough is a normal defense mechanism, we all know. At times it can be debilitating and difficult to treat, and chronic cough may be due to single and multiple causes, and we have to address them all. And think of the common causes first. It is as usual for the other cases too, that is upper airway cough syndromes, GERD, NAEV, account for the most cases and should be evaluated in details. So cough may be at times the marker of a serious underlying condition. So thank you all. Thank you, judges.
Thank you, Dr. Ghosh, for your very nice and elaborated deliberation. You have almost covered every aspects for evaluation of this cough. This is a very common symptom we frequently encounter in our ENT practice, and it is at the same time it also sometimes becomes very difficult.
Exactly, sir.
So your deliberation is very elaborated and very nicely explained. Thank you very much.
Thank you, sir.
I would like to request Dr. Devabrata Das to kindly provide the participation certificate to Dr. Ashish. I would again like to request Dr. Devabrata Das to kindly provide the certificate and memento to our chairpersons, Dr. Manoj Go and Dr. M. A. Rashid. I would also like to request Dr. Indranil Sen to kindly receive the certificate and memento. I would like to request Dr. Snehashish Barman to kindly provide the memento to Dr. Indranil Sen. Now we would quickly shift to our next session. That's a symposium on cochlear implant session. The speaker being Dr. I.N. Kundu, Dr. N.V.K. Mohan and Dr. K.P. Verma. And it will be chaired by Dr. Piyush K. Roy and Dr. Roshit Chatterjee.
পীযুষ আসবে না আরম্ভ করব?
Sir, he is on the way. So you can start with the...
Good morning to all of my colleagues, seniors and juniors, and welcome the speakers for this symposium. Subject of this symposium is very interesting, cochlear implant. This is an evolving technology. Cochlear implant has created a paradigm shift in the management of severe to profound deafness. And very interesting history of starting. It started in 1957 by in France. But initially, and it is a subject of interdisciplinary effect, and that includes engineers, ENT surgeons, audiologists, neurologists, and psychologists. In 60s, when it started, it was a period of pioneering and experimentation. In 1970s, this was the time for feasibility study of the implant and auditory stimulation. And the next phase was the development of the commercially viable multicentric cochlear prosthesis. The initial starting was in France, as I told, but the literature was published in French, so it did not reach America. It accidentally or incidentally, one patient came for follow-up with William House. He is a dental surgeon, later turned on a otologic surgeons, and they have both brothers, William House and Howard House. They have otologic group in Los Angeles. In 1961, they implanted first case with a gold electrodes. But after few days, they removed the electrodes for fear of infection and others. Then they did another case in the same year, but they also removed that electrodes for fear of infection and others. Because they started studying on their own fund, that is cost a lot of funds. So there is a private funding is going on, and they have the advantage because they used to do vestibular schwannoma operation by middle cranial approach. So they used to do the study with the neurosurgeon. After that, it started in Stanford. And in the Stanford University, that fellow, Simmons, he started in 64 with the multiple electrodes. He started with 6 electrodes. But later on, in 1969, the House brothers, they stopped in between, and then again they start this implant with 5 electrodes. And later on it goes on, and in 1987, I think, it started in India, in Bombay, by Andrea D'Souza, as far as I remember. Now I welcome our friends on the dais, Dr. Indranath Kundu, Dr. Mohan, and Dr. Verma. I think all of you know Verma is from Southeastern Railway. Mohan is now at present at CMAR, and Indranath Kundu is professor in another department at Arjikar. Before I start, because we have got limitations, I will just like to make the few points. 15 minutes for each participant to submit their experience in this field. 15 minutes only. Because so it will cover 45 minutes. Then 10 minutes for interactions with the audience. And 5 minutes we kept for us for concluding remarks. I think I will ask Dr. Verma to give his experience and presentation in the initial phase.
Good morning, everybody. Respected chairperson, sirs. First of all, I would like to thank AOI West Bengal for giving me opportunity to present here on the topic of cochlear implantation. I have given the topic to discuss with is indication, candidacy, and pre-operative workup. Our chairperson, Dr. Asit Chatterjee, was involved with us. He was our honorary visiting consultant when I joined this place. This is a beautiful place. You can see the background. Two icons of Kolkata, Howrah Bridge and Vivekanand Setu. Just behind our iconic building of Southeastern Railway. I work here. It is a multi-specialty hospital, 350 bedded. And many specialty, many first has been done here in the city of Kolkata. This is our OPD setup. It was inaugurated by Financial Commissioner of Indian Railway and some of our children, implanted children. I would like to show one or two video because there is time constraint. So I'll go one or two video only. Sound please.
शुभकामनाएं देती हूँ। आप सब स्वस्थ और प्रसन्न रहें। मेरा कोक्लियर ऑपरेशन 2015 में डॉक्टर केवी वर्मा द्वारा हुआ था। अब मैं क्लास 2 में पढ़ रही हूँ। पहले मैं ना सुनती थी ना बोलती थी, पर इस ऑपरेशन के बाद मैं एक नॉर्मल बच्ची से सुन भी रही हूँ और बोल भी रही हूँ। आप सब कहते निमंत्रण है कि कभी हिम्मत ना छोड़िए। आपकी हमेशा आप जीत होगी। धन्यवाद।
किस देश में रहती हो? किस राज्य में रहती हो?
हमें है विश्वास, बुरा है विश्वास, हम होंगे कामयाब एक दिन। हैप्पी
जॉनी जॉनी सुना दो तो थोड़ा सा। जॉनी जॉनी नहीं सुनाया था। किट्टू जॉनी जॉनी सुना।
This is a live situation where the child who was implanted at the age of 1.5 years traveling in a car with noise, and see the result.
हो गया हो गया। ट्विंकल 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 सुना था।
किट्टू कहाँ जा रहे हो?
So regarding history, Ashish sir has already told a lot, so I am not going in much detail, just passing this slide. So what is cochlear implant? Some basic introduction about implant. It is a implantable electronic device, implantable, and it bypasses the damaged hair cells. It has got two parts. At present, it has got two parts. Research is going on so that it can become single implantable device. Outer one is processor, and inner one is receiver stimulator with electrode array. The electrode array goes inside the cochlea and directly stimulates the cochlear nerve. This is what initial implants look like. This is the earliest one. Then this is the first multi-channel device implanted in Australia, and these are recent ones. Currently, we can say 4 players are there in the world market, and all three these mentioned implants are good. Advanced Bionics from USA, Cochlear from Australia, Medel from Austria. One Neurolec is there from France, and some other players are also coming. Research is going on. So, why, when and for whom cochlear implant needed? cochlear implants are economically very costly device, hence the indication and candidacy must be precise and definite. Candidacy for CIE has changed gradually, but significantly since the first multi-channel device were implanted in the late 1970s. Due to increasing experience, improvement of technology, and proven reliability, and the selection criteria has broadened with shifting borders. Main extensions are related to age, additional handicaps, residual hearing, and special etiologies of deafness. The obvious goal for careful selection of cochlear implant patient is to never have a single patient perform more poorly with their CI than they did with their hearing aids. The selection of patient is a team approach. It starts from school teacher, parents, then it comes to audiologists, speech language pathologists, surgeon, caregivers, and psychologists. Everybody's role is important. It is not a single hand game. The stages in patient selections are questionnaires. What all things we have to ask to the patient and their party. Age, onset of hearing loss, whether it is prelingual, postlingual, duration of sensory deprivation, considering plasticity of brain, hearing aid use, audiological investigation, language assessment, radiological examination, psychological assessment, vestibular testing, medical and otological examination. Psychological assessment is done to know the mental status of patient, whether he will get benefit after this implant or not. If low IQ patient like Down syndrome, we can do implant, but we have to prognosticate the patient's parents. Vestibular testing is to know any vestibular defect before surgery. And medical and otological examination is obvious. We have to do surgery under general anesthesia, so it's needed. And counseling is very, very important because the surgery can go wrong anytime. It may benefit the patient, it may not benefit the patient after the implant. So counseling is very important. Next thing is, implant is only 10% in my opinion. The AVT, post-operative ABT is 90% part of the implantation rehabilitation. So we have to counsel the parents that they have to go for this AVT sessions as much as possible. Currently, FDA has approved for implanting. The minimum age is 12 months, although some people are doing surgery in around 6 months of age also. Some cases are reported. But the FDA approval is 12 months as of now. Changes in age of implantation are due to better and early identification of hearing loss. That is mostly due to universal hearing screening. In India, still we are missing this part, but slowly it is coming up. In our railway setup, we have started this program. So every children, they get discharged with this screening done. Then increased public awareness regarding cochlear implantation is also an important factor. Increased professional awareness. Technology has advanced, skill has advanced. Changes in technology includes better electrode arrays, thinner electrode arrays. Programming is becoming very good now. And intraoperative telemetry, nerve response can monitor. So with all help of all this, the indications has increased. The literature has demonstrated that in terms of speech development and language acquisition, the best results come from children implanted under the age of 2 years, similar to normal hearing children. All CI devices can be safely indicated for children below 12 months, up to above 12 months or older. However, implanting children younger than 12 months remains controversial. Further reduction in age at implantation are currently limited by the nature of audiologic testing in very young children. In cases of hearing loss due to meningitis or hereditary hearing loss, implantation should be considered before the age of 12 months with due care. These are batteries of audiological evaluation we have to do depending on the age of the candidate. It may be behavioral audiometry, VRA, free field audiometry, pure tone audiometry, especially for young, older children or adults. Tympanometry gives middle ear function, and in profoundly deaf acoustic reflexes usually we get absent. ABR is the gold standard. It may be ear specific or frequency specific. ASSR, OA is a screening test which is utilized in neonatal hearing screening. Then aided free field testing can be done, and some special tests are also recommended depending on the condition of the patient. This speech banana, our normal audiological curve should come in this part. If our curve is coming in this area, the patient is normal, and if it is coming below that, he is having hearing loss. So, what is the audiological thresholds for children for implantation? If it is 12 months to 23 months, it should be more than 90 decibel, that is profound hearing loss, and beyond that, severe to profound hearing loss is indicated. Speech detection and best fit hearing aids in a sound field equal to worse than 55%. Hearing aid trial for at least 3 months is given. It gives benefit. Even though small sounds the child get, it will help in development of the speech area, and then the child will get used to the hearing aid. During hearing aid trial, child should be making at least month-to-month auditory progress as well as speech and language progress. If this is not the case, then CI evaluation should be done. Additional evaluation should be speech and language assessment, psychological assessment, IQ testing, counseling, family support, motivation, and most importantly, realistic expectations. Medical and otological examination is required. Radiological examination, I will not go in much detail. Dr. Mohan will discuss that. For that, we have to do the gold standard is HRCT. It should include axial and coronal cuts of temporal bones, and it has advantage of superior visualization of the bony structure of the OT capsule and the course of the facial nerve. And it has got disadvantage, it can miss cochlear fibrosis, retrocochlear pathology, CNS abnormalities, and cochlear nerve hypoplasia or aplasia. Then next is MRI. It is important for delineation of the cochlear nerve bundle and their divisions. Axial cuts is looked for. Most effective in identifying cochlear fibrosis, able to identify presence or absence of cochlear nerve and caliber. It does not give proper visualization of bony anatomy, inability to detect the presence of the round window, oval window, or an enlarged vestibular aqueduct. Often requires anesthesia for young patients. Then MRI sagittal cuts of internal acoustic meatus to look for 4 nerve bundles in the internal auditory canal. It is very important. Adult candidacy criteria is proper history we have to take, onset and course of hearing loss, duration, etiology, history of hearing aid use, means of communication, education, motivation, and realistic expectations. So, due to shortage of time, I will pass some slides. This is important. Speech recognition testing is the cornerstone in adult CI patient selection, where the best added scores an open seat sentence test of less than 50% in the ear to be implanted, and less than 60% in contralateral ear is considered as an indication for implantation. Which ear should be chosen first? Residual hearing. In the early years of CI, the audiologically worse ear was chosen so that expected iatrogenic cochlear damage would have fewer consequences. In the late 1990s, the better ear with the most residual hearing was preferred, as studies had shown that better preserved peripheral neural pathways would lead to better result after CI. Still debate is going on. It is generally accepted that duration of deafness has a negative effect on CI performance. most clinicians choose the year with the shortest duration of deafness. I have got some experience in that. One adult I implanted after a gap of around 40 years, and I didn't get the desired result. I have implanted only 4 adults till now, and 3 has done good. If it is only functioning labyrinth, it may be due to surgical factors, due to otological medical history like otitis media, cholesteatoma, and personal factors. Usually right ear is preferred. These are contraindications: hearing loss of neural or central origin, absence of cochlea, absence of 8th nerve development, active mid-ear infection is a relative contraindication, psychological contraindications are there, other contraindications of surgery, Michael's deformity, that is absence of cochlea, tympanic membrane perforation, it can be done simultaneously, it can be repaired, severe organic brain dysfunction. These are immunization schedule, and this is a new topic. Now trend is going towards hybrid cochlear implant, where if the audiogram shows hearing loss up to 1.5 kilohertz, up to moderate hearing loss, and above 1.5 kilohertz, it is severe to profound, then in these cases we can go for hybrid cochlear implant, that is electroacoustic stimulation. This is the graph. I will explain this. This black area is for hybrid candidates. This area for hearing aids, where hearing loss is within, which can be corrected by hearing aids, and this area is for cochlear implant, where hearing loss is severe to profound. And in this area, where in lower frequency, hearing loss is up to moderate, and in higher frequency, it is severe to profound. So these are ideal candidates for hybrid candidates. Surgery part, Kundu sir will explain. These hybrid electrodes, long-term research shown that mechanical flexibility of the electrode array is one of the key factors for preserving residual hearing. Studied with different lengths of electrodes have shown that an insertion depth of 10 mm has a good chance of preserving residual hearing. Electrodes that can be inserted to a depth of 18 mm to 22 mm are a good compromise. Combines cochlear implant technology with a digital hearing aid. This device uses one microphone for the input, but has 2 separate digital sound processors for differentiating the processing. The parallel processing of these signals, however, is performed separately and optimized for both acoustic hearing and cochlear implant stimulation simultaneously. This is the...
Dr. Verma, you are encroaching on others' time.
Sir, bilateral implant can be done. It may be simultaneous or sequential, sir, or only 2 minutes. It has got some advantages and disadvantages. Improved hearing quiet, better sound localization, lateralization, improved hearing and noise, assure that better hearing is implanted, qualitative listening improvement, balance, richer quality, more confident feeling, and less fatigue. These are disadvantages. These are some special cases which will be discussed by our next speaker. Electrocochleogram, it helps in intraoperative damage to inner ear. It can be discussed, but time is short, so I am just passing over. So conclusion is overall the selection criteria have been broadened with increased experience and technological improvement. This development may continue, and the borderline between hearing and CI will shift further. However, the basis for success still remains good rehabilitation, a team approach, and the willingness of a patient to undergo the whole process of CT. Thanks for your patience hearing.
Thank you. This is an emerging subject. We can go on continuing hours after hours. But the management, they have restricted my time. So I would once again request to keep it your timing within the limit. I will next request Dr. NVK Mohan to give his presentation. Thank you.
Good morning, everyone. First of all, thanks to AOI West Bengal team. It feels so good to be back amongst friends, amongst family, and, the first physical conference in so many years. Anyway, oops. Right. So I'll come straight to the topic. I'm going to speak on surgical anatomy and imaging for cochlear implantation. Let's cut the basics. The sheer burden of hearing impairment is increasing, and with the increasing need and newer centers coming up, there is a need for us to understand the finer aspects of the cochlear implantation. This field as such is not new to us. We are all very acquainted with the middle ear, and we are all, especially in our country, we have enough workload on the otological aspect. But there is some fine aspects, about relevant aspects of anatomy and radiology so far as cochlear implants is concerned, and that's why it becomes important. So what are the approaches? We all know posterior tympanotomy, or the facial recess approach, which is the commonest approach, and then there is the suprameatal or varia technique, and the endomeatal, which is probably rarely done. So coming to the surgical anatomy relevant to cochlear implants. Posterior tympanotomy, we all know, between the vertical part of the facial nerve and the chordae tympani with the fossa incudis superiorly. We use the standard landmarks, the short process of the incus, lateral semicircular canal, and the digastric ridge. Mention here about the sentinel cell. There can be a cell, air cell, just before we enter the facial recess, and that can give us an idea that, okay, we are close. Now, a quick word about the dimensions of the variations that could affect the facial recess. Now, the crotch of the chordae tympani nerve, or the point of takeoff of the chordae tympani nerve from the facial nerve. Now, that is kind of variable. Gray's Anatomy puts it at 6 millimeters above the stylomastoid foramen, but there are different studies which say otherwise, and it can be very variable. But this Indian study, which is very interesting, and they had a mean of about 4 millimeters from the stylomastoid foramen. And there can be numerous variations in the course. It could arise below the stylomastoid foramen. It could bifurcate soon after arising. It could arise at the level of the lateral semicircular canal, or even branch into the posterior canal wall. And it subtends an angle of about 25 degrees with the facial nerve, the chordae tympani nerve. And what has been seen in this study, it's very interesting. It says the length of the facial recess, that is from the crotch of the chordae tympani to the posterior most prominent part of the short process of incus. So that is the length of the facial recess, and that's very variable. 9 to 18, I mean, it's a mean of 12. You can understand, I mean, it's twice from the minimal this thing. But there is a positive correlation with pneumatization. So more pneumatized the temporal bone, the longer will be the length of the facial recess. And not just that, there has been seen a positive correlation with the width of the facial nerve as facial recess as well. So if in a good well pneumatized mastoid bone, you are likely to have a longer facial recess and a wider one as well. And the width at the level of the facial recess is about 2.93 plus minus 0.4 millimeters. That's the width, but that's the maximum width that is available to us. And where do you get this maximum width? That is about, say, 3 to 3.8 millimeters below the short process of the incus. So if we keep the short process of incus in mind, and if we try to enter the facial recess, about, say, 3 millimeters, place a 3 millimeter burr at this thing and mark your point, and if you start there, that you're probably going to be safest. And so just skip that. Now, once we've done the facial recess, once we've opened the posterior tympanotomy, opened the facial recess and done the posterior tympanotomy, we need to be aware of this pyramidal ridge. The pyramidal ridge is a ledge of bone that can connect the pyramidal eminence with the styloid eminence. So it can be present in about 80% of patients. So, and this will restrict our view of the round window niche area. So we need to take that down. And once you've taken that down, the different kinds of visibility of the round window membrane. I'm not going to go too much into detail. Type 1 is after we've removed the overhang. If you can see the entire round window membrane, then that's type 1. Type 2A is where after removal you can expose 50 to 99%. Type 2B is 1% to 49% of the round window membrane exposed. And type 3 is where, despite taking down the overhang, you cannot visualize the round window membrane. Now let's come to the round window pre-chamber. Now the pre-chamber is the round window niche, along with the round window membrane itself. This whole area is called the pre-chamber, and the round window niche. We've got the round window membrane, and then we've got this anterior pillar. Anterior pillar and the posterior pillar. Now, the promontory or the overhang. The overhang is also called the tegmen, or sometimes it can also be called canopy or canonus. Different literatures, name them differently. So this whole area is of vital importance to us. This is our area of work. Now, also some relevant anatomy of the retrotympanum and why it is necessary. So this spicule of bone, this ledge of bone from the the anterior pillar down towards the hypotympanum, towards the jugular bulb actually, this is called the funiculus. Now the funiculus, the importance of the funiculus is it actually separates the hypotympanum from the inferior retrotympanum, right? And the fustus, this actually is a ledge of bone that connects the styloid eminence with the basal turn of the cochlea. Now, this identifying the fustus is very important because the fustus actually forms the floor of the round window niche area and will actually point towards the round window membrane, right? And this area below the fustus is called the Proctor's area of concamerata, which is cells that develop around the fustus, okay? And somewhere here could be the subcochlear canaliculus. Now this is a very vital structure that we need to identify. So this subcochlear canaliculus can be variably pneumatized, and that can actually, if the round window membrane is kind of obscured, that can actually appear as the round window niche, and people have been known to implant this area and land in trouble. So how do you steer clear of that? Obviously, the fustus. This subcochlear canaliculus is located between the fustus and the funiculus. That's why we need to identify these structures. And keep in mind the fustus, if you stay above the fustus, we are kind of safe. The subiculum, well, we all know this subiculum and the, this thing. I'm going to skip this part. Punticulus, it's probably just this thing. Now, once we've identified the round window membrane, now we need to be aware of the cochlear hook region. Now, we've all heard about the cochlear hook region. Cochlear hook region, what is it? The cochlear hook region is actually the most proximal part of the cochlea. So, and knowledge of this area is important for insertion. It's got a fish hook orientation, and the reason is soon after it starts, all the cochlear compartments actually rotate 90 degrees. So the orientation of the osseous spiral lamina, the basal membrane, and the spiral lamina, they all change from horizontal in the anatomical plane to vertical. And if you're operating, then in the right ear, it's it's above the round window membrane. In the left ear, it's going to be it's obviously above the. It's going to be to your left in the left ear and to your right on the right ear to begin with, and then it becomes the roof, and then it comes to your side. So if we are not careful about the angle of insertion, then we can end up injuring the osseous spiral lamina, and that kind of is counterintuitive for the whole surgery. So and the other thing to remember is, despite this change in orientation, the scala tympani still kind of follows an approximately straight trajectory for the first few millimeters. I would say about 8 or 9 millimeters. Right. So that's the basal turn. That's the round window membrane. Okay. That's the cochlear aqueduct. That's the inferior cochlear vein. And see, the whole thing turns 90 degrees. And if you look at the dissection, See, that's the round window membrane, that's the spiral lamina, and osseous spiral lamina, it turns really 90 degrees. That's the scala vestibuli, the scala tympani, this is the fistis, pyramidal eminence. That is the vestibule, right? So, now, we've, the other things to, keep in mind when we are at the beginning of insertion is the two bony prominences that are unique only to the hook area. That is the secondary spiral lamina here, which is above the spiral lamina, and it's present where it's on the top of the spiral lamina, at the superior rim of the round window membrane. And then the crista fenestra, which is anterior inferior to the round window membrane, and these two at the entry to the round cochlea, to the round window, to the scala tympani, they actually narrow the entry point variably. So we have to keep in mind these areas, and actually the crista fenestra, if it's very well developed, then it can actually change the direction of your initial direction of trajectory of your electrode, and that can lead to injury. This is a optical coherence tomogram picture, and that's the osseous spiral lamina. And you see, that's the round window membrane. You're going here. If this is too developed, then it can directly hit the osseous spiral lamina. Now, the other thing is that you might want to remember is if you encounter an ossified cochlea or a basal turn, and you're doing a drill out, the two things that you need to remember carefully is how far anteriorly can you go chasing the lumen. Now, you have to remember that the internal carotid artery is just about 12 millimeters away from the anterior edge of the round window membrane, and also, I mean, there's only about 1 or 2 millimeters that separates the internal carotid artery from the distalmost part of the basal turn. And also, if you have not been successful, or even if you have been partially successful in implanting the basal turn, you might want to access the middle turn as well. And where do you access that? Just, you can see that is the tensor tympani muscle. And just below the tensor tympani muscle, the processus cochleariformis is where you drill medially down, and you can find the middle turn of the cochlea, right? So these are the two things, and this is a coronal section. You can see the tensor tympani tendon, that's the processus cochleariformis, and you can see the middle turn right below here. Okay, that's the second turn of the cochlea. You can see there, and if you just drill down, you'll enter the middle turn of the cochlea. So that's an important thing to remember. Coming to the imaging for cochlear implantation. So what are the aims of imaging? Number one is to make sure that there's nothing that precludes an implant. So you rule out contraindications, and you also confirm candidacy. And number two is, once you've confirmed your candidacy, you have to identify if there are any deviations from normal anatomy, and especially those that might impact outcomes, because like Dr. Verma said, a lot depends upon how well you counsel the patients and the family. So you have to have as much information as you can preoperatively, so that you can counsel the family properly and have a happy patient and less weight on your mind. And also to study the anatomy of the temporal bones, so that you can anticipate any problems that might crop up, and also to prepare for any potential complications. Sorry, I'm a bit thirsty. So what modalities? CT and MR both. You cannot have one and not have the other. Sorry, but that's the bottom line. HRCT temporal bones and MRI brain and the inner ear with 3D reconstruction of the cochlea. And when do you do it? I would say this is what we practice. Soon after diagnosing the deafness, we do a MR to make sure that the child has a nerve and proper lumen, the cochlear structure, cochlea is there, and so that we can understand the feasibility of cochlear implant, and then we start workup. And then HRCT temporal bones probably just before the surgery, so that we can study the anatomy and then plan accordingly. You could have both done together, but sometimes we've seen that from the diagnosis to the patient coming onto the table, there's subsequent gap, because patients are arranging for fundings and all of that. So it makes sense to space them out, so that you've had two images done, and one at least at least one imaging done immediately before the surgery. So on the MR, let's talk of the MR first. On the MR, what do you look for? The two essential things that you look for is, one, is there an implantable structure? That is there a cochlea and a patent lumen of the cochlea? Do we have that? So that is to what you go by. And then, okay, we have a structure. Now I put in the implant. What structure is going to carry the impulse to the central nervous system? Is there a nerve? If there is a nerve, is it adequate? So, number one, implantable structure. Sorry, I'm going to overrun, please. I'm going to overrun. I'm 20 minutes jantam. Anyway, my lecture is longer. Anyway, so number one is an implantable structure, and then a stimulable structure. And what sequences? T2 weighted images, especially the 3D Fiesta is pretty helpful. And cuts, axial cuts, very important, and the parasagittal oblique sagittal cuts. Okay. Now, just give me a second, please. Okay. Now, I'm just going to now it's always best. Huh? Oh, sorry. Sorry about that. Right. Okay. So, so it's always best to study the scan on the console, and when you go down from above, as you go down, you can, as we're going down, see, we see the superior semicircular canal appearing here on the right. As we go down slowly, we can start to see the internal acoustic meatus appearing here. And as we go down, this is the vestibule appearing here. And on this side, you can see two streaks here, black streaks. The one anteriorly is that's the facial nerve. The one behind is the superior vestibular nerve. And as we go down, we can see the middle turn of the cochlea appearing. That's the middle turn. This is the vestibule. And further down, yes. Now, that's when we see the eighth nerve branching, the cochlear nerve entering through the cochlear canal. This is the black region here is the modiolus. This is the middle turn, the apical turn. And you can see the inferior vestibular nerve going towards the vestibule. Now, and if you look at this closer, then you can possibly, I'll show it on the pictures otherwise. Okay, so that's how we read it. Once we see these nerves entering the cochlear canal, then we know, okay, there's a nerve. And also, I would have liked to show you the parasagittal cuts, but I don't have them here. I'll show you on a still picture. And also sometimes on the sagittal cuts, coronal cuts, you can see the turns of the cochlea very nicely. You can see the turns of the cochlea. So, right, coming back to our main presentation. Right, so this, Dr. Verma already showed these structures. I'm going to skip that. Kilo? Kilo? Kilo, about take the second screen only. So, okay, on this you can see the chalo, proti chale galo. So you can see the osseous spiral lamina here. There's the scala vestibuli and the scala tympani of the basal turn, and that is the modiolus. And this is the blue arrow is the interscalar septae, right? So coming to the HRCT temporal bones, we do it before surgery. I'll not talk about all of this. It's better for identification of the dysplastic cochlea and identification of potential sources of complications. What do we look for? We look for pneumatization, or if there's any coexisting pathology. You look at the dura and the sinus, it's low-lying, or if it's a high-riding jugular bulb, then it might sometimes become difficult to access the round window. The facial nerve anatomy. Often we encounter, cochlear anomalies, and with that, there will be facial nerve anomalies, and that can actually make the whole surgery tricky. So we have to identify that, and CT scan is better for that. Dimensions of the dimensions of internal acoustic meatus and its junction with the cochlea. So these are important because, where if there is a communication between the internal acoustic meatus and the cochlea, then you can have a gusher. Also, you look at the vestibular aqueduct and partitions of the turns of the cochlea and the internal structure, architecture of the cochlea. So I would have liked to show you this thing, but we'll come to that later. So on the CT scan, on the axial cuts, you can see the superior semicircular canal. That is the vestibular aqueduct. This is the vestibule, internal acoustic canal. That is the labyrinthine portion of the facial nerve. This is the middle turn. Is going towards the genu. That is the greater superficial petrosal nerve, and this is the horizontal facial nerve appearing. Again, this is the horizontal facial nerve. This is the middle turn of the cochlea. Basal turn of the cochlea. This is the round window niche, and this is the middle turn. From the basal turn of the cochlea comes the cochlear aqueduct. This is the cochlear aqueduct. The vestibular aqueduct will arise from the undersurface of the vestibule, and it will slowly, when you scroll down on a video, then you can see it better. I would have loved to show you, but Snehashish is probably going to kick me out if I take more time. So that's the cochlear aperture. This black area is the cochlear aperture where the cochlear nerve will enter, and that whitish area, that is the modiolus. So that's the in type 1 incomplete partition type 1, you will have no modulus in the entirety of the structure, right? And this is a wonderful projection. That's a Stenver's projection, which can show all the turns of the cochlea. Right. The internal acoustic meatus, that's the falciform crest. We all know the anatomy, the falciform crest of Bill's bar. So you can see the falciform crest here. The subcochlear canaliculus, it can be, pneumatized to variable extent. This is type A, where it goes right up to the apex. Type B, it's pneumatized but not going right up to the apex. And type C, where it's all a fused bone, and you can heave a sigh of relief in these kind of situations. The trouble with subcochlear canaliculus is you can bypass the round window completely and implant the subcochlear canaliculus. So you have to keep that in mind. Enlarged vestibular aqueduct, the Cincinnati criteria that is now widely used instead of the Valvesori criteria, that says at the midpoint, if it's more than 1 millimeter, then it's enlarged vestibular aqueduct, and if it's more than 2 millimeters at the porus, that's here. If it's more than 2 millimeters here, then it's an enlarged vestibular aqueduct. On a MR, see, if you look at this, that's the middle turn of the cochlea. So this is the vestibule. So from the vestibule, just under surface of the vestibule, you can see this CSF space coming right up to the posterior fossa. So this is the enlarged vestibular aqueduct as it will look on the MR. And remember, I was talking about the dehiscence between the cochlea and the internal acoustic meatus. So you can see the basal turn dehiscent here. And these kind of cases are where you will have, you can expect gushers and at high risk for meningitis. The cochlear malformations, the type 1, total absence of, all intracochlear architecture, no modulus, no this thing. In type 2, the basal turn has this thing, the middle and apical turn are, fused, and that can actually be associated with an enlarged vestibular aqueduct as well as an enlarged vestibule, in which case it becomes a Mondini. And type 3 is where, the outer architecture is maintained and, it's all cystic. I think I'll, skip all of this for paucity of time, but I would have loved to show that. Okay, so let's come to the take-home message. The facial recess gives access. It's in a more pneumatized mass head bone. It's longer and wider, making your life easier. Proper identification is very vital for placement of the electrode. We don't want to, implant the subcochlear canal. Fustis is, important to guide us in guiding us towards the round window membrane. As long as we stay above it, we are, safe. The hook region we have to be aware of, and the changing orientation of the intercochlear structures. HRCT and MRI are both important. It is better to read your own scans. Remember that as we are gaining experience, so are our radiologists. So we cannot rely on our radiologist for all of this, because some of these malformations are so rare, even they are experiencing it for the first time. So it's better we learn to read our own scans as well. Thank you very much. Sorry for overrunning.
So thank you, Mohan, for your nice intricate deliberation regarding the intricacies of the operation property planning. Now I request Professor Dr. Indranath Kundu for your deliberation of lecture in a nutshell, because we are in time's strain.
Good morning to everyone. I am just covering the slide in a nutshell because the time is very short. We have overrun the time. Now, you know all the components of cochlear implantation. Cochlear, we are not going in detail. So, in Arjigar Medical College and in my personal experience, I have done limited number of cochlear implant. Number is only 36 till today. And the surgical procedure, we know the various techniques. There is a transcanal technique that I have never done, and the transmastoid technique, that is the classical technique that I have done. And the surgical steps you all know, that is the first is the cortical mastoidectomy, then posterior tympanotomy, then the insertion of electrode array through the basal turn of cochlea, and the placement of receiver stimulator in a well drilled in the skull in the retroauricular area. Now, almost all cases, in all cases, the general anesthesia was done. There is nothing special in general anesthesia. The antibiotics that we have chosen in almost all cases is the ceftriaxone as per the body weight, and minimum 4 days or 5 days post-operative period, and the first injection should be given at least 20 minutes before the insertion is made. Now, the precautions that we have to maintain in the operation theater, that is everything should be sterile surgical scrubs and the gloves, and the slippers should be very separate, one for washroom, other for the premises, and the slippers for the operating room should be always separate. Now, incision, there are many incisions, but what I have chosen is the extended post-auricular lazy edge incision, and before making the incision, we fill the air canal by betadine, so that the canal will be stained with betadine, and when we are inadvertently entering the canal, we can be very cautious about that. Now, the flaps that initially I started posteriorly based flap, then anteriorly based, then superiorly based. Now I have seen that the superiorly based flap is best flap to me, and because the approximation is good, and it almost covers all the areas of receiver stimulator. Now, this is the posterior post-auricular incision. Before making the incision, we have to assess what we have to make the incision for the receiver stimulator and the speech processor. Now, nothing special in it. You have to identify the probable area of drilling. clearly identify the posterior auricular margin, post-auricular area, and the fossa mastoidea, spine of Henle if it is there, and the inferior temporal line. Adequate exposure is a must. And the cortical mastectomy, nothing special it, because the mastoid is virgin, so it is very easy to do cortical mastoidectomy in this case. And the one thing that we have to do, the edges must be sharp, it should not be saucerized. The short process of incus is the first landmark for identification of the facial recess. The incus vertex must be kept intact. This is the area. We have done cortical mastoidectomy. The short process of the incus you can see. And this is the area of facial recess that we have to drill it down. There are so many techniques of doing posterior tympanotomy. One technique is you identify the vertical part of the fallopian canal, and after identification, you drill down the bone in front of it. But there are so many schools are there, but to me, it is easy for me that I drill the area and I come across, whenever I come across the fallopian canal, I give respect to it, and whenever I come across the chorda tympani, I give respect to it and try to preserve it. Now, posterior tympanotomy should be enlarged very much, so that, like stapes surgery, we have to see the pyramid, the promontory, the round window, and the full view, or almost the full view of the promontory. Now, it should be enlarged so, as much as possible. And one thing is that in case of neonates or in the 1 or 2 years of child, the size of the posterior tympanotomy is almost as large as we can do in adult patient. And sometimes if the posterior tympanotomy is not adequate to see the round window, then we have to make the anterior canal wall fractured so that we can see the round window. So this is the area you can see the round window, and this is the area round window. After identifying the round window, the insertion of electrode will be done, but sometimes we do the cochleostomy and sometimes we do the round window insertion, that is a soft insertion. To me, both are easy and both are giving equally good result. And when the round window is very much visible, I do insert the electrode through the round window. But whenever you are trying to do cochleostomy, you should drill the area, the anterior part of the round window, and until the scala tympani is visible. But the round window insertion is very much easy, and one have to make the setting on the round window with 0.5 to 5 millimeter that is in the surgery. And cochleostomy, we can do it, but there is chance of bone that can enter or chance of blood and enter into the scala tympani. And after all, whatever may be the round window insertion or cochleostomy insertion, the insertion site should be sealed with soft tissue. That is the muscle. Now, this is how we do the cochleostomy. This is the full picture of cochleostomy. Now, next is the making a well in the posterior part, in the post-auricular area. The well should be drilled with first with the cutting bud, then with the diamond bud with great caution, because the dura is very much superficial. Any dural bleeding can be managed with bipolar diathermy or by diamond drill. A hook-like projection should be made over the electrode array in the well that connects the mastectomy cavity and the well, so that the electrode will never slip. Now, this is how we make the well. Now, electrode insertion. Classically, the electrode insertion should be done with AOS or claw or watchmaker forceps. Now, time for cochlea to remain exposed should be minimum as possible, and time to time the cochlea should be irrigated with decadron solution. And whenever you are inserting the electrode, any resistance, we gently try to rotate the electrode array and advance further. And if it is resistance is hard, then don't try to advance it further. Now this is, we are irrigating the cochleostomy by gentamicin, by decadron injection. Now three types of cochlear implant I have used. This is advanced bionic, that is having with a plunger or inserter, and that is the easiest technique to insert the electrode array. This is the second case. This is another type of cochlear implantation, that is a Neurolec type that we got first in the EDIF scheme, and there is a guard in the electrode array, and so over insertion is prevented by that, and the electrode is slightly fixed by the guard. This is against the Neurolec implantation, Neurolec electrode. And last is the insertion of nucleus electrode that has no guard, and that I have done many cases. There is a fixation of receiver stimulator. Okay, that is the that is after insertion of the electrode into the cochleostome or the round window. The rest of the electrode should be placed in a coil-shaped manner in the mastectomy cavity so that it will not slip away. And almost in all cases, the patient should have NRT. In NRT, sometimes the patient may not show good NRT, but one should not be depressed because the entry of air, entry of blood or bone dust may give a fallacious NRT result, and usually it subsides after in second NRT. Now closure should be done layer by layer with Vicryl, and mastered bandage should be given, and this is the post-operative stub area. The post-operative rehabilitation, that is the switch on after 3 weeks of surgery, and on the 4th day the caregivers training, and the patient should be followed up 1 week, 2 weeks, 4 weeks, 6 weeks, and 10 weeks, 12, 14 weeks, and 18 weeks in the post-op, and then in 2 to 3 months, depending upon the individual. After 1 year of switch on, the patient should be followed up yearly or twice a year, and the mapping should be done, and the patient should be put on audiovestibular training. AVT should be done by good hand. Now regarding the complications, theoretically the complications are many. The complication may be classified as early complication and late complication. The early complication may be theoretically facial nerve palsy or paresis, infection, wound dehiscence, scalp infection, the early device failure, dislocation of the electrode, CSF leak, balance disturbance and meningitis, so on and so forth. And the late complication may be the early device extrusion, pain at the site of the implantation, implant migration and displacement, late device failure, otitis media, meningitis, so on and so forth. But for all practical purposes, the complications are very much less. The facial, now first we are discussing the main complications. The facial nerve palsy is very, very rare. Paresis may be there, but it can be managed by steroid, postoperative steroid. Next is the chora tympani nerve injury. It is best avoided by identifying the chora tympani nerve and reading the CT scan in a preoperative period. And but preservation of chora tympani is a must because many a patient will do cochlear implantation in the second year also. So one-sided preservation of chora tympani is a must. Now, bleeding. Bleeding is usually, now next is the bleeding. Bleeding may be due to high jugular valve and or that should be identified, and usually not, it doesn't cause any hindrance for insertion. Other bleeding side may be nagging bleeding from the emissary vein in the posterior part of the wound, and it can be well managed by drilling it or by bipolar diathermy. Dural bleeding may be troublesome, but usually it can be managed by bipolar. And next is the infection. Infection should be avoided by proper OT asepsis mainly, and prophylactic antibiotics, ceftriaxone, should be given. Now the wound dehiscence, it is mostly occurs whenever we are stitching the wound very tightly, and the treatment is allow the wound by to heal by secondary intention and put the patient on antibiotic. Next, the scalp problem. So scalp problem may be there, and ultimately we can apprehend that the implant may go out. So regular dressing, infection control, and antibiotics is a treatment. Now early device failure is it is a out-of-box failure, but there is no way to prevent it. The only prevention is keep another implant ready at the OT premises so that if this fails, we can put another implant. So this is a must. Next is the dislocation or incorrect position of the electrode. Almost all cases we should have transorbital view or strenuous view to see the position of the cochlear implant after doing the surgery. If any problem is there, we should go for HRCT. Now, there are so many theoretical possibilities that electrode may be in the lumen, may not be in the lumen of the cochlea. It may be in the semicircular canal, or it may be anywhere nearby in the hypotympanic cell, but it is very rare. So these are the theoretical possibilities. Now, CSF leak. CSF leak occurs whenever if you cause dural injury during the surgery, or during making the well, or it may be CSF gusser after you do the cochleostomy. The gusser should be apprehended beforehand if we study the HRCT of temporal bone meticulously before you do the surgery. And if it is CSF gusser, the treatment is put the head elevated and wait for a little. Usually the gusser stops, and there is hardly any difficulty to insert the electrode. And after inserting the electrode, you should plug the area with lot of muscles. Now, balance disturbance is very much rare. So, to me, the complications are basically one is the choroidal nerve injury, and other is the extrusion of the implant. Okay. The extrusion of the implant in one case there is extrusion of implant. We tried to cover it, the implant by plastic surgery with the help of plastic surgeons, but ultimately it failed, and we have to extract the implant. So whenever the surgery is good, candidacy is good, and everything is good, usually the results are very good. Video is not working. So you can expect good results out of cochlear implantation. Thank you all.
So thank you, sir. Dr. Kundu, please, and all the panelists, Dr. Verma, Dr. Mohan, Dr. Kunduji. আমি এখানে আমাদের টাইম কনস্ট্যান্ট আছে, তাও আমি একটা আমাদের স্যাররা বসে আছেন, এক লাইন আমি বলছি। আর্লি 2000, ইন দ্য ফার্স্ট ডিকেড অফ 2000, আমরা গেছি রামকৃষ্ণ মিশনে, প্রফেসর রায়চৌধুরী শুরু করেছিলেন দেখতে ককলিয়ার ইমপ্ল্যান্ট আউটলো, 3-4টা আমরা দেখে এসেছি। সে আমাদের শুরু স্যার 4 or 5। আমরা গেছি পিয়ালেস হাসপাতালে, দুলালদা শুরু করেছিলেন, আশিস লাইরি এসেছিলেন, দেখতে গেছি। আমরা বিএনআর হাসপাতালে গেছি, আর এখন তো বসে আছে যার কথা না বললেই নয়, অমিতাভদা, প্রফেসর ডক্টর অমিতাভ রায়চৌধুরী। শুধু ওয়েস্ট বেঙ্গলে নয়, ওয়েস্ট বেঙ্গলের বাইরেও উনি হেল্প করছেন। ডক্টর দুবে এসেছিলেন ভেরিয়ার টেকনিক দেখানোর জন্য আমাদের এখানে। আমরা এখন অনেকটাই ব্যাপারটাই একটা ইনফ্যান্ট স্টেজ থেকে এগোচ্ছি লার্নিং কার্ভে, তাতে দেখা যাচ্ছে পেশেন্টের ফলো আপ কমপ্লায়েন্স যদি না থাকে, অনেক পেশেন্ট হারিয়ে যাচ্ছে। আমাদের পিজির টিমটাতে 88 cochlear implant is already done through NPPCT program, most of them mentored by Professor Dr. Raichodhuri, এবং উনি একটা টিম বানিয়ে দিয়েছেন আমাদেরকে এত সুন্দরভাবে, how to, when to, what are the intricacies, what are the biofilms, what the routine steps we should do. I am really thankful, sir, to Amitabh. আর ঠিক আছে, হ্যাঁ, যত আমরা সিলেকশন ঠিকভাবে করব, যত আমরা এমআরআই সিটি গাইডেন্সের উপরে গুরুত্ব দেব, টু প্ল্যান দ্য সার্জারি প্রপার, হাউ বিগ দ্য ফেশিয়াল রিসেস, হাউ ওয়াইড দ্য ফেশিয়াল রিসেস, এই ডিফিকাল্টিগুলো অ্যান্টিসিপেট করে যত আমরা এগোবো, যত আমরা সেপসিস মেনটেন করব ডিউরিং অ্যাসেপসিভ টেকনিক ডিউরিং দ্য প্রসিডিওর অ্যান্ড পোস্ট অপারেটিভ ম্যাপিং অ্যান্ড ফলো আপ এভিটি অ্যান্ড ইউজুয়ালি সবই তো বলা হয়েছে যে বাইনোকুলার হলে ভালো হয় কেন হয়। থ্যাংক ইউ ফর অল অ্যান্ড লাস্ট স্যার উইল কনক্লুড দ্য সেশন।
The one thing we have to remember that cochlear implant is not a cure for deafness. It is a powerful technology that allows profoundly to severe to profoundly deaf children to function normally, and they can come into the, with the proper training after implantation, then they can come into the normal stream. And I will request the association to keep it in mind that this type of interesting and evolving technology, when we discuss, we keep it a little more time for the panelists. And I wish it would have been better if you could have included one speech pathologist or audiologist and a psychiatrist in this seminar team. Thank you. Once again, I thank the panelists and all the audience for their participation. As he has already mentioned, the time doesn't permit for interaction. So those who are interested, they can talk to the panelist after this is over.
Thank you, sir. May I request Dr. Ashit Chatterjee to hand over the memento and certificate to the 3 panelists. May I request Professor Ayan Kundu to receive the memento from Professor Ashit Chatterjee, please. May I request Professor Piyush Kanti Roy to hand over memento to Dr. N.V.K. Mohan. May I request Dr. Professor Ashit Chatterjee to hand over the memento and certificate to Dr. Kailash Prasad Verma, please. Now may I request Dr. N.V.K. Mohan to hand over memento to Dr. Ashit Chatterjee, please. And may I request Dr. N.V.K. Mohan again to hand over memento to Dr. Piyush Kanti Roy, please. Now we are running short of time, so we are shifting to the next panel discussion. May I call upon Dr. Professor Amitav Roy Chaudhary to the dais as moderator of the panel on laryngology, benign vocal fold lesions. May I request Dr. Doipan Mukherjee also to the dais, please.
Good morning. I just want to share one fact. My friend Dr. Khageshwar Raut from Bhubaneswar, Odisha, he is the organizing secretary of next ISOCON in the month of November in Bhubaneswar. He is here. He wants to present a small slide for his conference and promote the conference in front of all of you. So, and I will also request all of you to come to Bhubaneswar for this ISOCON 2022.
Thank you, Dr. Doipan. So, good morning all respected senior ENT surgeons, stalwart of ENT, I can say. So, I am not here for any academic event. I have just come for this promotion. So, I am Dr. Khageshwar. I am organizing secretary of 30th ISOCON. ISOCON 2022. We are planning for physical, totally physical conference, no virtual mode. So I urge you for, as you know, we are a part of Eastern Odisha, Eastern India. So everybody, if any conference comes in this part, people have lot of expectation. As Doipan has proved, many conference he has conducted many good conferences. So I will not take much of time. So this is a little highlight of our conference. So we have this is now early bird registration is going on. We are ending it in the month end of the March end. and this is our registration fee. And we are planning this time, as Odisha known for Puri Jagannath and Konark, we are adding apart from this academic event, we are adding some cultural and tourism sector. So for especially those are interested for staying at Puri and Konark, we are planning to have a session over there, some lecture and all, and followed by darshan and sightseeing. And lot of unseen area, unexplored area you can find. This time promoting with association of some different agency, tourism agency. So now we have finalized till now 2 international faculty, they are operating faculty, they have consented for us, one from Poland, another from Netherlands. They will operate on lateral skull base. As you know, AOIWBCON is a purely business oriented program, a lot of academic hands-on program are there. So 2 faculty till we have finalized consented, they will come at any cost. Even if pandemic, they will come, they will operate. Even if fourth wave come, they will they have assured us they will come. And these are national faculty, lot of national faculty were adding. So apart from that, we have consultant hour, video presentation, e-poster, PG award, free paper presentation, and we have temporal bone or dissection workshop. As you know, there is a format for a temporal bone gold medal award. The people can bring their dissected specimen and they can participate. Those cannot, they can come pre-conference and register and do temporal bone dissection. We are planning to, this is our venue Mayfair Lagoon. It is a central part of Bhubaneswar. It is well communicated by road, by railway station. It is very close to airport. So nothing much about the venue. These are nearby to Mayfair. There are good hotels, Trident, ITC has come recently, and good hotels are there. Hospitality will definitely will take care. And nothing much about this is Puri, Konark. Everybody know better than us because we receive lot of Bengali tourists day in and day out. So these are some tourist destinations. We have planned many tourist attraction this time. Non-explored area we can reach. So please do register and come with your family, friends, and pass on this message and do early registration so that we have add some morale to the conference. Our organizing team will boost their morale if you register and come and participate. Thank you very much.
May I request Dr. Khageshwar Raut to take his chair as one of the panelists, and may I call upon other panelists, Dr. Bidhan Roy, Dr. Soumitra Ghosh, Dr. Aniruddha Basu, Dr. Sudeep Kumar Das, and Dr. Somrat Bandyopadhyay to the dais, please.
দরকার নেই আর এখন সরি এরকম থাক এসছে স্লাইড শো ডুপ্লিকেট স্লাইড শো এটা করতে হবে তো এসে গেছে ওকে টাইমারটা আমি নেক্সট স্লাইড দেখালে টাইমার শুরু করবে এখন টাইমার দিই কি হবে Good morning. Respected seniors, my teachers, colleagues, second day of our physical conference after 2 years. After having gone through all the subspecialties, we still have head and neck and other specialties coming as a panel. We are going to conduct a very small panel for about 45 minutes is the time which has been given to me. I will not take much time introducing the speakers because they have already been invited, and So we would straight away go to the panel because the time is very short. Now, we decided to touch up on a very practical oriented panel discussion where we are going to look at some case scenarios that are present in our day-to-day laryngology practice as an otolaryngologist, routine otolaryngologist. So, first of all, I want to highlight that modern laryngology has changed the way we look at laryngeal lesions and laryngeal problems that the vocal problems that we have. And why is it so? The basis on which this has changed is because this is the picture of a cadaveric larynx where we can see we used to call them vocal cords, and that's what we read in our textbook. But if you look at the newer textbooks, you will find that they are referred to as vocal folds. Why is it so? Because of the multi-layered structure. This is a stroboscopic picture of a patient. So, this actually has changed the dimension and changed the way we look at laryngeal problem, because we have to deal and we have to think about all the layered structure of the vocal fold as far as the benign lesions are concerned. So, I would come to the panelists straight away. Indirect laryngoscopy, as you can see, I have put this incidentally was invented by a music teacher in Paris and not by a scientist, not by an ENT surgeon, to look at the larynx, who accidentally saw a reflection of his mouth as a singing teacher. He is a singing teacher, Manuel Garcia. So, but I would start with Dr. Aniruddha Bose, that we know that with modern gadgets we are drifting away from indirect laryngoscopy, because in every case we want to do laryngoscopy. But where is the role? I am sure there is still a role, at least for postgraduate learning, definitely yes, but where do you see where indirect laryngoscopy still holds good as a basic examination? Maikta? Yeah.
Hello, I'm sorry. It's a part of the routine clinical examination of any ENT patient coming with a voice problem or a throat problem. We routinely do it in OPD. Sometimes if it is not visible, then we put a local anesthetic spray.
But when it is visible, I will go to Dr. Khogeshwar. When it is not well visible, when it is well visible with indirect laryngoscopy, which is the case in about 50 to 60% cases, what information even today is useful in indirect laryngoscopy before proceeding to fiber optic?
One thing is you can do it very quickly in sitting where with examination site. You can OPD straight away. You can.
No, I know that. But what 1, 2, 3, 4? What information do you get from indirect laryngoscopy if it's a well cooperative patient?
So definitely laryngeal inlet structure. We can see any problem in the vallecula, laryngeal inlet, and vocal cord, and you can see it and diagnose many diseases, many benign disease as well as carcinoma disease.
So what I understand, and the message that should go to the audience is that, and especially the juniors who are present, that it still gives you a good impression of what's going on in the larynx if you can visualize the larynx. I personally think movement, vocal fold palsies can be well diagnosed by indirect laryngoscopy, and mass and other things. Smaller lesions, obviously, we need fiber optic laryngoscopy. For paucity of time today, I would not go with all questions to all the panelists. If somebody wants to add anything, please do.
No,
we'll go to the next.
Also, we can see the surrounding structures.
Yeah, that's what they said. The laryngeal inlet.
Apart from that, you can see the piriform fossa, posterior region, lateral pharyngeal wall, everything actually.
So we should not do away with indirect laryngoscopy. Very strong message, in spite of the latest gadget we have in the audience. के धोले आज क्या time होगा ना, but one I will allow.
Direct laryngoscopy also. If I cannot see the vocal cord during the indirect laryngoscopy, difficulty in the seeing, then during the direct laryngoscopy, it is also difficult.
I agree, very pertinent point. A patient who, cooperative patient, but you cannot visualize the larynx, that's going to be a difficult patient for microlaryngoscopic surgery and direct laryngoscopy when you do under GS. So it's a predictor of. We come to the endolaryngeal examination. So you see, sky is the limit. If we look at the list, fiber optic laryngoscopy, which can be rigid or flexible, video stroboscopy, high speed camera, OCT, narrowband imaging, and finally, last but not the least, is functional MRI. You can actually ask a patient to sing and do an MRI to see what is the vibration of the larynx and what is the, how does the larynx behave during the phonation, and act of swallowing, act of breathing, all breathing, airway and phonation. Everything you can evaluate on functional MRI. But the point is, I think at least in this part of the country, fiber optic laryngoscopy is still the gold standard for evaluation, for modern evaluation of laryngeal disorder. I would go to Dr. Samrat Bandyopadhyay, Dr. Sudeep. What about, what is your preference for doing a patient for laryngoscopy, rigid versus flexible? Which cases do you think you would need a flexible, which cases rigid, and the advantage and disadvantage? If you can just enumerate, and then we'll go to the next one, please.
Definitely flexible laryngoscopy is more preferable because we can see that it's more physiologically, because whenever we pull the tongue, physiology alters. But for the practical purpose, flexible is not available everywhere and is costly, and that's why in most of the cases, in many cases we shift to the rigid in general, and in special cases we will go for flexible for better visualization, in-depth visualization, where the rigid cannot be seen, when the vocal cord cannot be seen, the rigid in some cases, when Dr. Khawas says that in the IL or in the rigid we cannot see the vocal cord, particularly in case of the post-radiotherapy cases where there is fibrosis, lot of fibrosis there, it is very difficult to see the vocal cord and the larynx with the rigid. In that case, the flexible is advantageous.
Thank you.
Even the subglottis we can see in the subglottis, and the part of the larynx we can see with the flexible, which cannot see in the rigid.
Thank you. Dr. Samrat, we know that there are many things we can see with rigid. Which are the cases where you would prefer to have a flexible straight away, without attempting even rigid?
When you are suspecting some neurological lesions, in that case it is better to go for flexible, and when you are suspecting some lumps, bumps or any other lesions, then it is better to go for rigid, but sometimes we need to evaluate with both, we need to use both the scopes.
Dr. Rai, anything to add?
No, patients with some oral pathology like submucosal fibrosis, trismus or some
flexible,
other causes.
that's a very valid point. And young patients who will not cooperate for
pediatric patients.
That's what I said, yeah. I'll go to Dr. Soumitra Ghosh. If I was a beginner and I ask you for an opinion that I'm going to start a voice practice, which scope would you ask me to buy to start with? And when, I mean, obviously both should be there, but if I want to start my practice after my MS.
For a very, from a very practical point of view, number one is a rigid laryngoscope. The standard rigid laryngoscopes.
Louder.
The standard rigid laryngoscopes that we get in the market are 8 mm or 6 mm from stores, but I would still suggest to go for a 4 mm nasal endoscope, reverse it and use it in your clinic as a laryngoscope. You reduce the gag, gives a fair amount of good picture. If you want to go for a second scope, it's a 6 mm scope, and if you can add on, a flexible will be pretty good, because for all our professional voice users, we have to go for a rigid and a flexible. Routine cases, we can do away with a rigid scope. I personally use in my routine clinic, even after this COVID era, I have shifted from indirect laryngoscopy with a mirror to rigid laryngoscopy in all my laryngeal cases. I use a 4 mm nasal endoscope upside down, which is pretty good, and most of us have it in our OT. So I would suggest.
So that's a very valid point, that if you have to start your practice and when the 8 mm scope which we normally use are not very useful for younger patients and uncooperative patients. And so even a nasal endoscope where you just have to turn the.
Just to add on, it reduces the gag significantly, and most of our patients we can do away without a spray.
Yeah.
With a 4 mm scope.
70 degree 4 mm can be an additional
but you have
tool.
To reverse it and hold it in the reverse way.
The only thing is the chance of injury of the scope is more in case of 4 mm because
it's just a matter of practice.
I mean, you have to be careful about that, but
And even the pediatric cases, you can go away with the 4 mm
Sure.
scope, more than 8 years
So
of age.
just to summarize this slide, that the scope can be of various diameters, it can be of various angulations like 70 or 90. We have discussed the advantages. The limitation of flexible scope, there is not much limitation of flexible scope except for the image quality. Obviously, if you want to represent an image, give a printout, the rigid scope gives a fantastic image. Unless you have a chip-on-tip camera, where the camera is located at the tip of the flexible scope, you can still get a fantastic. And what I say is that rigid is an anatomical examination and flexible is a physiological, because you can ask the patient to swallow, you can check for aspiration, you can ask the patient to sing, you can ask the patient to go high and low, whatever problems the patient is having in their physiology, you can check everything in the physiological position of the larynx. We'll now touch upon a few scenarios. Quickly, I will go to Dr. Bose again. This is a case. I will tell you the history. A 60-year-old gentleman who is actually a singer presents with a low-grade fluctuating dysphonia for some time, and then suddenly presents to you with a acute hoarseness. And obviously, it does not tell us, it does not need explanation to say that there is acute hemorrhage in the left vocal fold. What is your opinion on this patient who is a singer? How would you tackle this patient now?
Yeah. So I guess this is a flexiscope or a strobe. This is a flexible video, no?
Yeah.
Okay, then we will go for a stroboscopy next and see the vocal fold movements. And in most of the cases, in my opinion, this hemorrhage resolves spontaneously with proper voice rest and speech therapy and anti-reflux therapy, and maybe steroids if it is not otherwise contraindicated.
So, is anyone going to comment on any other additional pathology other than the vocal hemorrhage, which may need some attention?
Maybe it's a right vocal cord cyst with a tail maybe there, and on the contralateral cord there is a reactionary hemorrhage maybe there actually because of the repeated trauma.
So, being a singer,
yeah.
What will you do?
Now, first you have to go for the stroboscopic examination. Then this is the consequences of some other problems, that is vocal overuse, voice abuse, maybe smoking, alcohol. So, we have to address those issues first. Then we have to send the patient for one-time speech therapy. Then we will go for, if it is a cyst, we have to go for MLS.
Okay, so how long would you, Dr. Sudeep, how long would you wait for this patient before you think of doing anything if stroboscopy confirms that this is a cyst? Will you operate during the acute phase of hemorrhage?
If it is cyst, after resolving the hematoma and preoperative speech
So
therapy.
that's a very strong message for the audience that we must not touch our knife on this patient before the hemorrhage has settled. And I personally think, I think the panel would agree that the stroboscopy, as has been mentioned, should be done once the hemorrhage has been settled, so that we know what is going on in that other cause, which has other vocal fold, which has led to the hemorrhage.
And speech therapist must be consulted before the operation.
Okay. So that's the point. And what about any medicines, Samrat? A singer patient, he needs to earn his bread and butter.
So we can start.
You cannot stop him
we can
for
think
6
of
weeks.
steroids.
Steroids.
Yes, and there is features of reflux.
Excellent. I think there is a huge interadenate pachydermia in this patient, which is a classical feature of laryngopharyngeal reflux that needs to be treated. We'll just touch on this, Dr. Raut. What anti-reflux medication do you prefer for this patient?
We prefer,
because it's a short panel, we'll just touch everything.
So we prefer
and get the opinion.
Esomeprazole preferable we use, pantoprazole or esomeprazole.
Whatever product molecule you give, do you give once a day, twice a day?
Twice a day.
Okay.
We usually give one pantoprazole or another anitine, the other group, HR blocker.
Anybody else? We want to comment?
Lifestyle modification is very much important. Avoid spicy food, avoid excess tea and coffee, tobaccos, and the gap between the dinner and the going to bed. and before going to bed, any neutralizing, that means liquid antacid or so, which neutralizes the rest of the acid before going to the bed. It's very important, even more than the
Any
PPI.
panelist would like to add any other molecule in addition to PPI? Anybody? Yeah.
Just a couple of things against this video. If you see the hemorrhage on the left hand side, the hemorrhage has got few areas which is yellowish. So this hemorrhage is a couple of weeks old and it has started resolution. It will take around 6 weeks time for resolution. If the patient comes to me at this point, I will advise oral steroids, Visolone for 7 days, full dose PPI, avoid phonotrauma, professional voice user. If a show is not in the pipeline, then I would ask her not to sing. I would ask my therapist to give a good amount of voice therapy. I would reassess the patient at least after 3 to 4 weeks from this stage. Go for a strobe 3 to 4 weeks down the line. By that time, I am expecting this hemorrhage to go down. So twice daily PPI, 300 milligram ranitidine at bedtime for 6 weeks, Visolone for 7 days, chimeral fort you can add, probably it gives us some help. So after 1 month of this therapy, we will do a strobe and then we plan, probably he will require some surgery maybe after 6 weeks when these hyperphonatory things come down.
So I think all the panelists agree on the point that we first need to assess the hemorrhage, whether it is acute or chronic. If it's acute, absolute voice rest, steroid will help to give rise to resolution, and then we need to reassess with a stroboscopy to see what is the condition on the right vocal fold, and also what is the condition on the left vocal fold, and probably anti-reflux medication, lifestyle modification, and finally some surgical intervention. But we have to be again careful putting a knife on a singer's vocal fold. 3 times or 10 times you should sink before you do the surgery. If it's really essential, you have to do it. I will go to a very quick common condition. We are not going to discuss the diagnosis. I will just play this video. This is a vocal fold nodule. Very small vocal fold nodule, but significant phonatory gap, and you have the history of the patient here. I would now start with Dr. Vidhan Roy and go in the other direction. Oh, sorry, I'll show you another video. So this is one case scenario where this patient has got fluctuating 2-3 years of teacher who's got this problem, and medical treatment has failed, and we can clearly see that this is a vocal fold nodule, bilateral nodule, and there is a significant phonatory gap and the patient is hoarse. The second scenario, another lady who has had this problem for a long time. This is actually not stroboscopy, it is a stroboscopy, and we can probably see that this is more advanced and more pronounced nodule, and now the voice is persistently hoarse for last 6 months, which is not even resolving with voice rest and primary measures. So Dr. Roy, depending on, between the 2 cases, what will your management vary? How will you proceed? And we'll take opinion from all of you.
Regarding the first case, voice therapy is the mainstay of treatment.
Perfect.
And other measures.
I agree. Yeah.
And regarding the second case, it is little bit a matured nodule, and everything I think has been tried. So we can opt for, if it is possible, intralesional steroid injection. If it fails, then lastly we can consider microlaryngeal surgery for the lesion.
Do all the panelists agree on this?
Yes,
Anybody with a difference of opinion?
In
Anybody
second
like to
scenario,
add?
mucosal OAB is not there. That means already is a hard nodule which hampered the mucosal OABs. So no question of waiting.
So again, the message is that if it's a soft nodule, early nodule which resolves and fluctuates with voice rest and thing, that is a patient who should not be taken up for surgery, because theoretically we know 85% of the nodules will resolve with therapy, 15% will eventually need surgery. And who are the patients? One of the patient scenario is this: very robust nodules, not responding to medical treatment or therapy, and very fibrotic and advanced and mature nodules, because there is more fibrous element, and therefore therapy will not resolve this, and probably we need to surgery. do surgery in this patient. We are not going to go because time is biting, so we'll go to the next scenario. 50-year-old gentleman. I'm sorry, ladies and gentlemen, because of shortage of time, we are just going through case scenarios, and hopefully that will give us an insight about those things. So again, a fish trader who came, an important thing is he is the only earning member in the family, hoarseness for 2 to 3 months, and he has tried medication here and there, and it has not failed, it has failed, and we see this kind of a picture. I would now go to Dr. Samrat. With this background history, what will be your...
Considering his profession, it is better to straight away go to the surgery and give him a serviceable voice.
Okay. Any other points? Anybody wants
Little
to...
bit inflammation is there. It looks like a cyst with a superheated inflammation. Just wait for 3 weeks for reduce the inflammation and go for operation.
So will you try some medical treatment? I fully agree that there is some amount of inflammation as well, but only point is that he is the only earning member in the family. These are the decisions we have to take in our practical day-to-day life. You cannot ask this patient to take voice rest for 4 weeks and come back for surgery, and then post-surgery another 2 weeks of voice rest. His family will die and starve. So, what about the opinion of others, like Dr. Gautam?
Long time, including therapy, and at least maybe 4 or 6 weeks before time, because there is implementation.
Yeah, I agree, Dr. Raut.
I saw that there is still keratosis patch over it.
Yeah.
So and if he is a smoker or something, so suggestion of smoking. There is maybe contact ulcer or something.
Yes, this one,
yes.
here, the whitish patch.
Yes, whitish
so
patch.
that is a very valid point, that there is a little whitish patch on that polypoid swelling, and that needs to be followed up.
Yes.
Because this can be a leukoplakia on top of a polyp also, or a leukoplakia which, because of repeated phonotrauma, has resulted in a polyp. So we do not know which came first, and that's why we need to keep an eye on this patient.
Yes.
I fully agree with all the panelists, but just we have to think, we cannot ask this patient, because he will have to earn his living, he will have to shout, he will have to sell his fish in the fish market. So that is the challenge, how you do, and at the end of the day, I think it's customized, because one person said he will straight away go for surgery and give adequate voice rest of the patient, make the vocal fold heal, and let him go back to work in 15 days time or so. The other panelists feel that you should optimize it. So there is no hard and fast rule about this patient. The point to highlight is that decision making and consenting and counseling discussion with the patient, how we go about the whole problem. So we will again go about 2 situations. Vocal fold polyp, again, like the pictures I have shown you, these are very straightforward. We can take a pair of scissors and just cut it, like we have done for ages. But when we have situations like this, we have a huge polyp on one side, and hopefully we can play this. Yeah. I would now ask Dr. Soumitra Ghosh, who has been silent for some time.
Shall we go to the first
yeah,
slide?
if you can describe the finding that you think in this patient, according to you.
This patient has got a huge polyp on the mid-third of the left focal fold, and a contralateral contact lesion, which seems to be a bit of a sclerotic, a bit hard, and the mucosal wave is present on the right side, and this is absent or restricted on the left side. So for this patient, he will require a surgery. Definitely we have to take out the big polyp, and on the right side, the sclerotic thing, seeing this picture, it seems, yes, we have to take it out there also. But again, the final decision is taken until I palpate the lesion on the right side with a palpator or a instrument on the table. Because whatever picture with whatever best cameras you see, The final decision whether to touch it, the small lesions, is best taken when the patient is in the general anesthesia and when you palpate it with the instrument. So for this patient, we have to remove the polyp on the left side. Probably the right hand side lesion also needs to be taken out.
Okay, so we go back to that. I think he has clearly stated what is the plan.
And
I will ask one question to all the panelists, starting from Bidhan Roy to the end, that would you touch on the opposite vocal fold at the same time, or would you like that to be resolved? Just one answer. I know you will definitely take out this big polyp, whether the other side you will touch or not.
I will not touch the right cord.
Perfect.
No.
No.
If it is not very much close to the anterior commissure, it is then it is not a very big problem because it will not come in contact.
Dr. Raut?
Said little bit conservatively you can touch. Not
Conservative surgery.
Conservative,
Okay.
more common.
Like a flap, micro
Yes,
flap
yes,
or
yes,
something.
yes.
Dr. Bose?
Yeah, after giving adequate conservative treatment, including speech therapy and anti-reflux medication for about 4 to 6 weeks, if the contact lesion doesn't subside, then
So
we
he'll
can
do a
attempt-
second sitting surgery.
Second sitting.
So I think the opinions will vary here from person to person. There is no hard and fast rule, but what Soumitra said, I partially agree with him or entirely agree with him in the sense that you can actually palpate with a probe and see if it's a very robust kind of a polyp which is, or contralateral polyp which is formed, then probably doing the surgery in today's modern laryngological practice is not a bad idea. But at the same time, you need to see how you do it. I would just highlight one point here. Another patient, like same situation, polyp on the right vocal fold with a contact lesion on the left vocal fold. I personally, I think Dr. Bose, Dr. Somrat, Dr. Soumitra, they also use laser, and many of you, Dr. Raut also, all of you probably use laser. So I would, if I am doing a surgery with a cold steel instrument, I would not, probably touch the other vocal fold. If I have laser in my armamentarium, then I would probably do the same thing, because as Dr. Raut said, very conservative surgery, because you are trying to restart the healthy phonation. So if one nodular swelling remains at the striking zone, the patient will not have the optimum phonation, and therefore the patient is likely to have another lesion somewhere because of the suboptimal phonation. So if you can give good vocal fold like this, this is another patient whom we operated, and we could, with laser you can give this kind of precision. And with that, probably it's my opinion. Do you agree that if you have laser, conservatively you can do the other side also, but with a scissor it is very tricky to do that small lesion, and probably I agree with doing conservative. Small question on cyst. Again, there are two kinds of cysts that we commonly find in our practice. The first one is very obvious. It's a mucus retention cyst arising from the mucus gland of the vocal fold surface. And the second one here is an intracaudal cyst, also known as epidermoid cyst. Now, obviously, the management will vary. In terms of technique, I think everyone would agree that they both need surgical treatment. Anybody for conservative treatment for these patients? No. So we agree that they will need surgery, but I want to ask what kind of surgery? Shall we go to Dr. Sudeep now? Like for the first and second, would your surgical technique vary? Because first one is on the surface, it contains mucus, it's a mucus retention cyst, and the second one is very deep, lying in the multilayered structure of the vocal fold. It's a subepithelial epidermoid cyst. So would your surgical technique vary?
In both the cases, we have to do the micro flap, but in the second case, which is now in the screen, dissection should be more meticulous, otherwise chance of injury of the vocal muscle is there. When it is on the surface and with the redundant mucosa, so it is some amount of mucosa we have to also remove to make it smooth. So it is more easy.
Perfect. Dr. Raut?
I agree with sir. So
Cold steel, laser, because you use laser, I know, in your institute.
So I use cold steel.
Cold steel. Dr. Bose, he also has laser in
Yeah,
his
laser,
hospital.
but we don't have an AccuBlade. So without AccuBlade, this mini microflap without AccuBlade is impossible. But the other one we can still do with the microspot laser. But I would prefer cold steel. And microflap won't be possible in this retention cyst, I think.
Okay.
Difficult. You have to sacrifice some this epithelium and SLP also a little bit.
Dr. Roy?
Yes, microflap for this epidermolysis is very is okay, but producing or creating a microflap for this mucus retention cyst is little bit difficult with cold instruments.
As Dr. Sudeep pointed out, there is bound to be some redundant mucosa. So that has to be handled also. So it is not easy. So Dr. Soumitra, any comment?
Mini microflap for both of the patients. Regarding the instrumentation, I would always prefer a laser. If the patient cannot afford, then very good cold steel instruments should be required for dissection. For the mucosal variety, there is a high chance of the cyst bursting, and what I have seen in my experience, is the inferior part.
Hey, volume बढ़ाओ. Hey, volume बढ़ाओ ना.
भैया अच्छा ना?
Hello.
नहीं volume का तो बढ़ाओ.
Hello. Okay. Okay, I am repeating once more. Mini microflap for both the cases. Considering the instrumentation, very good cold steel instruments will be okay, but I would still prefer a laser if the patient can afford. For the mucosal variety, there's a high chance it will burst, and the commonest area of bursting is the inferior surface. When you are finishing off your dissection, when you are just dissecting it from the lamina propria, and it keeps away, because the mucosa in the inferior lip area is much more thinner than the superior surface. And again, there is always a chance of bursting of the cysts, so you have to be extremely careful.
So, any other comments?
I would prefer a laser in both the cases.
So, I think what we again have to, it takes us back to preservation of mucosa, preservation of the multilayered structure of the vocal fold for effective phonation. And therefore, whatever works best in my hand, I would probably like to do. The first one, I agree with other people that even if you use just a scissor dissection, it's always nice to make a small incision here, somewhere here, and at least elevate a plane of the cyst, and then you can resect it with a scissor, because as Dr. Sudeep said, there is bound to be a lot of redundant mucosa even if you do a subepithelial dissection of the cyst. And in the second type, epidermoid variety, you know, we have to do a microflap because you cannot cut that. If you cut it with a pair of scissors, it will be a big crater in the vocal fold and the patient is going to be much worse. So, we have to do a microflap, but at the end of the day, whether you use laser or cold steel, it depends on what. Laser is nothing but a tool, it is not a technique. Lot of people come and ask us, will you do laser surgery? Then you have to tell the patient that laser is nothing but another knife. So, laser is nothing miracle, but yes, laser has its edges. We have shown you in that small contralateral region how beautifully we could do with the laser, which will not be very easy with a handshaking and everything happening. So, and this is for the benefit of the postgraduates, if there are any here, just to show you what is a classical flap like the epidermoid cyst. As you can see here, this is another patient of epidermoid cyst where we excise the epidermoid cyst and we can reposit the flap. So, this is at the end of the surgery. It does not allow us to show all the surgical technique, but this is the basic principle of a microflap, and this holds very well with this epidermoid cyst, as you can see here. coming to the next scenario, which is white lesion. Again, a very challenging situation for laryngologist. The first patient, a middle-aged patient, smoker, and you can see grossly hoarse. Because of paucity of time, I am not asking the panelists to diagnose. I am telling the diagnosis so that we can discuss the treatment. Because I can see here that the patient has got a right vocal fold white lesion. There is a small polypoid lesion which may be a contralateral lesion because of the striking with the right vocal fold. And also, as the patient speaks, there is a lot of hyperfunction. As you can see, patient is trying to phonate with the ventricular band. The ventricular bands are coming opposing during the course of phonation. So this is one case. Another patient, also smoker. This is the stroboscopy. No hyperfunction. You can see the ventricle also almost, but there is no mucosal wave in the right vocal fold, and there is a white lesion. Now, I would again start with Dr. Bose from that side, have opinion of all the panelists. How do you go about each patient? Is that different? Because there are two types of lesion here, and there is a multiple lesion on this side. Dr. Bose, please.
Yes, in the first patient, I think we'll go for, after prior conservative treatment, including speech therapy and all, then take up the patient for surgery and excise the white lesion on the right vocal cord and for histopathology, and the left lesion also I think I will treat if it doesn't go away with the initial conservative management of 4 weeks or like that.
Perfect, thank you. Dr. Graut, I would like to have opinion on each panelist on these patients.
I agree with Dr. Bose. I will
Same.
do same thing. I would wait for some time to see the other side is resolving or not. Definitely right side.
Sorry,
requires
can you
surgery.
repeat on this one here? What will you do? Excise the whole lesion.
Yes.
Okay, send for biopsy.
Yes.
And this one, also excise the white lesion or also do something about this polyp? You will wait.
We
as
will
you
wait
said.
before surgery. We will give 2 weeks, 3 weeks time, and we wait. We will see. If it is not resolving, we will take out both.
Okay.
Both sides.
Dr. Sudip.
In the right, if the mucosal wave is little bit preserved, present in the scenario, then we can go on conservative with the maintaining the vocal hygiene and lifestyle modification, vitamin A.
You mean this patient here? Okay.
In that case, most of the cases improvement is noticed.
But will you not be worried about that white lesion being suspicious?
No, I'm telling about that one.
Oh, you're talking about the polypoid lesion.
So
Samrat?
Regarding the other one,
yeah, number 1 is this, number 2 is this. So
regarding the
1 and 2.
Number 2, I would like to see whether there is any involvement of the muscles or not. I can advise one CT scan.
Absolutely, yeah.
And preferably one biopsy before considering the final treatment.
So I got your point. We'll summarize at the end. Dr. Roy, Vidhan Roy.
Number 1 is a purely epithelial lesion, I think.
Yeah.
So the chances of preserving mucosa with conservative measures is very less. So we can go for excision of the keratotic patch and wait for the
this one.
Yeah. Wait for the other lesion to heal up with conservative
And
measures.
obviously wait for the histopathology. Yeah. And this one?
For the second one is again there is some epithelial lesions. Maybe there may be some submucosal inflammation or something else. We have to, after thorough radiological investigations, we have to palpate the lesion under general anesthesia and under microscope.
Radiology means CT.
CT.
Yeah.
Then on palpation, if we can find something else underneath this appearance, then we have to decide accordingly to go for the extension of the surgery, how much we should exercise or not.
Okay. Thank you. Dr. Ghosh, is there any role of voice therapy in any of these patients before doing any surgery?
I'll just try to add on one or 2 points. In the number 1 scenario, there are 2 lesions. One is a vascular polyp on the left hand side and a white lesion. I would like to try with some antifungals for around 3 weeks with a full dose PPI and some amount of voice therapy, because you can see that hyperfunctional false vocal folds which are there to compensate the phonatory gap. So voice therapy, antifungals for 3 weeks and full dose PPI. Reassess the patient after 3 weeks to see whether that white lesion is still there or has reduced. Eventually this patient will require some surgery to get rid of that polyp, and if after 3 weeks of conservative management the polyp is still, it may reduce or may not reduce, and if the white lesion goes off, then we know it's a fungal and we may not have to touch that. This is for number 1. In the number 2 scenario, if it's a stroboscopic picture where we can see there is absolute loss of mucosal waves on the right side, which indicates that this lesion has penetrated into the SLP. I would advise a CT scan to see whether there is any paratracheal extension. If not, I would like to, ideally, I would like to take this patient up for a laser. I would like to do a laser chordectomy, send that sample for frozen section. If the margins are clear, done. If the margins are not clear, I will go to, maybe I would finish off at first with a type 2 chordectomy, and if the margins are clear, done. If not, I will go down again with a 2 millimeter margin to finish off.
Okay, so that, thank you. So that brings us to another video which I borrowed from my friend. Another white lesion here. Now this lesion here is slightly different from what we saw in the sense, and this patient also has a background of being on inhaler for a long time, a diabetic patient. And obviously Soumitra has pointed out that we do get these patients where we have fungal laryngitis which can mimic a white lesion or a leukoplakia. So history of the patient is important, I think, and so if you suspect fungal laryngitis, I would ask any of the panelists to volunteer other than Soumitra. What medical treatment will you advise if you suspect the trial of antifungal?
Fluconazole for 2 weeks.
For?
2 weeks.
2 weeks.
Fluconazole.
What dose?
200 milligram OD.
Okay.
We give
Anybody else?
atraconazole. We give atraconazole.
Okay. So at the end of the day, it does not matter what molecule you give, but antifungal trial is a good option, because this is a patient, there is not much of vocal trauma, because this patient, we have to see that other patient we saw was, you saw the larynx is squeezed, there is a contact lesion, so this is a clear-cut case of phonotrauma in the background of reflux, smoking, voice, whatever. So without phonotrauma, white lesion, and there is a good, there is a good amount of relaxed larynx, no tightness, no muscle tension, so you should suspect, and the patient being on inhaler, you should probably suspect, and a trial of antifungal. And I think what most of the panelists did say, if we go back to that we would definitely need to do some histopathology, wait for the histopathology, whether you, if you have a laser facility and frozen section, what Soumitra said is correct, that you can take a frozen section, wait, and do a type 1, type 2, type 3 chordectomy, even if it's invasive squamous cell carcinoma. If you do not have that facility, probably excise based on the CT scan, especially for this patient, because it is likely to be deeper, and then take a call and take the final call on this lesion probably. And in this patient, everyone has highlighted that some amount of conservative therapy should continue in the post-op period. We'll go to the next patient. We have 1 minute 25, but I have asked for 5 minutes extra, and I have been allowed. So we can just run through this one. So this is a patient. This is probably going to be our last case. We will now start from the middle. Shall we start with Somrat? Hoarseness, short onset, sudden onset, 5 to 7 days, young patient. I want to, obviously, let's pronounce the diagnosis. It's a right vocal fold palsy.
Vocal cord paralysis.
Now, what are the things that you would look for in the laryngoscopy which will help in your management, Samrat, and the next person would probably take up how do we do diagnostic workup in this patient. Short onset, sudden hoarseness with right vocal fold palsy.
Yes, we should look for whether there is any in laryngoscopy.
Yeah. You answer that laryngoscopy, we will take opinion from others also.
Okay, we need the contralateral vocal cord, this compensatory movement, whether establishing or not, and amount of phonatory gap, risk of aspiration, whether there is any.
Absolutely.
And laryngoscopy.
5 minutes. Okay, Dr. Sudeep, how would you do any workup on this patient, or you would just straight away try to correct or do something for his vocal fold palsy?
No, we have to look for
short history, sudden onset.
Even in the neoplastic condition, there may be a sudden onset. So any neoplastic, it may be commonly it is viral or idiopathic, but it may be due to neoplastic conditions which may present as sudden. So we have to look after for the neoplastic in the throat, and though least possibility also of the throat. I mean also of the chest, upper chest. Sometimes it may involve the right.
So you will do some imaging also.
Imaging also.
What kind of an imaging?
Imaging means the CT scan.
CT scan. Dr.
And
Raut,
ultrasonic of the neck.
Dr. Raut, what would you ask the radiologist for the CT scan? Just a CT scan of larynx or something?
As it is right-sided pathology, so definitely the pathology must have in the neck, not in the chest. So we will do neck evaluation like ultrasound of thyroid. Even
ultrasound of thyroid?
Thyroid we have to do, and if any suspect, you can do ask for CT. First investigation should be ultrasound of the neck, and if no conclusion made, you can ask any suspect think any node, anything, so you can do CT scan, contrast enhanced CT scan.
Of which area?
Of neck.
Of neck. Anybody else who would like to extend the evaluation? Dr. Bidhan Rai?
In addition to those, we can ask or we can go for the CT scan of the nasopharynx also.
Okay.
Yeah, and apart from that, pan-endoscopic examination of the other parts of the whole ENT region is needed. If everything comes clueless, then we can wait actually.
Okay, we are coming to management. You want to add something?
Yeah, the standardized.
Very quick, we don't have time.
2 millimeter CT scan from base of the skull to the upper mediastinum with contrast.
Yeah, I think that is the gold standard at the moment.
The radiologist.
If you have facility, we need to evaluate the entire trajectory of the nerve, which can be injured at any stage. So once we have diagnosed that there is nothing, no secondary pathology, how will you go for management? Dr. Bose.
Yeah, first conservative management with speech therapy, anti-reflux therapy, and all that for at least I think 9 to 12 months. And if the patient is a professional voice user, singer or a teacher, something like that, then we may go in for, provided the patient consented, for injection laryngoplasty.
Very, very valid point. Anybody else who would agree with him? Or all of you will agree with him? What is the indication of early intervention for this patient?
Aspiration.
One is aspiration, second is what Dr. Bose said.
Speech,
Professional voice users with a vocal demand. A singer.
Along with the speech, one thing I want to mention that along with the speech therapy, even in the, we have to the swallow therapy also. Otherwise, even little bit of aspiration is going on.
There is bound to be some aspiration. So look at aspiration, look at breathing. I mean, breathing will not be a problem in this case. And look at voice. And depending on the vocal demand of the patient, either intervene early with an injection laryngoplasty or wait for this thing to happen. Dr. Roy, how long will you wait before you intervene if it's not a professional voice user or no aspiration?
If there is no emergency indication, we can wait for 6 to 9 months.
6 to 9 months. And we would go for a definitive surgery, which is like going to be?
No, definitive surgery is in the form of adduction of the vocal cord. Maybe injection, maybe some other procedures, we can try for it.
Dr. Ghosh, How long will you wait? And before that, can you answer me? Is there any indication where you would go for medialization thyroplasty early?
Early medialization thyroplasty for these patients? Okay, if it's
Not idiopathic, any patient of vocal fold palsy.
not responding to conservative management for more than 6 months. That is the standard verdict.
No, what I meant to say, if
Early.
post-thyroidectomy,
Yes,
this is not this
post-thyroidectomy,
post-thyroidectomy
yes.
patient where the surgeon has said that
That he has
I
definitely.
have cut the nerve because of disease. So it's
Yes,
very
very
clear
big
notion that should go to the audience that if it is documented that the nerve has been cut, and if you are not planning to do any re-innervation surgery, which is being done in many parts of the world and even in India now, then probably early permanent surgery can be done. So I think we all agree that this patient, we need to look at the signs of aspiration, need to look at the compensation by the other vocal folds, start voice therapy, investigate if there is a cause for the vocal fold palsy. If there is no cause, or if it's not iatrogenic, or if it's not after any surgery, then probably we can wait for some time unless the patient is aspirating, or if there is a high vocal demand, then we can do an injection laryngoplasty to stabilize. Advantage of injection laryngoplasty is that you can stabilize the voice, meanwhile the compensation will be easier, and at the end of the day, the injection may not last for a long. Even if the vocal fold recovers function, gradually it will take over its own function over the injection. So that is the advantage, and in 6 to 9 months time, you do a permanent procedure of medializing the vocal fold. I think with that, we would like to conclude. There is no time to show. So thank you very much, but I think we all should remember that the man behind the machine is important. So it's our thought process and customized treatment to this patient, which will actually help the patients to get the benefit. Thank you all the panelists for being so illustrative and descriptive about your thoughts and very clear point to point. And I'm sorry we could not cover more. I had to rush because in 45 minutes time this is what we could do. Thank you very much.
Okay. Thank you very much, Professor Amitabh Rai Chaudhary. Thank you very much. Now I would request Dr. Rai Chaudhary to hand over the participant certificate and mementos to the panelists. First, I will ask Dr. Rai Chaudhary to hand over the memento and certificate to Dr. Shamrat Bandyopadhyay.
Thank you very much.
May now request Dr. Bidhan Rai to receive the certificate and memento from Dr. Rai Chaudhary.
It's always a privilege to have you as co-panelist, and thank you. Thank you. Mask.
Now may I request Dr. Rai Chaudhary to hand over the memento to Dr. Soumitra Ghosh, please.
It's a pleasure.
And now I would request Dr. Aniruddha Bose to come and receive the memento and certificate from Dr. Rai Chaudhary.
Thank you very much.
Now may I request Dr. Sudeep Kumar Das to receive the memento and certificate from Dr. Rai Chaudhary.
To the great bronchoscopy and airway surgeon, thank you. Dr. Raut.
May I request Dr. Khageshwar Rao to receive the memento and certificate from Dr. Amitabh Rai Chaudhary.
It is indeed a privilege to have him on the panel today, extempore, and we would all come with a big team to ISOCON, I promise.
Thank you.
From on behalf of AOI West Bengal. Thank you very much.
Now, please do come with all the friends and family. So definitely we expect we'll do have more hospitality and cherish and good time. Definitely, I promise.
Thank you.
Thank you.
Now finally may I request Dr. Bidhan Rai to hand over the memento and certificate to our moderator of this session, Professor Amitabh Rai Chaudhary.
Thank you. Thanks.
Our next session is on otology. The topic is tympanomastoid surgery, a critical review. Moderator of this session is Professor Dr. Utpal Jana. I request Professor Utpal Jana to come to the dais, please. The panelists in this session are Dr. Ashok Kumar Saha, Dr. Kollan Pal, Dr. Debanshu Ghosh, Dr. Debobroto Bishwas, Dr. Jayanto Saha, Dr. Shaumo Ghotok, and Dr. Atish Haldar. All are requested to come to the dais, please. The time for this panel discussion is, we have 45 minutes.
Signal আসেনি?
কেন হচ্ছে বন্ধুরা বারবার?
এই সবাই চলে যাচ্ছে। So, good afternoon to everybody. First, I like to thanks AOICON West Bengal for inviting me to moderate this session on otology. The panelists are Dr. Ashok Kumar Shah. Please. Ashok Shah is here. Dr. Kollan Pal, Dr. Devanshu Ghosh, Dr. Debobroto Bishwas, Dr. Jayanto Saha, Dr. Shaumo Ghotok, and Dr. Atish Haldar. So all are very experienced otologic surgeons, and they doesn't require any introductions. Especially Dr. Ashok Shah, he has written a book on otology also. He is now in the Kishanganj Medical College after retiring from Medical College. Dr. Kollan Kumar Pal, I think he's doing practice in not 24 hours. Dr. Atish Haldar, he was previously in Malda, where I am now. Now he is in Purulia. Dr. Jayanto Saha, he was also previously in Malda, now in Arjikar. Debobroto Bishwas, in Arjikar. Dr. Devansh.
Previously Malda. Previously also Malda.
Oh, yes. And Dr. Devanshu Ghosh, he is now in AIMS Kollani.
Previously Purulia.
And Dr. Shaumo Ghotok, he is now in Kuchbihar. So, just in the beginning, still the tympanomastoid surgery is the most common surgery we do perform. And there are some now other surgeries also has come into our field. But tympanoplasty and mastoid surgery, this is I think the most common surgery which we do almost every day or day or the other day. And so success is very important for this surgery. So first, I like to ask some things regarding the assessment of disease. So there are so many things like audiometry, X-ray, autoendoscopy, microscopy, but HRCT is nowadays is usually done especially in cases of squamosal type of disease. But now my question is, do you ask these investigations in all cases of squamosal disease, Dr. Saha?
Hello. If a facility is available, we do it. It will help for knowing the erosion or erosion of the facial canal. But always we should not advise, especially in case of children, who is very early childhood. Again, in case of pregnant mother, there is may have some chances of hazards. Other than this, sometimes we have seen that in a case of dehiscence, we have taken our HRCT, but in HRCT...
So you are doing in all cases of squamosal type of CSM, you will ask for a CT scan, HRCT, temporal bone. All cases?
Not all
Almost
cases.
all cases?
Not all cases.
Then which cases?
Only with complications, as well as adult patient, and patient have the history of complication and others. But in case of early childhood, if there is no complication, I am not doing this. In case of female, I cannot advise because radiation hazard is much more in HRCT. Again, everything I'm thinking that when I'll do operation, I'm thinking there may have some dehiscence. I'm exploring, for which it is not so important in every cases. But if it helps, it has some additional helping investigation.
So what are the opinion of other panelists regarding CT scan? Do you advise in every cases?
HRCT
or in selected cases?
HRCT in squamosal disease is very important regarding 3 points. First, we can know about the complications of the squamosal disease.
We know all the importance, but
And
I just like to ask you,
next
in
is-
which cases you will do?
If there is a congenital malformation, as sir said, we will not do it in pediatric population, but in a small child there may be some congenital malformation, so we must do it. And also when we operate in the only hearing ear, we must do. And also in cases of the second surgery, then in previous surgery if there was any pitfalls, for knowing the anatomical landmarks, for knowing the extent of cholesteatoma, and for localizing, and as sir has said, if there is any dehiscence of the facial canal or if there is a fistula in the lateral semicircular, all these
yes.
can be known by
So any
HRCT.
other opinion, you are performing all cases, CT scan, you are advising in all cases?
No, sir, only with complication we go for HRCT.
So I just actually in all cases or in selected cases?
Whenever the clinical history and examination suggests that there may be some impending complication arising out from that squamosal CSM, or the frank complication is there, either labyrinthine fistula, as sir has mentioned, or facial nerve paralysis. So in that cases, and also obviously, also sir told in revision surgery, we are embarking on a revision case. In that case, I do in CT scan routinely, not on all the other cases.
Not on all the cases. Jayanto?
But I like to get preoperative CT scan each and every cases, if possible.
Yes.
Actually, it eases my perioperative decision making because I can get what is the condition of the bony outlines. Variably, on many a times, the middle fossa dural bony structure is not a single line. Occasionally, there is an undulation. That is many times a problem perioperatively. So the preoperative
So you are
assessment,
advising, you like to do this
if
test
there
in
is no contraindication,
in all
it is
cases.
better for me.
Sogmo Ghatak?
I would prefer doing it in all cases, sir.
Yes. So most of the panelists are of the opinion that CT scan can be asked in almost all the cases, except in few cases. We do investigations for many reasons, not only for diagnostic purpose, but there are also other reasons, along with otoendoscopy and otomicroscopy. Do you perform it routinely before doing mastoid surgery or timpanoplasty surgery? Somo? No.
Sir, I don't do otoendoscopy at all.
You don't do it routinely. Anyone is in favor of doing routine otomicroscopy and otoendoscopy?
Microscopy I might do, sir, but if it is specifically about otoendoscopy, I don't do otoendoscopy.
Yes.
But sometimes I do examine under the microscope to decide some few points.
Dr. Devanshu Ghosh, do you perform otomicroscopy or otoendoscopy in routinely in all cases before doing surgery?
Yeah, because we have facility of otoendoscopy in our OPD setup. We have the trolleys and all. So we do all the cases otoendoscopy using 2.7 mm.
Dr. Devaruto? Routinely.
Routinely in all cases.
Yes. What is the importance of doing auto-endoscopy or auto-microscopy? Most of the families they are doing it because I can take from auto-endoscopy or auto-microscopy occasionally. Okay. So Dr. Otish.
Go for auto-microscopy in every case, but I don't go auto-endoscopy.
Yes, Dr. Kollar.
Automicroscopy we should do in all cases, but I think auto-endoscopy should particularly be done in revision cases, because in revision cases there may be some hidden areas, especially in the sinus tympani and sinus subtympanicus, and especially in the retrotympanum and the hypotympanum. So in that cases only auto-endoscopy can give a view, not automicroscopy.
Yes, Dr. Saha.
Auto-endoscopy you can do only to get bright illumination, good magnification. For if it is available, you can do.
Yes. So actually, there are many pathologies that may be overlooked in case of clinical examinations. So auto-microscopy or auto-endoscopy is must before doing any tympanomastoid surgery. That gives much more information regarding any other pathology like hidden cholesteatoma or any hidden polyp or any other things. Yes? Yes, definitely. Auto-microscopy or auto-endoscopy with suction, definitely. Okay. So thank you. Next, the pre-operative situations. Though these situations usually should not be occurred in our day-to-day practice, but again, we have advised some surgery, and after 7 days when we planning the surgery or going to the OT, we have seen that there is some fungal infections or there is some active discharge. So in this situation, what to do? Whether you postpone the surgery or you continue the surgery. Dr. Saha?
Usually
This is a very common situation, though this should not be occurred, but again, in hospitals base or also in private practice, sometimes we see that when we are doing the operations or during the day of operations, we have seen that there is some fungus infections and active discharge.
Usually what we are doing, if patient have any discharge, every 7 days before operation I will look at that patient. If there is discharging air and there is any fungal infection, then we should put some antifungal and steroid drop. That is
during operation you have fine with it.
Then I have to think, thorough irrigation with normal saline. After that, I will do as a mucosal disease or squamosal disease, I will do operation.
Dr. Paul?
Operation, no problem.
You will do the surgery or you will postpone it or give some antibiotic after doing.
If there is a active discharge, I should go for a suction clearance and give topical antifungal antibiotics and wait for the active discharge to be reduced.
Yes, Dr. Otish, what is your
Postpone
opinion?
the surgery if there is any fungal disease, but in every squamous case there may be some amount of discharge, I have to go for surgery in every cases. But if there is fungus, obvious fungus, then I go postpone the case.
Dr. Joyendra Saha?
If the discharge is a mucopus or fungal debris, then there is a big no from me due to chance of graft rejection or failure. But if it is a mucoid discharge, although there is no contraindication, there is also no contraindication, then I better to postpone for it because of perioperative bleeding chance.
In hospital-based cases, usually postpone, but it is very difficult to postpone in some private cases. We have advised 7 days before that there is you do tympanoplasty, and on the day of operation, when the patient admitted, and if you postpone, there is some problems. Dr. Vishwas?
First of all, we need to see what the discharge means. If the discharge means it's an active infection, we need to postpone the surgery. No questions about it. Now, if the discharge in case of mucosal diseases might be there due to inflammation also, might not be there might not be any infection per se. Those cases you need to take the call on table. Like an inflammation might lead to a messier field, more bleeding. So that depends upon the surgeon at that point of time.
Okay.
So an active discharge means what
No, you
that
will not perform surgery.
No.
Yes. Dr. Ramangsu Ghosh?
If you see, sir, if you are doing just repair of the perforation, that means only tympanoplasty and myringoplasty in such a situation suddenly diagnosed on table, it is better to postpone the surgery. And if you have to access the mastoid along with the graft, repair of the graft, in that case, if we suddenly found this sort of fungal infection, we can go ahead, suppose using Jensen violet or washing with properly with betadine in that case, then in that case we can go for the surgery.
Achha. Dr. Somo Khadok, whether to postpone the surgery or you will continue the surgery? You will do it?
I will do the surgery.
Yes. So the opinion is, there is some various opinions
My
regarding
choice
these
of graft
points.
might change, sir, but because I might not go
But
for
there are lots of reports that with these conditions we can do the surgery. If there is a fungus infections, there is lots of irrigations with betadine and saline. You clear it and you can do the surgery. Even in active infections, you can do the surgeries. The results are same whether you do it with active infections or without active infections. Next, graft. This is mainly for the junior, that sometimes the graft becomes smaller or it is perforated during the teasing of the muscle fibers, etc. So how will you manage this? If the graft becomes smaller or there is a perforation in the graft? Dr. Somo Khadok?
So if graft is small, then I'll generally take another piece and do double breasting and try to cover it up.
Yes. Any other opinion?
If the graft is smaller and there is a gaping starting from the anterior part of the annulus, we can use a small gaping of course. In that case, we can use the Abgel to.
He is telling that if there is a graft is smaller, we take another graft and no problems, you can brace it. Okay. Whether your same opinion?
Yeah, we can use it.
Any other opinion from? Yes. So if there is a graft which is smaller or perforated, there is no problem. We can take another graft and both the grafts can use in the same fashion like temporal plasty. This is a problem. Another point is that we usually use the temporal fascia as a graft material, but sometimes also we use cartilage. So my question is that when you like to use cartilage as a graft material? Dr. Jayanta Saha?
Sir, usually I use it when it is second revision or third revision cases. Otherwise, I like to use temporalis fascia graft.
Dr. Otish?
In large perforation, I usually use cartilage graft, and also in division cases, I use cartilage graft.
In large perforations?
Very large perforation.
Routinely in large proportion you use it? Doctor, any other opinion from the panelist?
So in cases of subtotal perforations and in cases of anterior perforations, we should always use cartilage because it is more resilient to resorption and negative middle ear pressure, so it can withstand the negative middle ear pressure better, and because it has a similarity to our natural tympanic membrane because it contains a collagen type 2.
Dr. Saha?
Yes.
So when you like to use cartilage?
Subtotal perforation, sometimes there is, if posterior rim is very thin, then cartilage should be put and it will help for placing the graft.
Okay. So cartilage is sometimes used in case of mainly when there is a denuded middle ear mucosa and also some large perforations. Also when the tympanic membrane is very thin to strengthen the yeast.
I would like to say something here. I strictly follow Dornhofer's criteria, and he has given a very wonderful definition of what is a high risk perforation. So I follow that. There are few situations which he calls high risks. One is the graft is the TM is perforated greater than 50%. That is one. Second is when there is active discharge, as I said, as you were discussing. Third is when there is bilateral perforation, because it implies poor eustachian tube function if there is bilateral perforation.
Yes, that is also another important valid point.
These three are for high risk, and the other one, as you said, is for an atelectatic drum. I will always prefer using a cartilage because it implies that the eustachian tube is not functioning properly. So these are the criteria where I routinely do follow cartilage tympanoplasty.
Yes. So these are the situations when we usually use cartilage. Next, what technique you follow for anterior perforations? Anterior perforations are very dangerous when there is no remnant of tympanic membrane, only annulus is there. the failure rate is much more high. So, Dr. Shah, what technique you will follow in such cases?
If redeem is very thin, less than 2 millimeter, it is better to get one window and put the graft through this window.
Yes. And we are practicing skeletonizing the malleus in all cases of tympanoplasty.
Mostly we are doing because it will help for keeping the graft, because to make the air space better, graft should be placed on the head, handle of malleus. That is
Dr. Pal?
Yes, first of all,
Same opinion.
Same opinion, but for anterior perforations, we can take up the anterior canal wall skin and then tuck in the fascia and then place it again.
Not always doing some window, but just limiting the anterior wall,
which is
you are also doing it.
Tucking.
Yes.
There is some other techniques
Dr.
also.
Otishalar?
Sir, I do not skeletonizing the malleus in every cases.
Yes.
In small perforation cases, I do not do that. And for anterior perforation, I usually tuck up the graft below the anterior skin and put it down.
Okay, Dr. Joyendo?
Sir, I always skeletonize the malleus handle because to visualize the articular chain.
Yes.
And for anterior perforation, I actually approach for conventional tympanoplasty approach. And if there is margin is too short, then I just elevate or raise the meatal flap anteriorly 2 to 3 millimeter away from the annulus, and just leaving the antero-inferior quadrant.
So, do you palpate articular chain in every case of myringoplasty or tympanoplasty?
Yes, sir.
Dr. Devarabodhu Bishwas, so do you follow this same principles?
Yeah, almost the same. Malleus is skeletonized in all cases.
All cases.
Yes.
Dr. Devangsu Ghosh?
Sir, I usually skeletonize the malleus because problem is twofold. Number one, I have to palpate and see the movement of the other ossicles. Number two, if I make a V-shaped knot sometimes to make the underlay, keeping the malleus handle above that. In that case, if you do not skeletonize it properly,
it's very difficult to place.
Yeah.
Yes. Dr. Shoma Ghodok, same opinion.
No, sir. I only skeletonize the malleus if after freshening the margins of the graft, if the new margin touches the malleus, then I go for skeletonization.
Yes.
If it is so small that it is not touching after freshening the margins, the graft is not touching, the perforation margins are not going up to the malleus handle, I don't skeletonize it.
So actually, skeletonizing of the malleus we are not practicing in the previous years. Usually we are placing underlay graft behind the handle of malleus. But in case of large perforations, subtotal perforations, also in case of other, for examination of the ossicular chain properly, we have to do the skeletonizing of the handle of malleus.
Sir, is skeletonizing going to improve my visualization of the ossicular chain in any way? Because
yes, sometimes there will be some problems in the, you have to change also, see the whether fixity of the handle of head of the malleus also.
that is a different thing. So if there is loss
So
of mobility,
if you
obviously
have to feel the ossicular chains, all the ossicles separately.
Right. But even if I do not skeletonize the malleus per se, I can palpate and see if it is moving
Yes,
or.
that is the point. And also are doing not skeletonizing the handle of routinely in all cases.
Yes,
It's very small perforations, we are not doing it. So residual perforation, that is a very pathetic situations after any surgeries. Residual perforations. So what are the factors responsible and how to avoid? Dr. Saha?
Very difficult. Problem, I am thinking that if we put the gel form in the middle ear, sometimes graft will be gel form in the middle ear, that sometimes may cause extrusion of the graft more laterally. That is one of the factors. Another factor, if we give the graft only technique, graft uptake is better, but sometimes there will be some gap anteriorly. Another point, sometimes residual gap may be due to technical fault of the surgeon. He is not properly placed, where graft should be placed just under the annulus. What we are doing only under the technique, not the only or under the same technique. On the posteriorly, we are placing the graft on the posterior canal wall, that is only technique, and anteriorly we are pressing the graft under the annulus. This technique is good.
Dr. Paul, anything to say? Any other points?
I agree with sir. Only when there is excessive middle ear pressure or in cases of temporalis fascia graft, these residual perforations are seen, not in cartilage tympanoplasty.
Dr. Oti Saldar, and what are the factors which you think the most responsible for a residual perforation?
When the graft is not properly placed in the anterior superior region and anterior part, that is the most common cause of residual perforation.
Yes. So anything to add?
Margin replacement should be accurately done.
Yes, that is also an important valid point. Margin replacement should be done accurately. Any other point?
Actually, sir, the problem is graft should be sufficiently bigger, because we know whenever the graft is outside the body, it shrinks to 1/3 of the size. So there, in that case, there is a problem of tucking in all throughout the 360 degree. That is the main important reason. And other is the freshening, as the Dr. Shah has told. Freshening should be adequate all throughout.
Yes. Dr. Shomo, same thing. So the take-home message is that though, and yes.
One more thing I would like to add here. Earlier, we used to take grafts, we used to dry it. With fresh grafts, it seems better.
Yes, definitely. So the most important thing is that the margin should be present very clearly first. The graft should be placed all over along the canal wall, so that the graft is supported by the bony canal wall. In the anterior window, though it is may required, but we are not doing routinely anterior window, so we are elevating sometimes the anterior annulus, and we are tucking underneath the annulus. But in difficult or revision cases, I think anterior window placement and the graft is insulated between these would be much more helpful. And another important point is that the temporal fascia should be in touch with the tympanic membrane. That is one important point. So if there, so if there is no touch in the obturative flap with the temporal fascia, then there may be a chance of residual perforations. Otherwise, if we do it with all the factors, it is almost a 100% success. So inadequate graft coverage of the perforations, slippage of the graft, and thus losing contact with the flap, tympanomedullary flap, placing the graft all over bony sulcus, and making anterior window or proper refreshing of the margins. So these are the important factors to be kept in mind during doing tympanoplasty. Now coming to the mastoidectomy, usually we are doing sometimes canal wall aft or canal wall down mastoidectomy. So in case of squamosal disease, when we do the canal wall aft mastoidectomy, Dr. Shah, in which situations?
When the cholesteatoma is limited.
Limited to?
Limited means it may be above epitympanum and above the mesotympanum and mastoid. But if it is hypotympanum or nearer to the station, we should not do canal wall up technique.
Yes.
And if there is hypotympanum or anterior to the station tube, towards the station tube, there is a cholesteatoma, I think it is better to do posterior tympanotomy and to clear the disease to the hypotympanum and around the station tube, so that either we can do canal wall up technique with posterior tympanotomy. The result is better for the removal of the disease.
Okay, Dr. Paul, same opinion.
Same opinion. But only in, I think, in cases of children, we avoid a large mastoid cavity, we go for the canal wall up technique. But in cases of cholesteatoma extending into the mesotympanum from the attic, we should always down the canal. We should lower the facial ridge, and so it becomes the canal wall down.
So any other opinion from the panelists? I have to take.
Sir, in limited cases, I only go for atticotomy and go further. But if the cholesterol is extensive, I always done canal wall down mastoidectomy.
Yes. Any other opinion? So usually in very limited pathology, in the in case of attic region, or if there is some small retraction pocket or adhesive otitis media, in few these cases, we can do a canal wall of mastectomy. Okay. And also the patient's education is also very important, because canal wall of usually the recurrence rate is more, so you have to counsel the patient accordingly that you may require a second operations later on. So canal wall of retraction pocket with ossicular necrosis, cholesteatoma confined to attic, middle ear, antrum with an intact sacs. So in these cases, you can do a canal wall of mastectomy. So it is another point, the lowering of the facial bridge. In case of canal wall down mastectomy, usually we fear mostly during this surgery that how much canal wall should be lowered, how far, and as there is some facial nerve injury. So this is the most fearful conditions we face from the beginning. Okay. So I think Dr. Shoma Ghodok, you will find right persons to answer this. Yeah, how far and how much you will lower down the facial bridge in case of canal wall down mastectomy?
Sir, obviously I'll use the dome of the lateral canal as the most important landmark.
Yes.
And try to lower it down as much as possible up to that height, just avoiding the dome superiorly. And inferiorly, if the digastric bridge is visible, I'll go up to that, just above it.
Yes.
But I'll start from above. Generally, I try to start, I isolate the tympanic segment first and then follow it, then look at the height of the dome of the lateral canal and then follow it downwards towards the mastoid tips.
Okay. Any other landmarks you can debunk to?
Same as
is the lateral dome of the lateral and the digastric. Any other?
Another important thing is you have to flush with the digastric ridge area so that there shouldn't be any thumb between the middle ear floor and the mastoid floor. So
Yes,
that is another region of recurrence or
any other landmarks you will follow?
Not that much, or annulus.
Annulus?
Yeah, annulus
Yes.
you can use as a second
And
landmark.
Dr. Devrata, any points or anyone?
We can lower it up to until the point we see the fallopian canal. It's the easiest way. You see the fallopian canal.
Yes. So
ample
routinely
irrigation
in
and
all
stop.
cases you do it up to the fallopian canal.
In most cases, because where I need to remove the mastoid tip.
Or it depends on the size of the mastoid cavity.
In most cases, exactly, I'm going to that. When I need to remove the mastoid tip, it's always better to go up to the fallopian canal, because we are also removing the posterior facial cells. So in that case, it's better if you go to the posterior fallopian level of the fallopian canal, break the tip, and then bring in the muscles.
Yes. Dr. Joyendra Shah, any other landmarks you follow?
No, sir, same opinion.
Another important landmark is chorda tympani. Also, when there is you see the chorda tympani, it's also a good landmark. Fossa incutis also is a good landmarks. So during this surgery, and also how Dr. Ruti Shalder, when it should be down up to the fallopian canal. So how you know that this is a fallopian canal? What are the indications that you are very nearing to the fallopian canal?
When you come near fallopian canal, that be chance of bleeding.
Yes, there is some
That's
chance
the
of
most
bleeding.
important thing. I
And
think.
any other point?
First of all, we see the color.
Yes,
there is
color.
a
This is
reddish
very
tinge.
also important. Bleeding and color. These are the two very important points to see the fallopian canal.
Fallopian canal.
Yes. Yes.
When you skeletonize it, nearly when 2 millimeter is left.
Though
can
we
see
may
the
require
tinge.
it up to the fallopian canal, but usually depending on the mastoid cavity, it may not be lowered down or may not be required to down it up to the fallopian canal.
Yes, sir. Yes, sir.
Okay. So, Dr. Shah, what is the most commonest?
I want to add, can
Yes,
there
yes.
be the sound change during the drilling? Maybe some say that it is also indicating that you are approaching to the fallopian canal and damaging it.
Drilling,
Drilling,
change.
changing sound whenever.
Yes, yes.
Sound drilling.
Dr. Shah, which part is most commonly injured during the surgery?
Near this
Facial nerve was
second genu of the fish.
Second genu. What is the most important reason for this?
During thinning, and when we are giving the Adidas, when we are seeing the short process of incus where it is, that time it may injure. That is because this is a very, very delicate part, and if we are making very, very thinning like paper. Sometimes it may happen.
So any opinion from the panelists?
The most common part which would be injured, the facial nerve you are talking about, it's the second genu during
Why?
the surgery. Because that would be done in cases where we are drilling from the posteriorly, from above downwards, and there is no incus. If the incus is there, it would probably protect it. So if there is no incus, we break the facial bridge. The first structure we are going to hit is the genu.
Dr. Shoma Ghodok, your opinion, same opinion, that second genu is the most commonest site for injuring the facial nerve?
In canal wall down mastoidectomy?
Yes,
or
yes,
canal wall
definitely.
down? I would believe it is the mastoid segment. Vertical segment is more commonly injured than the second genu. I think so, because that is what I feel.
Dr. Devangshu Ghosh?
Traditionally, in middle ear surgery, it is the tympanic segment, and mastoid surgery, it is the vertical segment. Okay, so and the problem is whether the facial canal is previously intact or not, whether it is diagnosed previously that there is a facial paralysis or not. In that case, that is a forewarn us as a surgeon to go slowly in that area. And another thing, Dr. Bishas has told rightly, if there is no incus, that is, so we can go and impinge on the fallopian canal to deal to damage in that area.
Yes. Small, yes. In the other case, you can start from the attic, inside out technique. If there is a very small one, it is very
better for the inside out. In case of the canal up, to find out the rudimentary antrum, very common to go towards the facial second genu.
So, from the discussions, the most commonest part is injured the second genu. If it is very rare to damage the facial nerve until there is dehiscence in the canal wall. So, most commonly this part has a dehiscence. So, we don't care it for the dehiscence or to look for the dehiscence.
If it is also associated with granulation tissue.
Yes. So, that's why it is the most commonest part injured during the surgery. So, how to remove the cholesteatoma from around the stapes and sinus tympani? Dr. Shoma Ghodok, what is your principles to remove most delicate structures? These are the.
Sir, for stapes, I generally use a 45-degree pick and go from posterior to anterior, following the pyramid and the stapedial tendon. And for sinus tympani, I will lower the facial ridge as much as possible, and also do a part of bony canaloplasty and look at the sinus tympani and use a curved hook or something like that.
So, whether you to remove the pyramidal process during this time to look for the sinus tympani?
I haven't done it as such.
Any other opinion?
An angled endoscope.
Angle endoscope.
Yes.
Any?
Sir, it depends on the technique, but basically you have to be utmost meticulous working in this area around the stapes. So you have to fix the stapes with your left hand if you are a right-handed surgeon with a fine sucker needle. Then you have to very gently and meticulously try to take out the.
So whether to remove the pyramidal process for clearance of the sinus tympani?
Sometimes it may be necessary to give a view, to take a view in the.
Sometimes you may have to clear the pyramidal process also with a very small fine 0.6 millimeter bar. So any other opinion? I have a short of time, so I have to. Okay. So most important thing is that we have to be very gentle during dissections of this part, the most thing, and it should be the last part. Next, ossiculoplasty. What material you use for ossicular reconstructions? There may be sometimes bones, cartilage, or some synthetic material. Dr. Devarabodhu Vishwas, just which you are commonly used? Just one question.
Cartilage.
Cartilage. So most of the times, I think panelists' opinion that you are using the cartilage most of the times. Okay. And your preferred technique with or without suprastructures. If there is Dr. Janjasa, you are also using the cartilage.
Yes,
so
sir.
how you use the cartilage in case of suprastructures when present or when it is not present?
When it is present, suprastructure is present, I take a part of cartilage, preferably floor cartilage, then make a small hole by drilling it and capping it over the stapes head and
Yes.
just over the temporalis fascial lobe. But without suprastructure, it's difficult to
Yes.
give a cartilage and stable it. So I prefer to use a torf.
Torf.
In that case.
Yes. Any?
I have a difference of opinion here, sir.
Yes.
If the incus is present, my always first choice is autologous incus.
Autologous incus.
Yeah,
Yes.
autologous incus always be
Ah.
my first choice to reconstruct the ossicular chain.
Yes.
If it is not there, then I have to resort to the Teflon processes like PORP or TOR, Teflon material. And if the superstructure is present, that is no issue. It is type 3A or type 3B, minor columella.
Then how you will reconstruct?
I put the incus after reshaping it over that. Over that I put a cartilage cap or shield of cartilage. Over that temporalis fascia.
Yes.
This is the standard. In case of the only footplate is present, and I follow usually the TOR either, or I follow the BKRC search technique. I use a cartilage shoe tympanoplasty.
Yes.
Small cartilage shield of 1 millimeter diameter put there, and also use the SARS innovated instrument. This is a cartilage puncher.
So most of the time
Yeah.
you using cartilage.
Yeah.
Bones very rarely.
Yeah.
Do you use preserved cartilage? Preserved cartilage from the septal cartilage or septal spar like that. Anyone is using preserved cartilage or preserved bones like incus?
One thing, auto incus should not be used because it is infected.
Infected, sir.
Usually
Yeah, we
it
should
may
not-
cause potential infection. It can carry, for which any time infection may cause.
Preserved cartilage?
Never. Preserved cartilage can take, but problem is that cartilage tympanoplasty, as it is easily available, why we are taking preserved cartilage? Number one. Number two, cartilage tympanoplasty have 3-4 benefit, because when we do interposition osteoplasty, this is a rigid fixation, easily dislocate. Another, there is a submersion of the footplate that may also cause. Again, intactness of the ossicle with this
Which
is
you always use the cartilage
cartilage
Never
implant.
using some ossicle or
Because
receptor
now we have
ossicle.
used a torque port. We have seen that sometimes it is displaced, sometimes there is some erosion of the bone lateral wall, and for which it is better to take cartilage. And cartilage gives good hearing and long-lasting hearing intactness.
Anyone in the panel is using ossicles, recept ossicles? Dr. Somo?
So if it is a cholesteatoma case, I am never using reshaped incus. But if it is a mucosal disease and I have done a canal wall up, I might use. I have used it rarely. In cholesteatoma and canal wall down, I generally use Teflon PORP or Teflon TORP with a cartilage cap above it.
Yes. So can you sometimes use the handle of malleus as a prosthesis?
Sir, I have never used. I don't
Especially in case of when there is no suprastructure is present.
You can cut the tensor tympani tendon in that case and directly put the handle, tip of the handle to the foot plate area. Then you can do a reconstruction.
Yes. So most of the time we are using the cartilage in using as a ossiculoplasty. Sometimes it is better, but with suprastructures, I think the hearing improvement is much. But with without suprastructures, it is very difficult to gain the hearing. Next, cavity obliterations. When and how you obliterate the cavity? I just have 5 minutes more. We have to end by this. Cavity obliteration. Dr. Saha?
Cavity obliteration we should do only when there
Actually,
is
we are
a-
not doing routinely.
Not routinely.
We are not
because-
practicing it
because
routinely.
There is some problem. In case of diabetic patient, we should not do, number one. Number two, if there is a dead air, then we do.
No, actually, that are not the
That is
questions.
what-
How you do it?
Either bone chips together with, or cartilage together with the local flap.
Is Dr. Dr. Pal?
Yes, first.
We do not require actually cavity obliterations in all cases.
All cases.
Ah.
Only
So,
in
which are the
cases-
cases when we do cavity obliterations?
Especially in some canal wall down technique, in cases of recidivism, where there is both recurrent and residual cholesteatoma, we should always do in second surgery mastoid obliteration.
Dr. Oti Saldar, when actually we are not doing all cases cavity obliteration, huh? So when will you do it? When you require to do it?
I do not do it routinely and never do it because
Yes.
there
Dr.
is
Jayanta
in the
Saha?
first chance. In the first chance, because there is chance of residual cholesterol in the case of cavity ablation technique.
Now, if there is a dural collapse or dural herniation, we should do.
Dr. Jayanta Saha?
Sir, if there is a big cavity and I am satisfied with the disease clearance, then I will do cavity obliteration.
Yes, that's the most important thing. It is a big cavity with some pockets like in the synodural angle or near the tip. You have to obliterate it for a better cavity. Dr. Devarudh Vishwas, what is your opinion? With Dr. Saha?
Almost the same, but I routinely break the, in case of a canal wall down, I routinely break the mastoid tip and advance the muscles, both digastric and SCM.
Okay. So though cavity obliteration is not required in all the cases, but when there is a deep cavity, we have to avoid some obliterate it. Next question. Where not to place a graft in after, this is the last question, after canal wall down mastectomy? Dr. Shomang Hodok? Usually in the previous years we are not placing graft. Just we are doing the mastectomy with gouge and not also drill. But now you are regularly putting a graft in the mastoid cavity for better healing. But when you not like to put a graft? In which cases?
I generally try to put graft in all cases.
Yes, I also try it.
If I am happy with my disease clearance, I put graft in all cases.
Dr. Devangshu Ghosh, especially there are two situations where you will not place graft.
Number one, if I am not sure in cases where I have not cleared the disease fully, and I may undertake
If you are not sure, you can do it. You can counsel the patients that you will get a second operation. But you will not put a graft. Dr. Devarudh Vishwas?
Exposed facial.
Anyone? When you are not putting a graft after doing a canal wall mastectomy?
So if there is a granulation tissue entangled with the dehiscence facial nerve or in around the facial stapes suprastructure or foot plate, there is chance of further complication. I don't put it.
No, in these cases you can put a graft and can do a second leg operations.
Sir, if there is a proper myotoplasty and there are presence of granulation, the granulation dry up. If there is proper myotoplasty due to the aeration of the mastoid cavity. So I do not use graft after when there is some granulation tissue present in the mastoid area and other area.
Anyone? Okay. No, actually, not malignancy. Usually, if the cholecystoma involves the eustachian tube orifice or eustachian tube, and there is involved the hypotympanic cells, which is very difficult to clear. So in these cases, usually we don't like to put a graft in the canal mastectomy.
Complications?
Okay. Yes, thank you all for suggestions and also thank you.
তুমি সবাইকে দিয়ে দেবে
Hello? When there is extensive cholecystoma, like involvement of the eustachian tube, and there is also involvement of the hypotympanic cells, so especially, and also if there is some, in these cases, you will not put a graft. It is very difficult.
We are running short of time, so discussion will be held afterwards. Thank you, Professor Jana, for the panel discussion. May I request Dr. Jana to hand over the mementos and certificates to the panelists. First, I would request Dr. Ashok Shahab to collect his memento and Sir. Huh? May I now request Dr. Shomog Hotok to collect his memento. Hey, time short. Somo. May I now request Dr. Joyanto Shah to come and collect his memento? Dr. Devobroto Bishas, please come. Dr. Debangshu Ghosh. Dr. Kollan Pal, please come and collect your memento. Dr. Atish Haldar. May I now request Dr. Ashok Shah to come and hand over the memento and certificate to Dr. Utpal Jana, please. Our next panel discussion is on head and neck surgery. Topic is management strategies in CL larynx and hypopharynx. The moderator of the session is Colonel B.K. Prasad. May I request Colonel B.K. Prasad to come up to the dais, please. The panelists are Dr. Manoj Mukherjee, Lieutenant Colonel P.S. Kumar, Dr. Shubhabroto Sengupta, Dr. Indranil Pal, Dr. Shukrit Bose, and Dr. Shubroto Mukhopadhyay. All are requested to come to the dais, please. আরে অতীশ গার্ড করে দিচ্ছিস তুই এটা সেট করা আছে আমি টাইম ওয়েস্ট করছি এটা টাইম হচ্ছে তোমার 45 মিনিটস the mic, there's a pointer and everything.
Full screen কোথায়? Full screen আসলে automatically চলে আসে।
Good afternoon, ladies and gentlemen. We have an expert panel to discuss the management strategies in cancers of larynx and hypopharynx. And it's very good to see that the association has selected a diverse experts in the panel, two being from the central government who work with the central government setup, one in armed forces, another is in ESI, two being from the state government setup in Kalyani and in Calcutta Medical College, and one from the private corporate setup. So it's a very good combination. Oh, I hope that everyone will have very interesting point of view as to how they manage based on the guidelines that are available in the literature. So here we are dealing with larynx with its oncological subsites of supraglottis, glottis and subglottis, and we are dealing with hypopharynx with its oncological subsites of pyriform fossa, the postcricoid and the postephageal wall. Now, there are a lot of things which are common in the presentations and management strategy, clinical examination. There are certain things which are different vis-a-vis larynx and the hypopharynx. So we'll first see what are the different things and then we'll see what are the common things. See, this symptom can be early in larynx, symptom can be late in hypopharynx. Similarly, you have nutrition poor in hypopharynx, laryngeal function is poor in hypopharynx. There are more incidences of regional metastasis and distant metastasis. Prognosis is bad in hypopharynx. And if you see the common things that this histology in both sides, commonest is squamous cell carcinoma. On gross examination, either it is ulcer or proliferative disease, or ulcer or proliferative disease. Presentation is the spectrum of symptom that is available there. One may come early and the other may come late, but the spectrum of symptoms is same. And all the patients go through the same set of examinations. So these are the common things. And at the end, the management strategy grossly divided will be same, because early lesions will be treated with single modality and late lesions will be treated with multimodality. So with this, we go ahead with etiological factor and then how to examine the patients. So in larynx, the commonest etiology is smoking. Then we have synergistic action of alcohol. Then the patients who are exposed to paints of petroleum fumes, wood, dust, radiation, and the other etiologies. So first I would like to start from Colonel Prem Shankar as to what are the etiological factors which are there for hypopharynx in addition to what is there in larynx.
As you have mentioned, sir, in similarity, the etiology is more or less common, but in hypopharynx, the alcohol is much more responsible for creating, because this alcohol is passing through, and smoking is much more for the larynx thing. Both have synergistic action for larynx as well as hypopharynx.
Right. Dr. Sengupta?
As has already been told, I agree with Dr. Prem Shankar. Smoking and alcohol are the main causes in these head and neck tumors like hypopharynx and larynx.
Yeah, with respect to post-cricoid, Dr. Sukrit?
I first of all apologize for a very bad voice I'm having today, but I'll try my best. Post-cricoid, I think, along with hypopharynx, probably a genetic factor would come into the etiology.
Yes.
And food habits, GERD, alcohol, as rightly said,
Yes.
probably more goes as an etiological factor with
Yes.
hypopharyngeal malignancy.
Yes, so almost everything is there. Tobacco chewing here comes more in picture than smoking the tobacco. And alcohol has got the same synergistic action. Genetic has been brought out. Plummer-Vinson syndrome is supposed to be one of the precarcinogenic factor in cases of hypopharynx. Other factors being same. HPV has been debated and the research is still going on whether there is strong association or poor association with laryngopharyngeal cancers. So let's go to the case scenario. A 50-year-old male presenting with hoarseness, difficulty in breathing, dysphagia, choking spells. All the symptoms are there. So how do we evaluate? Now we are suspecting a case of laryngeal cancer or hypopharyngeal cancer because we are dealing with that. So we'll take the case history in detail and see how the nutritional status, how the performance status is, and see whether the patient has got in situ tracheostomy tube or nasogastric tube there or not. And then we come to ENT examination. So, Dr. Manoj, what would be your checklist for ENT examination?
From the history, I'll first take the case as a CA larynx or hypopharynx.
Yes.
It is 100%.
Yes.
Then you have to use your whatever the gadgets and facilities you have to exclude to make sure it is not a cancer.
Yes. So clinically, what would be your checklist? You are looking at the throat of the patient.
Yeah, definitely. First, if possible, IL examination, but that is not the sufficient. At least very good FOL should be done.
Yes. What all you like to see in examination?
Definitely the whole of the larynx,
Yes.
tongue base, hypopharynx, all the hidden area.
Yes.
Don't forget the oral cavity.
Yes.
And I must mention that only FOL and IL is not the sufficient. At the end, you should not forget to palpate the tongue with your finger. Try to palpate whole of the tongue base and the hypopharynx as much as possible.
Yes.
Because you can, with FOL and IL, you can see the mucosal lesion. But what is deep to the mucosa, that you can palpate. That
Yes.
must come in your clinical examination.
Yes. So you have the checklist, you see the primary lesion, how it appears, nature, its extension, superiorly, inferiorly, laterally, medially. At the same time, you palpate airway evaluation, of course, because we are dealing with the food and airway. and whether the framework is
One thing is that
there or not. Yes, Dr.
another
Mukherjee.
thing, in addition, I have to palpate the neck also.
Yes.
For proper, whether the laryngeal crepitus is present
Yes.
or not. Another thing is the thyroid cartilage, whether it is broadening or not.
Broadening or not, tenderness or not,
Is
lymph
there
node?
any metastatic neck nodes are there?
Yes, yes. Dr. Supreet wanted to say something?
Yeah, I wanted to add the neck node.
So this would be the checklist. Now, next comes the imaging studies. Okay, Dr. Indranil, what imaging study primarily you would like to do?
Well, whenever we get a case of suspected carcinoma of larynx or hypopharynx, first we need to confirm the diagnosis, whether what we are suspecting is correct or not. We can be in error. So, and then we have to know the extent of the disease, that we have to stage the disease.
Yes.
I guess your question is about staging of the disease.
What imaging study you would like to do first?
The imaging
Yes.
will be.
There are various modalities. Which one you do first?
Yes. The imaging will be to stage the disease. So the imaging modalities that I select will depend on my laryngoscopic findings. If I am suspecting an early laryngeal cancer, I will restrict myself to just ultrasonography of the neck.
Okay.
If I am suspecting an advanced laryngeal or hypopharyngeal cancer, I would ask for a contrast enhanced CT, or in very selected cases, MRI, and even fewer cases, very, very selected, depending on specific indications, may be a PET scan.
Right. Dr. Mukherjee, what would be your gold standard of imaging?
At least one CACT.
CACT.
When you are suspecting CA, at least one CACT, MRI should be done, and if I am dealing with the extensive disease, wider area, I should prefer for the upper GI endoscopy also to exclude any primary lesion or exclude any lesion down the line in the esophagus or other.
Sir, Dr. Mukherjee, sir, your take.
Another thing is that, in addition to this imaging, flexible fiber optic laryngoscopy should be done to evaluate the particular certain areas of the larynx.
So we take it as a clinical examination. Your clinical examination will include whether you are using Hopkins rod or flexible endoscopy. So that one we have done. Now we are at the image stage before we go in with the rigid and take biopsy.
In the post-cricoid area, if it is involved, then barium swallow X-ray will be helpful. Whether any other lesion, synchronous lesion in the esophagus also. That should be excluded.
All right. So gold standard is still considered as CCT, which we do from base skull to the root of neck, and we have to see all the parameters that are listed here: site of lesion, how is the volume of the tumor, where does it extend, and especially to the hidden areas as well as to the thyroid cartilage. So, what are the signs of thyroid cartilage involvement in CCT that you see? Sir, Dr. Subrata, sir.
Whether any erosion of the thyroid cartilage
Yes.
is present or not.
Yes.
If there is erosion, then will chance that the growth has extended extralaryngally
Yes.
involve the strap muscles or
Yes.
thyroid gland itself.
Yes. Anybody else apart from erosion?
Yeah, there
Any other
are,
subtle sign?
There may be sclerotic changes or erosive changes. Erosive changes are more specific, but sclerosis is definitely indication of involvement of the thyroid cartilage. But for the other cartilage like the arytenoid or cricoid, if there is sclerosis, it is definitely indicating that some involvement is there. But in thyroid cartilage, sclerosis may or may not be involvement. But if there is erosion, it is definitely the sign of involvement.
Another thing we should look for whether there is any splaying, that is
Yes.
widening of the cartilage.
Yes. So features of cartilage involvement, one should consider sclerosis, erosion of course, irregularity, expansion, and obliteration of marrow spaces, as well as how it has gone through the cartilage. So apart from CCT, when would you consider MRI scan, Dr. Prem Shankar?
The imaging serves two purposes in these all CA larynx and hypopharynx. The first purpose is to know the extent, and second purpose, it helps in your therapeutic decision.
Yes.
So first, both are correlated. It's not separate thing. So if you know the extent and if you suspect even I mean, I suspect means even if an iota of suspicion of involvement of posterior prevertebral space or soft tissue involvement which upstages the disease.
Yes.
You must, and I say you should err on the positive side, that you should go for MRI.
Right.
Because carcinoma is life-threatening disease, and you get only one chance to cure it.
Yes. Dr.
If
Sengupta, any change in view, any difference or addition?
Even I would suggest even in early laryngeal carcinoma, if there is involvement of the anterior commissure, MRI may help you to find out the pre-epiglottic space involvement or paraglottic space involvement, even in early cancers.
All right. So more or less things have been brought out, that involvement of inner pericordium of thyroid cartilage, which is not confirmed by CECT. Definitely one should ask for MRI scan. Then base of tongue involvement, prevertebral fascia involvement, very prevertebral space involvement, that is very important. Any role of NBI, Dr. Sukrit?
Early lesions, lesions which are difficult to diagnose. Maybe we are having to do a repeated biopsy. NBI can be of use in those kind of lesions.
What will you look for? What will be suggestive?
Oh, if there are suspicious patches there or if there suspicious growth is there, then maybe we can do a deeper biopsy to get a diagnosis.
Yes, so narrow band imaging is slowly coming. It is one of the contact endoscopies where narrow bands of light based on certain wavelength, that is 450 and 415 and 540 nanometer has been used, where it catches the altered microvasculature of the mucosa. So we can detect all the dysplastic changes early because the first beginning starts from there. So in some cases, yes, where you want to have confirmation or you want to have extent of the disease, you want to take biopsy from most appropriate site, you might go for narrowband imaging. Yes, Dr. Manoj, or CCT, where would you like to ask for CCT of chest or you want to go for PET CT?
They have the different indication. If there is extensive disease, we must do a CECT.
Extensive means what here?
At least stage 3 or stage 4, when I'm suspecting stage 4 disease, or there is some extension of the disease, subglottic extension, or if there is supraclavicular palpable lymph nodes. In that case, I'll ask for the CECT chest.
So stage 3, stage 4 disease.
Yeah.
Lower nodal nodes. Okay.
Lower nodal nodes. And PET CT, I don't require it in fresh cases.
Okay.
I ask for it in post-radiotherapy, for workup of the post-radiotherapy, or when I'm suspecting recurrent or residual disease after the primary treatment.
Right.
Then we go for the PET CT.
Okay. So here we have to rule out distant mets. So T3, T4 lesions, of course, when the nodal volume is very high and lower neck nodes are involved, or if you're planning something like gastric pull-up where you need to clear out that everything is normal, and post-treatment as he has said. So these are the situations where you require chest CT or you require PET CT scan. So once we are done with imaging, now is this time for
one thing,
yes.
we should not forget the USG whole abdomen also for advanced cases.
Sure. That's a very good point. So now we are ready for the DL scopy or ML scopy. Yes, Dr. Indranil, what are the aim of doing DL scopy, ML scopy?
First is to confirm the diagnosis, because a direct laryngoscopy will help us get a biopsy.
Yes.
That is a very important, most primary investigative tool for us.
Yes.
And of course, both fiber optic laryngoscopy and direct laryngoscopy have their own advantages and disadvantages.
Yes.
The advantage of a fiber optic laryngoscopy is a greater panoramic view that we get. Whereas in case of a direct laryngoscopy or microscopy, microlaryngoscopy, we get a much more tubular and much more restricted view.
Yes.
In case of fiber optic laryngoscopy, we will be able to assess vocal cord mobility much better than in direct laryngoscopy, where the patient is under general anesthesia. Only during reversal we'll be able to get some idea of the vocal cord mobility.
Yes.
However, but in direct laryngoscopy or microlaryngoscopy, we'll be able to palpate the lesion.
Yes.
With our instruments and get an idea about the induration around the vocal cords So that's the advantage of a direct laryngoscopy.
Yes. Specifically, Dr. Subrato, anything you would find extra apart from whatever he has said?
In the direct laryngoscopy, you will
Which
definitely
scores over
for
the
confirmation
FOL?
of the diagnosis. For
Yes.
confirmation of the diagnosis.
Yes.
Other than this, the extension of the growth can be detected by direct laryngoscopy. Extension of the growth surrounding,
Okay.
and the passive mobility of the vocal cord by palpating the arytenoid, as well as the growth palpation, how much indurated surrounding that can be assessed
Yes.
by direct laryngoscopy.
Yes. Dr. Bose, you want to add something?
I would like to add one. Sorry. I would like to add one thing. There are certain areas, hidden areas, which are not very well assessed by a fiber optic laryngoscopy. Mainly the post-record area.
So it's
that
very
is-
well.
that can be done
yes,
by.
very well brought out. That you have to examine, map the disease, see into the hidden areas, and the first point, that is the most important point which is brought out, is that we have to take biopsy, which will prove the tissue diagnosis. Okay, now we have the tissue diagnosis. So we would like to go and stage the disease so that appropriate treatment can be planned. Then we can discuss the strategies of management. Now staging disease, early cancers, then moderately advanced cancers, then you have advanced cancer. This is common for laryngeal as well as hypopharyngeal cancers. So early are stage 1 and 2 with T1, T2, no nodes. Then you have moderately advanced where it is T3 or there is N1 node with T1, T2, and then stage 4 would be A, B, C, C being distant metastasis, B being inoperable kind of thing, and T4A which is operable. So we'll not go into details of it, but it will give us a good picture as to how the decision making is done to adopt different strategies for management. So yes, Dr. Subrato, first you will set up the goal. What team you would like to have as a full-fledged team, since you are working in a premier institute? For management, what team?
Team means
Apart from the onco surgeon, I mean, you are the operating surgeon.
The ENT people will definitely the primary role.
Yes.
For the diagnosis, and for the goal of treatment, I will prefer in my team as a radiotherapist, radiation
Yes.
oncologist.
Yes.
And then the oncologist, medical oncologist, the oncosurgeons sometimes helpful. Also, plastic surgeon will be sometimes helpful.
Yes. So it's a big team apart from the rehabilitationists or the speech nutrition therapists also. Everything has been brought out very well. So what will be your major goals? This is the team that you have.
Okay.
Yes.
Major goals is that I have to treat the disease for curative purpose.
Yes.
And after curative, the patient will be rehabilitation in different aspects, in the form of voice rehabilitation, in the form of swallowing rehabilitation, in the form of olfactory rehabilitation. These are the major goals.
Yes. Yes, Dr. Bose.
Should have a functional larynx.
Okay.
Post-treatment should have a functional larynx.
Good. Next. Anybody else want to contribute?
Actually, the best possible outcome to the patient, depending on the stage of the patient. Functional larynx may not be possible always.
Right.
So
I think it should be adequate oncological clearance with minimal morbidity as far as the stage determines, and a good quality of life.
Right.
Survival is not necessarily the primary goal. It may be our primary goal, but for the patient, survival only may not be the primary goal. The patient may prefer quality of life over survival.
Yes, Dr. Prem wants to add?
I think same line, the oncological clearance of the lesion is the most important part. Survival, I mean, if somebody maybe, I mean, some differ whether I want this comorbidities or not, side effect or not, he may decide for surgery or some other treatment. But as far as surgeon is concerned, oncological clearance, that is cure, disease has to be removed. That is the primary goal.
Yes. So as I understand, what has been brought out by the panelists is that survival with disease is the least important thing. Maximum cure and good quality life is the more important thing. So maximum cure, preserve the function of larynx, and good quality of voice and swallowing, as well as good quality of life. So this is more important than surviving with disease. So now we'll take up the management strategies case-wise, stage-wise, or you can say the severity-wise of disease. We'll just put case scenarios and ask the opinion of the experts how they're going to manage. So the first case is 40 years old male, a smoker, a school teacher who has complained of progressive hoarseness for about 6 months. So you may have picture like this, which is a mid-quarter lesion ulcerative, or you may have picture like this. So what will be the next investigation, Dr. Prem?
First and foremost is the imaging, that is CECT.
CECT. So this is a CECT picture.
Yes.
Okay, so you have a male patient of a young age, school teacher. Hoarseness is the only symptom. That is the endoscopic picture. This is a CECT picture. Would you like to ask for MRI?
Since this is confined to the, we can clearly see the extent of the lesion,
Yes.
confined to one vocal cord. MRI is not indicated in this case.
Not indicated.
All other surrounding structures are normal.
What treatment you will offer?
So this case can go
So
both.
cords are mobile, N0 neck.
Sir.
What treatment you would like?
Functional larynx, these both options like of radiotherapy, curative radiotherapy as well as surgical, both options have valid survival rate in these cases.
Okay.
But nowadays, radiotherapy is preferred over surgical excision.
All right. Yes.
Yes,
Dr.
of course,
Singh.
radiotherapy and surgery gives equal outcome in terms of function.
Right.
But radiotherapy is going to be a prolonged treatment, at least for 3 to 4 weeks. Whereas patient may prefer, because in this particular case, it's a mid-cord lesion. If we have the facility and training for laser surgery, we can go for endolaryngeal laser surgery, TLM.
Dr. Bose?
There's two aspects for this patient. One is the patient is quite young, 40 years. Number two is a smoker.
Yes.
So I presume after treatment he will not quit. And I would rather offer him a laser surgery first and hold back the radiation if the patient recurs again.
Okay.
It's a very valid point, yes.
Okay. So do you think the laser gives a good quality of voice compared to radiation, because he is a school teacher? You know?
In mid-third lesions and posterior lesions, the voice quality is almost acceptable.
Right.
If it is an anterior-based lesion, then probably radiation gives a better
Yes.
voice quality.
So in this case, intent is definitely to curative intent. At the same time, good quality of voice is required. So options are both. If you see the long-term survival, disease-free survival, it is equal in both. But the preference of patient will be one, and your expertise constraint may be other thing. So radiotherapy and surgery both have got equal, but voice quality is considered to be documented to be better in radiotherapy. But suppose the patient has chosen the other option which Dr. Sukrit has given him. He has undergone laser surgery, and type 2 chordectomy has been done. Final SPR is this. Squamous cell carcinoma well differentiated, margins are clear, closest margin is 2 mm. Dr. Bose, would you like to offer adjuvant?
No.
No. Okay. Why?
In a laser chordectomy with 2 millimeter margins, I would be quite satisfied to follow him up.
Yes. So even 1 millimeter margin is good enough. So nothing should be less than 1 millimeter margin. So that is the message. So let's go to case 2. Yes, Dr. Manoj. Case 2 is 60 years old male, smoker again. He's a bank employee, and this is a DL-scopy picture.
Yeah. And,
so one cord is involved, anterior commissure involved. It's going to the other cord.
yeah, what about the mobility of the cord or?
Cords are mobile.
Yeah.
Okay. First, I would like to know what is the importance of anterior commissure.
Yeah, there may be progression of disease through the pre-epiglottic space early, or involvement of the thyroid cartilage or extralaryngeal spread may happen earlier. We need the imaging first.
So this is the image, which is doubtful of inner perichondrium involvement there. So what next you will ask?
If there is doubtful from the CECT, MRI can help for detail.
So MRI has ruled out involvement of cartilage.
Yeah.
Now this is the stage. What will you offer him?
We can go for the radiotherapy.
Radiotherapy.
Yeah.
Any difference in view in this? No difference. So importance of anterior commissure, everybody knows that the Broyles ligament attaches the cords into the thyroid. at the site where inner pericardium is dehiscent. So chances of involvement of thyroid cartilage is early and higher, and it may go to pre-epiglottic space. And treatment is radiotherapy with definitive intent, curative intent. So you go to case 3, similar case, but the patient has been treated 4 years ago with 66 gray of external beam radiotherapy. 4 years the patient has been follow-up. Now 3 months back, a patient started having hoarseness, and presently you have a lesion like this.
सांस लीजिए, नॉर्मल सांस लीजिए, हाँ। सांस लीजिए, ई बोलिए, बस हाँ, ई, हाँ बस सांस लीजिए, सांस लीजिए, सांस लीजिए, नॉर्मल, सांस लीजिए, नॉर्मल सांस लीजिए।
So there is a lesion there. It's a recurrent, biopsy has been taken, it's a recurrence case. Both cords are mobile.
बस हाँ, ई,
What treatment you will offer?
सांस लीजिए, सांस लीजिए।
Dr. Indranil.
Since this is a post-radiotherapy case, the disease, well, it's still, the cords are mobile and the disease is post-T1A.
Yes.
Difficult decision, but I would go in favor of limited surgery, that is laser excision or something similar to that. I would not advocate a more radical surgery.
Dr. Subrodhan.
As the vocal cords are mobile, so I will do a microlaryngoscopy. As it is available, the laser is not available in my institute now. So I will go for microlaryngoscopy and limited surgery, removal of the disease, and then confirm.
Dr. Prem.
Since-
Recurrence.
Yeah, it is a recurrence case. So I think surgery has to be not limited surgery. Total laryngectomy has to be done in this case.
Yes, Dr. Sengupta.
T1A. So limited surgery if we have laser, but I will go for total laryngectomy
Total
for salvage.
laryngectomy, yes. Dr. Bose.
Of course, laser excision. Mobile vocal cords, I will never offer laryngectomy.
Dr. Manoj, will you?
We can think of horizontal partial laryngectomy.
Is radiation an option? 4 years has already passed. So everybody is going for surgery, either conservative or radical. Now is radiation, re-radiation is an option?
Re-radiation is an option, but not in this case, as because it is a 4 years just ago he has received the radiotherapy. At least 10 to 12 years before if radiation is exposed, then re-radiation can be considered.
Any alternate view?
There have been a few studies which are recommending re-radiation in laryngeal and hypopharyngeal cases post 2 years.
Post 2 years. So this is another view. Even after 2 years, people are recommending radiation. Patient can go for IMRT, of course, and there are conflicting views regarding the conservative approach or the radical approach to surgery. If your setup is so good that you can manage conservatively and follow up the patient, yes, but majority of center probably you do with total laryngectomy. So next case is a lady chews tobacco and consumes alcohol for 12 years and landed up with dysphagia. This is the picture. And there is a growth in the left piriform fossa which is involving the AE fold and going towards the supraglottis. CT picture. Biopsy shows moderately differentiated squamous cell carcinoma. So what is the stage of disease? Because of paraglottic space being free, cartilage being free and no nodes. Okay? So it is stage 2. What treatment you will offer, Dr. Manoj?
Yeah, definitely I go for the radiotherapy or chemoradiotherapy.
Okay.
So in T2, I would recommend radiotherapy. If it was T3 or T4, chemo radiotherapy with concomitant.
Sir.
So T3 I would.
In this In this stage, T2, definitely radiotherapy, single modality treatment I will offer.
Single modality. So anybody else going for multimodality, adding chemo or?
No, not T2.
In case of hypopharynx, though it is a T2 and N0, I'd like to go for concurrent chemoradiotherapy. Organ preservation protocol should be applied because these hypopharyngeal carcinoma are very likely to have a submucosal spread as well as to spread to the prevertebral nodes and those things, pretracheal nodes. So I would like to go for organ preservation protocol, that is concurrent chemoradiotherapy.
Suppose your imaging studies have ruled out nodal involvement. Occult, we don't know.
Yeah.
Mobile cord, functional larynx. So it is stage 2. So generally the guideline is that stage 1, stage 2 has got single modality treatment. Majority probably will go for radiotherapy. So next case is supraglottic disease. N0, laryngeal capitis is present, framework is normal. That means you can understand that the laryngeal functions are preserved. But here we have the paraglottic space is involved. So that is upstaging the disease to T3. Now what would you like to offer Dr. Bose?
T3, N0, M0s. For this case, I would go for a organ preservation protocol, which is concomitant.
Dr. Sengupta, any change in view?
Still N0 and M0, T3, organ preservation protocol, radiotherapy, concurrent chemoradiotherapy, and we may also go for addition of immunotherapy with cetuximab.
In addition or in certain situation?
Maybe in addition.
In addition. Dr. Manoj?
Yeah, we have to see the quality of voice.
Yes.
And what is the condition of the larynx? Is it functional larynx?
Yes, it is functional larynx.
Yeah. If it is functional larynx, then definitely organ preservation.
So it's a typical case for organ preservation protocol, which is mostly consisting of CCRT, concurrent chemoradiotherapy. Okay. So intent would be curative. Organ preservation. We'll come to organ preservation protocol. Now this is a case where there is growth in the right piriform fossa. Cords are immobile. No aspiration. Voice is good. No cartilage erosion. Apex is free, post-cricoid is free, biopsy is same. Now T3, N1, there is a note there. Dr. Manoj.
As the voice is serviceable, so here also I will prefer the organ preservation.
I think there should be no ambiguity here because the laryngeal functions are all preserved.
Yeah.
So one must preserve the organ and go ahead with the treatment. So we'll discuss that. Now here the patient is presenting with cough and choking on drinking fluid for 1 month. This is the main feature, cough and choking. There is a growth in the piriform fossa on the left side. And DL-scopy shows it is going to cervical esophagus. The apex cervical esophagus is involved. CCT shows piriform growth extended to paraglottic space, post-cricoid region, upper esophagus. What would be the ideal treatment in the best of setup? And what would you do in Kalyani? Yes.
The ideal treatment would be total laryngopharyngectomy with esophagectomy and gastric pull-through.
Okay.
That is, in fact, that's the only treatment option, surgical treatment option. Any other surgery less than that will be inadequate. So if we can't do that, the other thing that we can offer is radiotherapy, concomitant chemoradiotherapy.
Okay. So here larynx is dysfunctional, that is aspiration is there. This is the extent, so ideally it should be taken out, But the constraints of expertise or constraints of the full team may make you offer alternative treatment to the patient. So that is the thing. what he has said is right. Look, this case was operated by the same extent which Dr. Sen has told us. So the organ preservation protocol came up after many trials. So Veteran Affairs initially did a trial saying, neoadjuvant chemotherapy followed by radiotherapy vis-a-vis surgery. And they found that 68% of cases they could preserve the larynx. Then came the European Cancer Organization trial. That also proved that the neoadjuvant chemotherapy is giving better preservation of larynx than taking out the larynx. And we had the first-year trial where 3 arms were used, neoadjuvant with radiotherapy, concurrent chemoradiotherapy, and radiotherapy alone. And there also it shows that addition of chemotherapy is preserving the larynx more and more, with concurrent being the best. But for that we have to know when the larynx is called functional, when it is called non-functional. Dr. Mukherjee, Dr. Subrata sir.
Larynx functions mean at least one laryngeal unit should be present,
yes,
so that the vocal cord function is preserved.
Yes.
The means the arytenoid, mobile arytenoid over a cricoid cartilage on one side should be preserved,
yes,
should be there.
Yes.
So it is the function of the larynx is present.
Yes.
In this situation, I may try for partial laryngectomy.
Yes. So patients should be, airway should be good, ideally should not be tracheostomized, voice should be serviceable, there should not be any aspiration which is requiring active management, and there should not be so much of dysphagia that the patient requires alternative management. Then only we can say that larynx is functional, and in this situation all attempts should be made to preserve the larynx in cases of T3 lesions.
Tracheostomy, initially we cannot say
Initially
tracheostomy.
you cannot say. Yes, but many a times patient will present with stridor, so you have no option to do it. But at the same time, you expect that you will be able to decannulate the patient later on. Yes. So next case is where there is tenderness and widening of the laryngeal framework. So now you know the cartilage is being involved. Okay, so there is cartilage involvement. CSCT thyroid is already showing the cartilage is eroded. Squamous cell carcinoma. So it becomes T4A. That means the B factors are not there. So best treatment here, Dr. Prem Shankar.
Since the cartilage is involved, so the decision is that total laryngectomy, and it's a high volume disease T4, so probably radiotherapy post-surgery followed by adjuvant treatment.
So no doubt, it's a very simple solution, that is total laryngectomy with adjuvant radiotherapy. So total laryngectomy has been done. So now this is a different situation. A patient presented with stridor, tracheostomy has been done, and it is a pyriform fossa disease which is going to post-cricoid. It's going to post-cricoid here. And there is suspicion of prevertebral fascia involvement. Yeah, Dr. Sen Gupta. What next? Imaging, definitely will ask for MRI.
MRI, of course, and suspected prevertebral fascia is a possible contraindication for any surgical clearance. So
yes,
palliative radiotherapy or chemoradiation may help the patient.
Yes. So one is that if it is confirmed by the findings in the MRI, then if the stage changes to T4B, and your intent of treatment changes to palliation. That's what he wants to bring out. So any other thing apart from the involvement of prevertebral fascia that changes your intent and shifts you from giving a proper treatment. Dr. Sen Gupta, apart from this, apart from prevertebral fascia
general medical condition of the patient, we have to consider about his nutritional status, any other comorbidity, whether he will be able to survive the huge surgery.
So the
or
patient factors.
Patient factors.
Yes. Any disease factor? Yes.
Is there a carotid invasion?
Carotid.
If there is a mediastinal invasion.
So carotid is all encased. So this is
if
all.
the carotid is
and
encased,
mediastinal extension. So these
Naturally
three things
conservative.
will make it T40.
Even in post-cricoid extension, we'll have to check whether it's crossing the midline or not.
Yes.
If it's not crossing,
going circumferential midline or not. So all the points have been brought
partial
out.
pharyngectomy or a total pharyngectomy.
Yes.
Now, once it is prevertebral fascia involved, there is no question of surgery.
No.
Okay. So no question of surgery. Would you like to give NSCT, Dr. Bose? Or what is the role of NSCT?
This is prognostically a very bad disease. And I think the intent of treatment would be more palliative than anything else. So we can offer NSCT to this patient as a concurrent thing. But prognosis is very poor. Even
So you
if
have to counsel the patient, the prognosis is very, very guarded. Though you can give NSCT, see the response. If it becomes salvageable, would you like to operate?
No, in any
No.
case, I'm not going to operate.
All right.
All
So-
other, whatever
Yes.
other options are available,
That's
but
clear.
not operation.
So tracheostomy in CA larynx. Patient is presented with stridor. Definitely you will do. Sometimes in elective situation we also do when we anticipate the airway to be compromised and you are doing the DL scopy. So you do tracheostomy preemptive and then do under GI you do DL scopy and take biopsy. So will you do high tracheostomy, low tracheostomy, Dr. Manoj?
If I am planning total laryngectomy or any sort of operation, then I will prefer the high tracheostomy.
So to incorporate the stoma within the resection. What is your view on stomal recurrence?
Regarding tracheostomy, one thing is that if you give an left tracheostomy, then you should do the left tracheostomy 48 hours before the date of total line.
Yes.
But in tracheostomy,
Ideal.
And that is the high tracheostomy.
Ideal. What do you think stomal recurrence? Does it increase if you do tracheostomy?
Definitely there is a more chance of increase for tracheostomy patient, and tracheostomy patient makes the job of total laryngectomy little bit difficult.
Okay.
So better, but if possible, we can do the total laryngectomy and under intubation.
Yes.
And this is the reason we prefer the high tracheostomy to prevent the stomal recurrence.
Yes. So it is reported that there is increased incidence of metastasis to paratracheal nodes in cases of patients who have undergone tracheostomy. High recurrence, if the advanced disease, most of the patients will have advanced disease, the patient is presented with stridor unless it is glottic carcinoma. So naturally the incidence will be high. So what is this surgery? Dr. Sen, obviously. Simple.
I'm Dr. Pal. Dr. Sen is Dr. Inil Sen is sitting down there.
Ranjan Pal, sorry. I'm so sorry.
Yeah, this looks like a total laryngectomy.
Yes.
Yeah.
So that's a total laryngectomy specimen, partial pharyngectomy. Why is this scale?
Oh, that is scale is showing 6 centimeters. Yes. This is to preserve at least 6 centimeters of unstretched pharyngeal mucosa horizontally. That will give us adequate results with regard to post-operative voice rehabilitation so that we get adequate resonating surface in the larynx, and it's also, well, to prevent, to give an adequate pharyngeal outlet to prevent dysphagia, 3 centimeters would have been enough. But
How
we
will
need
you
6.
close the pharynx? How much mucosa you require to close the pharynx in which way?
We'll need minimum 3 centimeters to close the pharynx adequately.
Primarily.
Primarily,
Yes. So you require 3 centimeter for primary closure and about 2 centimeter for at least patching, and then 1 centimeter onwards definitely you will require some tubing. So you'll be closing in 2-3 slides. Now this is the situation. Patient undergone total laryngectomy, bilateral neck dissection. Final SPR as the tumor is such and such size. It is squamous cell carcinoma moderately differentiated. Margins are clear. Closest cut margin 0.8 centimeter. No LVI, no PNI. 4 out of 30 sample nodes are positive for metastatic deposits. So what is missing in the final SPR which might change your adjuvant, Dr. Mukherjee, Dr. Subrata sir?
No The margin is more 0.8 centimeter. It
Yes.
is not adequate.
Okay.
It should be more than 1 centimeter at least.
Okay.
And
So what is missing in the report? They have given the margin.
Depth of invasion.
Depth of invasion. Anything else? Dr. Prem Shankar, Dr. Sengupta?
Perineural extensions there.
We may have a, I don't know from HPR, but the size of the nodes which were involved, if they are more than 3 centimeter, then we should have gone for
Yes.
adjuvant therapy.
So all these cases will require adjuvant therapy. Your patient has undergone total laryngectomy, at least T3 or T4 disease, T4A disease is there. So they will require adjuvant therapy. Now adjuvant is generally post-op radiation, but in cases of closed margin or positive margin, or in case of extracapsular spread. So if 4 out of 30 nodes have been sampled where it has not been mentioned whether there is extracapsular spread or not. These are two main features which make you add chemotherapy in addition to radiotherapy in case of to make a good adjuvant therapy. So that is the only thing missing. Voice rehabilitation. So this is one way of rehabilitating the voice. There is another way of doing the same with electrolarynx. And there is one with TEP. Which one would you like to prefer, Dr. Manoj?
Definitely the TAP and gold standard is the Provox. But
Okay,
if there is
TEP, anybody
constant-
else prefers to habilitate the patient with a laryngeal voice by
Electrolytics.
esophageal voice?
Esophageal.
Nobody.
Actually, before the operation, the patient should be trained for speech therapy, and trained by the speech therapist for having the esophageal voice. And if the patient is cooperating and he is definitely desirous to have the esophageal voice, in that patient will try. Otherwise, no.
Any
Otherwise,
doubt will go for TEP.
TEP.
Okay. What are the things that you will consider in TEP for the best outcome? Dr. Manoj again, yes.
Yeah.
For best outcome.
First one is
where
the
will you place? How much?
First is the pre-operative counseling and speech referral to
Yes.
the speech therapy.
Yes.
Then par-operative.
Yes.
There should be a myotomy.
Yes.
In the pharyngeal myotomy.
Yes.
There. And the TEP should be positioned in the center in adequate place, at least 8 to 10 millimeter from that tracheostomy
Yes.
margin and all these things.
Yes.
Yeah.
So you need a good size permanent tracheostoma and sighting, as he said, almost 8 centimeter, close to 5 to 7 centimeter, 8 centimeter from the superior edge, and right size prosthesis so that there is no leak. Cecopharyngeal myotomy has been brought out. A lot of people say that patients should never go into hypothyroid state because of tissue edema which comes up there and makes it loose. And obviously, pre-counseling, educate the patient, etc., comes into view.
Another thing is that I will advise the patient for primary TB. Only
Primary TB. What do you prefer? Anybody used, somebody said Provox, anybody else has used other than Provox?
I have used Bloomsinger.
Bloomsinger.
I am also using in 90% of my patient Bloomsinger.
Bloomsinger, okay. Anybody for
I'm
Make in
using
India?
OM and have had no problems with that. It's much cheaper also.
Make in India, OM.
Yeah.
Okay. So you should publish a good paper out of that and let us have something coming out from our institute.
As you told, definitely Provox is the preferred one and the gold standard.
Yes.
But think
Okay.
of the financial condition of our patient,
Right,
we are
right.
using the Bloomsinger.
So we'll close with follow-up. So this is the patient, 51 years old male, CA hypopharynx, T4B. You know, patient is on regular follow-up and on follow-up at 3 months interval. In what scenario you will do flexible scopy, rigid scopy or PET scan? Dr. Prem.
In the flexible scopy, whenever patient is presenting with complaints, like say if you're having symptoms or on examination, you want to assess whether there is recurrence or residual, then flexible. If you PET CT is done, whenever you have suspicion in follow-up case, always we do PET CT to know the whether it has spread to other parts of the
Dr.
body.
Sengupta, will you do flexible only in symptomatic cases, or
No,
you
in
like
all
to-
cases.
In all cases.
In all cases when the patient present, that is the primary thing that
So
should be done.
this is one of the office procedures we
Office
must do in all patients. If symptomatic, then we can.
If symptomatic or if suspicious,
So would you
we will
like to do
rigid
rigid
scoping.
first, or first you like to do PET
No,
CT
first.
and then do rigid?
If
So
there
that
is local
appropriate biopsy
recurrence,
can be
if there is a
taken.
local recurrence without any metastatic symptoms, then rigid scopy, and if there are symptoms like back pain or intra-abdominal or any metastatic, then of course PET CT.
Yeah, a lot of individual and institutional protocol has come up where the flexible scopy is a must.
Yeah.
If the patient has got symptom, you're finding something in the flexible endoscopy, what we are doing is we are doing PET scan, and if there is good uptake, at least we take the biopsy from the correct side. So one can, it depends on the availability of PET CT also. So objective is to detect early and at the same time detect secondary, second primaries, evaluate the case. Clinical examination will include this. So thank you very much all the panelists, and thank you West Bengal AOI for arranging this panel discussion. Thank you so much.
Thank you, Colonel B.K. Prasad. Now let me ask him to hand over the awards to the mementos and certificates to the panelists. Dr. Shubroto Mukhopadhyay. Dr. Shukrit Basu. There is one announcement that the Dr. B.K. Roy Chaudhary Consultant Award paper will be held in Hall B from 2 p.m. onwards. Hall B. এখানে হবে না উপরে হবে. We'll now have the panel discussion. Dr. Indranil Pal. Dr. Shubhabroto Sengupta. All the panelists of the debate session, keep yourselves ready and come up to the dais now. Dr. Lieutenant Colonel P.S. Kumar. Dr. Manoj Mukherjee. And now may I request Professor Dr. Shubroto Mukherjee to hand over the memento and certificate to moderator Colonel B.K. Prasad. Now may I request Dr. Arunabha Sengupta. Dr. Arunabha Sengupta, please. Dr. Arunabha Sengupta, please, as chairperson of the next session. Dr. Ajay Malik, moderator of the next session. Dr. Ajay Malik, moderator of the next session. And I'm calling to cut short the time. I'm calling all the panelists. Dr. Tushar Kanti Ghosh, Dr. Shubhendu Kaur, Dr. Shirshak Dotto, Dr. Debjani Ghosh Shrestha, Dr. Shantanu Sit, and Dr. Shoikat Samodar to the dais. Rules and regulations will be conveyed by moderator Dr. Ajay Malik.
টাইমারটা বলে দাও 4 মিনিট
4 minutes
4 মিনিট এই তো অটোমেটিক ওখানে উঠবে আর ক্লিক করে আওয়াজ
click of it, okay. Good afternoon, everybody. Today we have the one of the most important events of any conference, that is the debate competition. Because in this, the speakers are not only experts and stalwarts, but they are also excellent communicators. So, as you all are very familiar with the speakers, I'll just tell them the rules. There will be 3 sets of topics. There will be one speaker who is going to speak for and one will be against. The rules are for the distinguished speakers. That is the time to be strictly maintained. 1 minute, what I'm talking now, 4 minutes will be given to each speaker, of which 3 minutes will be the main topic and 1 minute for a counter approach to whatever the opponent has said. Please restrict your talk since the time is very short. So restrict it to the topic. No need to say, you all are all ladies and a lady and a gentleman that maintain decorum, no personal comments. And I request all the best to the speakers. Unfortunately, I think it's lunchtime, but this is one event where you can learn the pearls of the topics. Okay, in a nutshell, these experts and stalwarts will summarize the whole topic. So keep your eyes and ears open. The first topic is on microscopic thyroid surgery. Dr. Tushar Kanti Ghosh, and against will be Dr. Subhendu Kar. So, you want to speak from here? So we start the first topic, and Dr. Tushar, over to you.
Yes, today the debate is the microscopic thyroid surgery. So my opponent is the Subhendu Kar. Subhendu Kar is very close to me. He was my roommate and mentor also. He's the great surgeon, but I am average surgeon. So if you give me the microscope, then average 2 will be better. I am more confident, about at least 4 times confident if you give me the microscope. So without microscope, sometimes I don't feel that I'm the comfortable surgeon. Okay, then definitely you will laugh. Why microscope? So my opponent or different surgeon told sometimes the microscope required sometimes to see the recurrent lesion nerve. But recurrent lesion nerve only, the only entry point you should look. There is a different code, sometimes different change of situation. So some from skin incision to total dissection, every time if you see the under microscope, there is a lot of change. After skin incision, platysmal level, if you see the under microscope, that will be different look. Vascular nature, loss of blood vessels, loss of blood loss. Blood loss will be very, very less if you see the under microscope. All time if you use the cautery or bipolar also. After that, main point is the from inferior part. Inferior dissection, only not cricothyroid entry point is the most important. Also from lower pole also, if you see the under microscope, sometimes you will automatically see the recurrent lesion nerve all time. And left, right also. And also parathyroid, not only preserve the parathyroid is most important, blood supplies the parathyroid also important. If you are not able to see the sometimes recurrent lesion nerve, in different critical situation. But why the thyroidectomy? Only thyroid, removal of thyroid, preserving the different important structure. So if you see the under microscope, all time all important structure will be preserved. Automatically you will remove the thyroid. So you are sure you will not injure the recurrent lesion nerve anyway. If you are definitely preserve the parathyroid. Also is very important upper pole. Supralaryngeal nerve also is very important. So all are important structure will preserve and you will do thyroid surgery. So Why debate today, this debate? Yeah, I think this debate, no debate is today, the microscopic ear surgery or not microscopic ear surgery. Today's debate, I think no debate is there. So why after 20 years, no debate will be there under microscope or non-microscope? Debate will be there endoscopic surgery of thyroid or microscopic thyroid. So we are basically 20 years back discussing the microscopic thyroid, why not taken for granted like ear surgery? All surgery will be done under a microscope. There is a lot of advantage. If you do the preauricular fistula also under microscope, then there will be a lot of change you will see. So microscopic thyroid is the best.
Time. Thank you. We start with against now.
Hello.
Dr. Subhendu.
My sincere thanks to the organizing committee. And now it is a little difficult to speak against Dr. Tushar Ghosh because he left no stone unturned to prove his point. Now come to the point. There is non-availability, of microscope in the periphery of our country. Our country is a huge country. You can't assess the problem from metro cities like Kolkata, Delhi, Mumbai, etc. So this is the genuine problem. And the second point is hands-eye coordination. That is difficult for non-ENT surgeon. It is not relevant in this August forum, but there also a learning curve for ENT surgeon also. And then next point, the working in the wrong place with higher magnification may looks ANSA or cervical plexus nerve like inferior recurrent nerve. Even working in higher magnification, smaller vessels or tributaries may looks like inferior thyroid artery or middle thyroid vein. And the next point is, it may take increase excess higher magnification may tempted the surgeon for excessive dissection, unnecessary dissection to show their charisma. Dekho bhai ki sundar dissection korechi. And the next point, it increase the time of the surgery, which may increase the stress of the surgeon and anesthetist. And that may leads to musculoskeletal problem of the surgeon. Operation পরে ঘাড়ে ব্যথা করছে, কোমরে ব্যথা করছে, আর anesthetist বলবে next case আছে দাদা ছেড়ে দাও তাড়াতাড়ি. This is the point. And I must mention one study published in the PubMed in 2019 November. Konstantinos clearly described in meta-analysis on some randomized controlled trial published in database in the PubMed. It clearly indicates there is no clear-cut advantage of microscopic thyroidectomy over direct thyroidectomy in case of decreasing recurrent laryngeal nerve injury or transient hypocalcemia. But this is like Indian share market. 2 days fall, next day increase. So next study maybe says something else. That's all.
Thank you. Thank you. Now we have a counter from Dr. Tushar. 1 minute, please.
My learned speaker told the microscope availability. We are born microscopic surgeon because the in ENT department, if you enter the nowadays, so definitely you should microscopic orientation and hand-eye coordination also required because the ear surgery is the main surgery. So without microscope, how it is possible? In district also, number 1 point. And dissection, it is the oriental learning curve. If you do the ear surgery also, why unnecessary you will injure the facial nerve without microscope? Or with microscope, there is a chance of injury? No. That is not. Also, that is I am against it. Dissection also is more comfortable. Time, definitely less time will be required because if you habituated after few surgery is the more comfortable. And my personal belief it is definitely less time. And also parathyroid also 1 point missed. If you injure the parathyroid also, if you see the under microscope, there is a blackish. If you think that there is a chance of loss of parathyroid, then you just incision with blade, knife. Then also advantage of the under microscope.
Thank you. Dr. Subhendu?
Dr. Tushar clearly indicates the advantage of microscopic surgery. But my point, my first point was non-availability of the microscope in the periphery. This is quite impressive in Kolkata, but in that remotest area, there is a very scarcity of the microscope. And the second thing, all surgeons, I mean general surgeons can perform thyroidectomy. So for them, it is difficult for hands-eye coordination. This is the point. And the charismatic surgeon is there, so you know from the different works of also. So my third point was the charisma.
Okay. Thank you. So I think it was a very, very lively and intellectual debate on microscope, use of microscope in thyroid surgery. Sir, just...
Tushar and Subhendu have done a beautiful job, but my point is thyroid is not dominant to ENT surgeon. It is the domain of general surgeon, it is the domain of head and neck surgeon. So domain of an ENT surgeon, that can give rise to a microscopic thyroid surgery. But the domain of a general surgery or head and neck surgery should be done by a naked eye. Number one. Number two, for the recurrent laryngeal nerve, if you, Tushar is telling that for microscope we can have a very good delineation of the recurrent. That can be done by a nerve monitor. We have got nerve monitor. If we touch the nerve monitor with a naked eye, we can see where the recurrent laryngeal nerve is going. So microscope, I think, is not a mandatory for going for a beautiful thyroid surgery. It is the thing which gives a great thing. Have you done that? Sir, will you do my surgery in microscope? Is it a microscopic surgery? They will say, oh, we are doing it in a microscopic. That is only a point for going for microscopic thyroid surgery. My opinion.
Thank you, sir. Thank you for your wisdom.
Surgeon also uses the loop basically. Or loop use kore magnification. So we are comfortable with microscope. So why not use the microscope? They are using the loop basically.
Okay, we are running short of time. Available.
Available.
Hello, but in this debate there is
Sir,
no
this is
no
debate
question
on only
of
microscope.
look,
The classical
no point
thing
of
goes
look
on
in
debate,
this
sir.
debate, sir.
Right, we move to the next topic, endoscopic tympanoplasty. We have two eminent bright speakers, Dr. Shirshak, who is going to speak for, and Dr. Jevjani Ghosh Shrestha, who is going to speak against. So we start with for. Dr. Shirshak, your time starts now.
Good afternoon, respected chairperson and moderator and dignitaries. Coming straight to the point. Nowadays, endoscopic in otological surgery are a milestone in the history of otology. If we see the advantage point by point, the number one, main advantage is very less tissue damage, very small incision, or there is no external incision at all, no place of post-auricular incision at all. So there is less soft tissue handling, less post-operative pain, less operative time, and patient can go home on the very day of the surgery. It can be done daycare. Number two, the view. View of the endoscopic ear surgery is very wide-angled view, wide view, and it can be multi-angled view. It can be angle can be changed. If we use the angled endoscope, it can be further betterment. There can be chance of further betterment. Number three, there is no chance of view hindrance by surgeon's hand or instrument. There is better visualization of the hidden areas of the middle ear, like sinus tympani, like hypotympanum. There is better understanding of the middle ear mucosal folds, which are very important, we are given important nowadays. And mucosal folds can be preserved to some extent by using endoscopic in ear surgery. Now, simply moving closer and simply moving closer the hand, you can enlarge the view, you can magnify the view. No need of repeated adjustment of the microscope focus. Now, next, limited attic cholesteatoma. Limited attic cholesteatoma is a very good situation where endoscopic sinus surgery, endoscopic ear surgery can be done with very minimum curettage, very minimum tissue damage, and attic or scutum is fall in the direct axis of the external auditory canal. So we can reach the attic directly through the external auditory canal without any incision. For anterior perforation in tympanoplasty, high-point tympanoplasty or myringoplasty, anterior perforation, where anterior margin is in many time cannot be seen in microscope without canalplasty, but in endoscope without canalplasty we can see the anterior margin, we can ensure the anterior tucking without any bone work. Now, if we see the literature for result, with all these advantages, results are almost similar. There is no statistical difference in result of, in terms of disease clearance, in terms of graft taking, terms of...
Please finish. Thank
and
you.
in terms of hearing outcome.
Okay, thank you. Over to Dr. Devjan, who is going to speak against the use of endoscope in tympanoplastics.
Good afternoon, respected chairperson, sir, moderator, sir, eminent delegates, and my worthy opponent. So today's debate is on endoscopic tympanoplasty, and I'm going strictly against the motion. So ever since the microscope was introduced in ear surgery in 1921, it has been the favorite tool of all otologists. It is a time-tested tool, and it has proved its worth. So why is the microscope a better tool for tympanoplasty than the endoscope? Firstly, because microscopic ear surgery is very comfortable and easy. The surgeon has both his hands free, unlike the endoscope, where the scope has to be held with one hand and the instruments have to be used with the other. This is very important when we are especially lifting the tympanomeatal flap, or we are placing the graft, or when there's a brisk bleeding and we want to use the suction with one hand and operate simultaneously with the other. So endoscopic tympanoplasty is much more cumbersome than microscopic tympanoplasty. Secondly, the microscope gives us a binocular vision, unlike the endoscope, which gives us a monocular vision. So depth perception is always better with a microscope. Again, very important when we are working at the depth of the middle ear, or we want to ascertain where the margins of the perforation are in contact with the graft, or for the beginners as well. Thirdly, in microscopic surgery, instrumentation is much more easier. The field does not get obscured by a brisk bleeding or fogging like that with the endoscope, where the instrument has to be moved in and out repeatedly, anti-fogging solution has to be used, or the limiting factor of an endoscopic surgery is the size and diameter of the ear canal, where manipulation of the instruments might become a problem, which is not there with a microscope. Fourthly, microscopic ear surgery is very safe. That is because there is no chance of thermal damage which occurs due to overheating of the scope, which again depends on the length of the scope used, the diameter of the scope, the power settings, the kind of light, and how close we are to the structures of the middle ear. Also, there's no chance of inadvertent damage to the ossicular chain or to other structures of the middle ear due to an inadvertent movement or sudden movement of the scope inside the ear canal. And finally, we will all admit that the learning curve in an endoscopic surgery is much more steeper than that in a microscopic surgery, especially because we otologists are first trained with the microscope, and often the transition also might prove to be difficult. So this is, with this I will conclude that the endoscope is still a complement to the microscope. When we join both the techniques, we can extend the surgical boundaries, but the scope has a long way to go before it takes up the position of the microscope. Thank you.
Very nice. Now, for the counter, the counter is what your opponent had said. You have to only counter that. You cannot add on to your points in this, okay? So, we'll just give you the time. Your time starts now.
I'm starting with the learning curve. Every surgery have learning curve. Okay, if we start with the simple procedure like diagnostic autoendoscopy, then grommet, then type 1 tympanoplasty, then mastoid surgery, learning curve will be very, very good. Number 2, there is a thermal damage. It is a problem with the xenon bulb, but LED bulb, tip of the endoscope rarely produce much heat. Inadvertent damage of the structure, 4 millimeter endoscope rarely causes damage. It is a problem with the smaller, thinner endoscope, 2.8. Number 4, the two-handed technique. In endoscopic sinus, endoscopic otological surgery, there is very minimum need of repeated suction and control of bleeding. And that is use of neurosurgical patty and use of intermittent irrigation. It can well control the bleeding.
Thank you. Thank you, Dr. Shirshak. I mean, that is exactly how a debate goes, where you just counter the points of the opponent. Okay, now we start with Dr. Devjani to counter what
So my
Shirshak
worthy
said.
opponent said that endoscopic tympanoplasty can be done on a daycare basis and the operative time is faster. So even microscopic tympanoplasty, they are all done on a daycare basis nowadays. Exposure to anesthesia is also very less because they are done under local anesthesia. If there's an indication of general anesthesia, it will be applicable to endoscopic surgery as well. Also, my opponent is very much aware that there are transcanal and endoral techniques. So over where the scar is very good. In microscopic surgery, even if we use a postoral technique, after 6 months, we all know that the scar is hardly visible. So cosmesis is again not a very comparable basis for this two procedures. He has admitted himself that the operative outcome of the two surgeries are the same. So technically, we can say that when we compare both the procedures, other than the fact that you can look into the nooks and corners of the middle ear with the scope, there is no practical advantage of the instrument. Rather, a microscope is always a better option because it doesn't have the negative points which I've mentioned.
Thank you,
Thank
Devjani.
you.
Now, hand over to the chairperson for his words of wisdom.
No, Srishak and Debjani have narrated beautifully their topic for and against. We, the old person, Dulalla, Oinda, are best in microscope because we are not concerned about the endoscope. Because we are becoming, and for the new generation, endoscope is become very popular. One point, the hidden area, if a cholesteatoma is in the facial recess or in the sinus tympani, it can be very good manipulated with endoscope. But what Debjani said about the heat, we have done plenty of studies where the heat causes plenty of hearing damage, the shock, and Debjani's point is very good because both hands are free, one can good casually with the microscope. But with endoscope, we have to be very much particular and the time need for one hand operation, and that will give rise to a expedite opinion. We have to do the operation on and on, then it will be very much experience with going for endoscopic tympanoplasty. But the future is endoscopic tympanoplasty as is going on. Thank you.
Absolutely, sir. The future is endoscope and how we improve the endoscope to overcome its shortcomings. Okay, now we move to the third topic since time is short. The topic is cartilage graft for tympanoplasty. It was briefly covered in the earlier one of the sessions. We have the young duo in this group, that is Saikat Samadhar and against is Shantanu Seth. So I'd request Dr. Saikat to start. Your time starts now.
Good afternoon, respected chairperson, sir, moderator, sir, my co-panelists and delegates. The next time you will enter the operating room, you will ask for not one, but a pair of surgical blades. To tell you why, I shall speak for the motion on the topic cartilage graft for tympanoplasty. It was in 1952 that Woolsten and Zollinger described the surgical technique of tympanoplasty with use of epidermal grafts. Later, fascia came, perichondrium came. But it took around 11 years to devise a more robust material, that is cartilage, and it was done by Salen and Jansen. So why was the need for a more robust material? The basic things lies in the pathophysiology of COM. Actually, the eustachian tube dysfunction is the main pathophysiology of COM. But instead of treating the cause, we treat the effect. So the cause always persists. To deal with this, we need a more robust graft, that is a cartilage. So what advantage that cartilage give? The cartilage is a very robust and tensile structure. It has got a long-term survival. It prevents retraction, neotium perforation. The graft uptake rate is around 96 to 100% according to world literature. As compared to temporalis fascia, the graft uptake rate in temporalis fascia is 86 to 95%. So it is very high with the cartilage. The cartilage can be sculpted to fit the shape of the pars tensa defect and even bony defects. The cartilage are available from the same surgical field in quantities which is enormous, even in revision cases. Now everyone will tell what about the functional outcome. I would like to cite a few landmark articles published in world literature. The first one is by Garber et al., a review article published in Laryngoscope in 1994, and I would quote the article. it is reasonable to expect that replacing a large perforation in the tympanic membrane with cartilage would affect the individual frequencies. Although a tendency for better airborne gap closure was seen at 500 Hz with use of cartilage. Another doyen in otology, Dr. Donhofer, published a review article in 2006 in which he writes, and here I quote, "Although one might anticipate a significant conductive hearing loss with cartilage, owing to its thickness and rigidity, studies have reported results to its contrary." Muhammad et al. In a systematic review and meta-analysis published in Journal of Otology and Neurotology in 2012 has said both cartilage and fascia used in tympanic membrane grafting gives equal and comparable results. Now I would like to add one more point, that is endoscopic tympanoplasty. In endoscopic tympanoplasty, as it is a one-hand instrumentation procedure, handling a temporalis fascia graft is difficult.
The time is up. Thank you. Now, Dr. Shantanu, if you can speak against the topic.
Good afternoon to my respected chairperson, moderator sir, and delegates in the auditorium. I am against the use of cartilage tympanoplasty, but I am not fully against it. I am against implementing cartilage in everywhere in tympanoplasty. There is a role in, there is a negative, to prevent the negative pressure, cartilage has always a role, and even construction of atticoantrostomy, there is also a role. And even interposition cartilage tympanoplasty also has a role. But except this, the cartilage does not have proven himself in all setup tympanoplasty. I can state, as my co-opponent has stated, there is papers regarding the good conductive outcome. There is also papers regarding bad conductive outcomes. And we can state a 2004 a model described by Desdens where the thicker the graph, the hearing improvement will be less, the vibration will be less, is been stated, and it has been seen in more 500 and 1000 Hertz frequencies, but it is equivalent in higher frequencies. So the thinner is the graft, will be the more vibration. So implementing this thing, we have many techniques to try to thinner the graft in doing the tympanoplasty. In trying to do that, what we are doing is that we are coiling the cartilage. Everybody has experienced that when we are trying to thin the cartilage, the coiling effect starts and the graft is not properly able to place underlay or even in the onlay technique of cartilage tympanoplasty. And the second point is that it is technically difficult. It is time consuming and required precision. Like when we are doing the palisade type of cartilage tympanoplasty, the placement of architrave and simmering is very difficult. And if we place the two palisades, there is a gap between more than 1 millimeter, there is always a chance of retraction. If the displaced cartilage is placed under the tympanic cavity, there is again the chance of retraction is there. The pocket formation is there. So in a long run, they were questionable. And second thing is that mucoperichondrium layer is actually supposed to give the nutrition to the cartilage. But if we have the study for around 8 years, 10 years, there is a definite role of degeneration of cartilage. We can prove by a stated journal in Hattari 2006, he has proved that whatever the cartilage removed from the re-exploration of the tympanic membrane, there is definite loss of chondrocytes, there is a dry atrophies there, and these changes in the posture and the size of the cartilage leads to long-term effect. So we don't have the study to say that after 10 years, after 15 years, what happening to this cartilage. And that is what to be needed to explore. And till then, we don't know what is the ultimate hearing improvement we can give for a long run. And one thing is a very minor thing, but it is very important because the mucosal, okay.
Just conclude that line.
Okay. The mucosal lining, which is generating underlining the cartilage, is also questionable. We don't know the mucosal is growing below the cartilage or not in specifically underlay technique of cartilage tympanoplasty.
Okay, point taken. Dr. Saikat?
Thank you, sir. I would like to just address a few points. First one is thicker graft. For that reason only I told you will need two pair of sharp surgical blades. Then coiling. Coiling basically depends on what site, from which side you are harvesting the cartilage. A tragal cartilage would not coil that much and it can be readily used. technicality. Technicality is easy because placing a temporalis fascia graft is far difficult than placing a cartilage. If you use a cartilage, you can place it very easily, specifically in endoscopic tympanoplasty. You place a cartilage very easily, and use of cartilage in endoscopic tympanoplasty is a well accepted procedure as of now. Second, degeneration. It has been repeatedly noted in various studies that degeneration occurs in very few chondrocytes, and that cannot account for a cartilage loss. Actually, the cartilage stays for quite a longer period and can provide stability to the grafted drum. Third is acceptability in all the procedures, or applicability in wide range of procedures. Cartilage more acceptable and more applicable in wider array of procedures. And I would by saying cartilage has predictable long-term results with low complication and wider acceptability.
Thank you. Dr. Shantanu, any counter?
Regarding consistency, there is stated that when you put the cartilage columnar strut, it has been seen it being spaced more. The reason behind that is it became shorter, distorted, and that's why the patients who has gone for the struts or columella need to re-explain. So this is actually stating that consistency changes. And as I first stated that this is not required to do in every patient. You need to do cartilage tympanoplasty because it is a versatile graft we can modify, and what I want to say it is we should use it but selectively.
Thank you. I think we'll first request the chairperson to give his words of wisdom on this topic, and then finally we'll do it on the conclude.
Thank you very much. Soikot is my student. He is working under me in SSKM Hospital, and Shantanu is also my student. They have done a beautiful narration here, but in an undergraduate study, we asked the student, which graft do you prefer? They said temporalis first. Then why? Easily accessible, pliable, low basal metabolic rate. But cartilage basal metabolic rate is not so low, Soikot, and the basal metabolic is much higher, and is not pliable, just like temporalis fascia.
Yes.
Temporalis is much more pliable. Yes, cartilage can be used when you are doing a record case of tympanoplasty, which is a very good sign, because for a failure case of temporal fascia, you can't get a temporal fascia, and the cartilage rate after the recurrent case is very good. So both the speakers have narrated very nicely. I thank my students for doing a beautiful narration here. All other students are my students. They have done a beautiful narration. I am very grateful. They know the subject very well, more than us. So I am very grateful to them. And also, he is my very good colleague, and he will narrate the whole thing now.
Thank you, sir. I think all the three topics were very well covered by the stalwarts and experts, and I congratulate AOI West Bengal for selecting these kind of fantastic professionals. They stuck. What was interesting, they stuck to the points given to them, and the words of wisdom from the chairperson was also very well taken. I think this is a most sought after topic, the debate, and I see a very bright future for such competitions. Thank you.
Thank you, Dr. Ajay Malik. Thank you, Dr. Ajay Malik. Now, may I request Dr. Ornav Sengupta to hand over the certificates and memento to the panelists. First, we start with Tushar Kanti Ghosh. Dr. Shuvendu Kaur. Dr. Debjani Ghosh Shrestha. Dr. Shirshak Datta. Dr. Shoikat Shomaddar. Dr. Shantanu Seth. এখন সৈকতকে দেবে হ্যাঁ Dr. Shantanu Seth. May I now request Dr. Ornav Sengupta to hand over the memento and certificate to our moderator, Dr. Ajay Malik, please. May I request Dr. Ajay Malik to hand over the memento and certificate to our chairperson, Professor Ornav Sengupta, please. There is one announcement. The winners of all the programs like Major K.K. Ghosh Award, Dr. B.K. Rai Chaudhary Award, and the e-poster, etc., will be announced during the valedictory session. Thank you all. And next session will be the Words of Wisdom, will be conducted by Dr. Shomendranath Bandyopadhyay. The chairpersons are Dr. Shantanu Banerjee, Dr. A.M. Shah, Dr. D.N. Chatterjee. All our seniors are requested to come to the dais, please.
So our next session is on Pearls of Wisdom. So I'd request Professor B.K. Rai Chaudhary to kindly take stage. This will be an interesting session. The speakers are the teachers of the teachers, and they will speak from their decades-long association with otolaryngology, and it will be chaired by also the teachers of the teachers, and I will ask Dr. Shantanu Banerjee, Dr. A.M. Shah, and Dr. D.N. Chatterjee to kindly chair the session. Sir, now I would ask the chairpersons to take charge of the session. Sir, Dr. Shah.
Thank you, everybody. Please be seated. Now, hello. Now we are starting a very interesting topic, and today, and we are here to listen from the teacher of teachers, their long association with the specialty and the fraternity, and they will say something which is not even written in the book, but they are saying will be the word of Bible. With these few words, I request Professor Dr. B.K. Rai Chaudhary to give his deliberation, and Dr. Shantanu Banerjee will say the concluding words.
Good afternoon, all of you. My task is to tell something about my wisdom, having a long experience of 62 years practicing the ENT. Since 1960, today is 2022. These are my credentials. and not necessary to go in details. In the beginning, I must say that when I joined in the ENT department in the year 1960, after passing MBBS, the task was doing outdoor job for 6 months, making tickets and preparing the tickets for different teachers to see the patients and teach the students. And for 6 months I had to do that in the OPD and not allowed to go to wards and ENT OT for 6 months. Then after 6 months, I was told to go to the ward and OT and to start assisting the seniors there. Now about the cases. What are the cases we used to perform in the OT? There were 2 things to write by ourselves, by house surgeons, sitting with the bosses there in the OPD, that tonsillectomy followed by intranasal antrostomy, or intranasal antrostomy followed by tonsillectomy. These are the very common advices I used to give. And in one OT, actually, we used to perform 8 to 10 patients of tonsillectomies, which you cannot think of today. I don't have any time to do also for tonsillectomies nowadays. So that is the way how we started our training in ENT, in the ENT department. I don't know in other department, in other medical colleges. And at that time only 4 medical colleges in Kolkata and 2 medical colleges in suburbs or districts. And after some time 1 medical college is added. So altogether, for years together, there were only 5 or 6 medical colleges. So, in this way, starting the career and coming to this stage, teaching students in the year 2022, really a tough job. Because at that time, there were no CT, there was no MRI, there were no other investigations available, not even audiometry, tympanometry were available in the department. So that was the situation and at that particular period of time. So after that, days goes on, years go on, we started learning, we started teaching, and I was made junior teacher as clinical tutor in the year 62, 1st April 1962. So since then I am teaching the students, and as a junior teacher, then learning things. At that time the X-rays are only conventional X-rays. There were no digital X-rays, there was no MRI, no CT, no audiometry, nothing was there. So in this way we went on, and after some time the day came when I was associated with the association, and my association with our AOI West Bengal started very, what shall I say, happily, in the sense, after passing MS from All India Institute of Medical Sciences, New Delhi, because I will have to say New Delhi nowadays, previously it was not necessary, as because in all the states you are having aims, naturally you will have to write where from you have passed. So after passing and coming back to Kolkata again, joining as shall I say, the clinical tutor, then what happened, in one of the association meeting, we were there only few members, 50, 60 members were there. Nowadays we are having about 400 members, I think. So After coming from Delhi, when I went for attending the meeting there in our association meeting, and none other than Dr. Amitav Roy, he proposed my name to join the executive committee as treasurer. So at that time there was no election. Only there was selection, and I made the treasurer of the association in the year 1967. So in that way I went on. Then after that, one day I became what shall I say? President of All India Association. So this is the medallion you are seeing in the screen. That is the medallion of President of Association of Otolaryngologists of India, which I was elected in 2006. So by the time actually we got, after passing from AIMS, even then we had only conventional X-rays. No CT, no MRI was there. But audiological section was there, and other sections were all was there, including verticology and other. After that, again, this picture you are seeing, the people are sitting in the dais, and along with them I am also there, and this is the picture you are seeing, Dr. our most dynamic secretary, the then secretary, Hattolo. So, তখন ও আমাদের দৈপায়ন, একটু বাংলায় বলি, দৈপায়ন তখন জাস্ট সেক্রেটারি হয়েছে এবং তখনই ও ডাইনামিক্স ছিল. So this was the committee formed for organizing the All India conference, which was held at Science City. So, and I was the chairman of this committee. So that's why I am to show this. And Dulal is here, Ohin is here, everybody is here. You can understand everything. See, you know everybody. Then actually I started microsurgery, I started other surgeries, and I started endoscopic surgeries and so on and so forth. So in fact, of people of those age, আমাদের এগুলো শিখতে হয়েছে, যত পড়াতে হয়েছে তত শিখতে হয়েছে নতুন করে, আমাদের কেউ শেখায়নি. ন্যাচারালি সিটি স্ক্যান আমরা জানতাম না, ডিজিটাল এক্সরে কি জানতাম না. So many things we had to learn because we were in teaching profession. So this is the picture you are seeing. I had been to Dhaka as an international faculty for conducting the micro-ear surgery workshop. That was probably in 2018. So you are seeing along with me the other stalwarts like tell the name. Hey, Doipayan, either naam bolo. One is from Hyderabad, Ayla Shami and Raju. So Ayla Shami from Madras and Raju from Hyderabad. Yeah. So in that way I started my career, and this is the picture you are seeing, that I was participating in one of the webinars which was held recently in 2018. So physical and mental alertness. To learn all these things, you must need physical and mental alertness. So this picture is to show how I am actually holding this live tiger. This is the picture you are seeing in Lataguri, which was our association, state association, held in the year 2018 with my few, what shall I say, few members which are very near to us, very close to us, and close friends. So you can see here one of the past presidents and other members of the association. Then one fine morning, I thought that why I'm not to do cochlear implant surgery. So I started cochlear implant surgery in the year 2005. And my mentor was none other than Dr. Kameswaran. Mohan Kameswaran, I think you know him. He was sent by Cochlear Company to help me to do this surgery. When he actually came to my institution, when I was there at BIMS as head of the department, and I told him that you just stand here and let me do. And I started that operation, and he was helping me because I was new for the first case I was doing. So that is the way I started. And cochlear implant surgery, when I started after doing also 20, 25, 26 cases, in the year 2019, in July, you have heard Dr. Parma here talking on cochlear implants. In one fine morning, I got the WhatsApp from him that, sir, what is the difference you get in adult cochlear implant with the children? In fact, I don't find any difference between the adult and children. Only difficulty is the structures is smaller in children, and otherwise there is no difficulty and no difference. The next point was, he asked that, good morning, sir. Thanks for your valuable advice. If postlingual patient, how much maximum gap is ideal for considering them for CI, cochlear implant? In fact, when a patient becomes profoundly deaf, having a vocabulary, because it is postlingual, so in that case, whenever patient wants, you can go for the surgery. That was my answer. Now I know one case, I will show you, who was operated on at the age of 75 years. And why? He was profoundly deaf by presbyacusis, and he was a multimillionaire, and he had none other anybody to look after his business and his money. Naturally, he wanted that I will have to manage my own property by myself. If I can't hear, how can I do that? Naturally, in that case, we have to do cochlear implantation at the age of 75 years. So one fine morning, I got one appreciation from my first patient, which I did in 2005, and that too after 15 years. That girl became at that time admitted in class 11, class 12. So she has become nearly much older, and I did cochlear implant surgery on her at her age of 4 years. So she written this in my favor. Tomar hate dibbo chhoai shunte pelo Rimi. Or patient naam chilo Rimi. তোমার কাছে আমরা দুজন থাকবো চিরঋণী, বধিরতা সঙ্গে নিয়ে জন্মেছিল ঘরে, শব্দ তুমি ফিরিয়ে দিলে ককলিয়ার করে, মেয়ের মুখে ফুটেছে কথা, ফুরেছে পুড়েছে মানুষ কাম সূর্যের মতো আমার থাকুক বারিন বাবুর নাম. So that was the appreciation I got. Then regarding adult postlingual cochlear implantation, this is one of my patients, Mr. Sanjit. He was bank employer. At the age of his 40-45, he was profoundly deaf. So he approached me and came to my department, and we actually, after examining him, that we thought that we should go for, he also wanted to get it done, and we did cochlear implant surgery in him. Only few years back, that was in the year, say, 2010 or something like that. Then he came after 10 years to me for examination, for re-examination, and he is still very fine. He can hear everything, and he has retired from his service. So that is the way how you can do good job for the people, those even with postlingual patients. Now, this is my last point. When I started the first workshop in the year 1995, at that time I was the president of this association, and that too I became president, or I was elected president 20 years after my secretaryship, which was in 1975. So anyway, that is not important. The important thing is to say that at that time, Dr. Anirban Vishwas, he was the secretary, and he was interested to have some workshop. And he requested me, sir, why don't you arrange a workshop in your institution? I was at that time I was head of the department at VIMS. I accepted that. Next day when I went for executive meeting in our office, that was in the Creek Row at that time, Anirban said me, sir, have you heard that there is some of your students, one of your students, আমার এক ছাত্র, he was head of the department at that time in one of the Kolkata institutions. কি বলেছিল জানো তো? বলেছিল যে গাউজার হ্যামার দিয়ে স্যার কি ওয়ার্কশপ করবেন, মাইক্রোসার্জারি ওয়ার্কশপ? তো আমি তখন ওকে বলেছিলাম যে এই কথাটা বলেছে সে স্যার দিয়ে শুরু করা ঠিক ছিল না। ও আমাকে স্যার বলার তার কোনো অধিকার নেই। ও যখন আমাকে দেখেছিল অ্যাজ হাউস স্টাফ, yes, really I used to do, because there was no microscope, there was no drill available at that time. So I had to do with gauze and hammer, and many of my students, they saw me to do mastoidectomies with gauze and hammer. And he also saw me at that stage, and he thought that I am still in that stage. And I told you that I'm learning, but you have to learn, because you have to teach and you have to learn. And by that time I became actually using the bars for 15 years. And he never knew that. So that's why I have written this here, this slide. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Param Brahma, Tasmai Sri Guruve Namo. This all of you know. And in this, actually, I mean to say, without knowing fully some person, you should not comment. And so much so that he was house surgeon with me for 2 years. And what is the audacity he has to say publicly to a person, the sir, Gauss Hamad diye workshop korben. So I showed him my abilities. That's at that time also I could do, practically I could play in the middle ear with the drills. So Dr. P.K. Khasnavish, you heard, under his name there is award also. Dr. P.K. Khasnavis was my first guru, and still I respect him. He was like my father actually. In fact, under his training, I got impetus to come to otology rather, mainly. So I think this is the good time, good period to remember him with this lecture of wisdom of mind. And with this word, I like to conclude my lecture. That is, Amar bhitore bahire, অন্তরে অন্তরে আছো তুমি হৃদয় জুড়ে. So I give respect to my teacher, to my guru, Dr. P.K. Khasnavis, and those who all, so there are so many who actually helped me to grow day by day and to learn things, to learn microsurgery, to learn other, to learn the art of using drills and all those, everything. So I respect all of them, and I request all of you, don't go beyond your capacity. You see? And if you say that, and somebody, you may not show me the respect, but he cannot show disrespect to me. Or if you say that, you should not call sir. Sir means what? Sir means, so you have got no right to call me sir, you see. So already I told that, naturally I am very much hurt at that time. That was in 1995, I still remember that. So with these few words, I thank you very much for giving me a patient hearing. Thank you so much.
Sir, I would ask, I request the chairpersons to say a few words. Sir, we also want to know about your wisdom.
আমি কি বলবো, আমি এখান থেকে বলবো, ওখানে কি বলবো?
না, ওখানে বলবো।
ওখানে গিয়েও বলতে পারি। I believe all of you are very hungry now, as I am, and all of us. We are hungry and we should go for good food. They have arranged for all of us. And now I have come over here, never knew that at this age, someday, I shall be on the dais to say something to my juniors. It is a surprise for me that association still remembering us, calling us to say something to you all. And I am convinced about one thing, that word of wisdom, meaning the persons who will speak, he must have enough wisdom in him. But at the moment, I have lost all my wisdom. I am 86 years old now. I do not know what I used to know in my past. What I used to know in my past. How I have worked all throughout this way to come to this stage, to become a household name in West Bengal. I do not know. I thank all of them, those who are instrumental to bring to me to this stage of my life. But I know it very well that wisdom is more in you now and not in me. I am far less wise than what you all are now in this. But sometimes, like a spark, few occasions, should I say, peep into my memory, and I speak to them in front of you just for 2-3 minutes. Look, while we started ENT in Kolkata, first thing, we used to see patients using the sun rays coming through the windows. Believe me, believe me, believe me. And only one head mirror and sun rays coming from through the windows, and we used to see our patients here, nose and throat, using that sun rays. And in rainy days, winter days, cloudy days, we could not see anything inside our ear, nose and throat. And our teachers mostly were too old to demonstrate us some surgery or to teach us something new. Nothing new. It was a primitive time in our childhood days while we were learning ENT from in this city. How it came up to this? Today I am surprised to see the knowledge of my student, and that is my words of wisdom. And wisdom never stay in the same time, same place. It shifts from here to another. What was their wisdom, we call it, that our teachers and we say in past we are very wise people, but today we feel that we are the most not at all knowledgeable persons. And now we are backward, as you say. We were simply foolish. ENT foolish people. We were not ENT specialists. That's how we started. But still then, people used to love us. Still then, people never thought of beating a doctor. It is surprising that today's students and doctors and specialists, they know so much of their subject, but the patients ran behind them to beat them. Is a matter of sorry. Why it has happened so? Somehow, so far I have said that we were primitive age people. At that time there was nothing special, but still then we used to do some surgery, we used to do something which used to help people, I do not know how they became all right at that time, how our patients became all right. We did nothing. One injection was there, crystalline penicillin. Another one, streptomycin and penicillin. And there are many patients we have seen dying of taking a crystalline penicillin out of anaphylactic shock. We have seen it. We have lost so many patients. There is a very, very wise gynecologist. In his book, preface, he wrote, I do not remember the patients I have cured. I only remember those I have lost. I have lost. This is the wise wisdom of a person, Dr. Markle. He is a gynecologist of UK. It is a quotation from his preface. And I tell you how ENT has come up to this stage now in Calcutta, in West Bengal. Few people went out of Calcutta, like Barin Roy Chaudhary. He went out of Calcutta. He knew that if I am staying in Calcutta, I will not learn anything. Yes, we give our pranam to our teachers, but he had to leave his teacher. Why? To get more teachers somewhere else in this India and to learn more. And what more? To bring knowledge where it was there, in New Delhi, in Bombay, and in so many places. I know many, many people in our contemporary. They used to go to some other places. There is no MS in Calcutta University. There is no DLO in Calcutta University. It started in 1963, if I am not wrong. 62. DLO. And I am the first batch student of Calcutta University. First batch MA student of Calcutta University. MS came in Calcutta University long after other universities of India. Long after. There was no DLO, no MS. We were the first batch student. I am one of them. And most of my friends, they all have died. Sorry. I remember them. Those who helped these teachers to start experimentally DLO and MS in Calcutta. And I am one of the victims of that DLO MS of Calcutta. None to teach us, none to show us any advanced operation, none to give us any good advice, none to tell us, go to UK, go to America and see how they are doing. You have to go. No teachers, because teachers have never seen UK, most of them, only one or two. He is hungry. He is requesting me to stop. Should I stop? Before that, I went to learn mostly from outside West Bengal. Mostly from outside. And they asked me, why you have come here? I said, to beg knowledge from you people. And those who have taught me at that time, they are far junior to me. And they are doing so excellent job. I have learned and I remember all of them and I consider all of them as my teacher. What a great workshop I have seen in Bombay, in Delhi and in many other places. From there, I stayed in a Pice hotel. Remember, 50 rupees per day per bed. In those hotels, we had to stay for 10, 15 days to see how those people in Bombay and Delhi and many other places work. I learned from them. Thereafter I came, like me, like Badin and many others, those who brought ENT, modern ENT, from other places in Calcutta. We have percolated this modern ENT in West Bengal. Yes, I am proud to say that there was no modern ENT in West Bengal. We are the primitive people few, those who brought the modern ENT in West Bengal. Modern ENT in West Bengal. Thereafter, as we went on going to some other places, আমাদের চোখ খুলে গেল. Oh, this is to be learned. এইভাবে শিখতে হবে, এইগুলো শিখতে হবে. And we got chance to go to abroad. I went to America, Hausian Institute, and in Hausian Institute I saw what is modern ENT. I go to many other places in India, many other provinces to learn what is modern ENT. And Hausian Institute, Dr. House, who was the founder of that particular institute. If possible, you must go and see this institute. And there I stayed for few weeks and learned modern ENT from them. Thereafter, at the end of the game, I saw that I have learned nothing. Because we had not enough training to learn things from them. We are so poor. And the last concluding day of our stay in Hausian Institute, I thought of going desperately to say thank you to William House, who is the founder of that particular hospital.
No, William was not Howard.
Howard House, maybe. And his son was also working while I was in Hausian Institute. His son was working with us. John House. And thereafter I went to Dr. House's home. It was not his home, it was his chamber. He was then 84. I am now 86. So what happened? I went to him Who are you, please? He asked me. I said, I'm a student of yours. Is it? From where you are coming? From India. Oh, really? Sit down. What do you want me to do? Sir, only one thing. You give me a massage, any massage, carry home message. I am going back home, India only tomorrow. Tomorrow morning, I have my flight. Is it so? Sit down, my boy. He immediately took a piece of paper and wrote only few lines. Gave it to me without going into any deep thinking or any exercises. He wrote, Dear doctor, please give that treatment to your patient what you think best for your nearest. Should I repeat? Give that treatment to your patient what you think best for your nearest. And take that amount of money from him what you yourself do not feel hard to pay another doctor for the same ailment. Should I repeat? Pay that amount of money from your patient what you yourself do not feel hard to pay another doctor for the same ailment. He is a person in richest country of the world, America. And his philosophy was like this. I wrote it. Thereafter I cried in front of him. He said, my son, go back home. So I wrote a big placard. Take that amount of money from my patients, what you do not feel hard to pay another doctor for the same ailment. And it was walled up in my chamber. I still remember William House's advice and still carrying his order. I am in Woodlands Nursing Home, chief of the ENT department. People say, I do not know. I am say the servant of the ENT department. And I say always that do something good to your patient. In this COVID situation, most of the doctors, my student, they have increased their fees double. Only man taking the lowest fees in Woodlands Nursing Home, still dead. And Woodlands Nursing Home requesting me to increase your fees, sir. You are the senior most doctor in this institution. Why your fees should be so less? Remain less. This is my worst of it. You remain in a low position so that one day you will get a great position. Thank you very much.
Sir, we are grateful for your sharing your thoughts with us. I am sorry to inform you that we will not be able to hear from Professor Nirmala Mujumdar, as he had to leave to attend some emergencies, medical emergencies that are developed in some of his relatives. So I think we will conclude this session. I would request the chairpersons to hand over the memento and the certificate of appreciation to Professor Rai Chaudhuri.
এটা আমি নেব?
না না, এটা স্যারকে দিতে হবে।
ও আচ্ছা।
স্যার আপনি
হ্যাঁ?
স্যারকে দিতে হবে।
আর কোথায় রাখবো?
May I request Professor May I request Professor Barina Raju to hand over to Professor Shantanu Banerjee, sir. May I request To Dr. A.M. Saha, please. Sir, what are you? Okay. आगे दीदी का गया ऑडियो दीदी तो डॉक्टर D.N. चैटर्जी सर सर की बोल रहे हैं
বলার কিছুই নেই যে আজকে বাংলায় বলি যে নির্মলতা চলে গেল বোধহয় এমার্জেন্সির জন্যে সেই জন্যে একটু দুঃখ লাগছে কারণ বহু পুরনো লোক বললে পরে আরও খুশি হতো কলকাতা শহরে MS এসছে দেরিতে প্রথম ব্যাচে আমিও সিলেক্টেড হয়েছিলাম কিন্তু তারপরে চণ্ডীগড়ে পাওয়ার পরে চলে যাই হয়তো আমার জীবনটা ওখান থেকে একটু মন নিয়ে বোধহয় মঙ্গলই করে দিয়েছিল এখানে না থেকে যেটা শান্তনুদা দুঃখ করলো যে এখানে থেকে আমি নষ্ট হয়েছিলাম কিন্তু সেটা আমাদের বাইরে যে ওই দুঃখটা মিটে গিয়েছিল কারণ পৃথিবীটা অনেক বড় দেখেছিলাম এবং দেখে ফিরে এসে আমাদের পরের জেনারেশনকে আমরা সেইভাবে দেখেছিলাম তা আমাদের ইন্দ্রনাথ আছে একজন যারা দেখেছিল যে ফিরে আসার পরেও একটা ভবিষ্যৎ আছে এবং ওরা আমাদের দেখেই হয়তো ENTতে দৌড়ে এসেছিল ধন্যবাদ
Now we will be having our ENT quiz session. Final round. There will be 5 teams with 2 participants each in each team.
Hello. So the final session is the final round of our quiz. Huh? So in team 1, Dr. Reshma Banu with Dr. Tidasha Pakira. Hattol, estis. Toro ye koi? Okay, dak. हाँ In the next team, Dr. Shriya Shina and Dr. Jaya Bhaskar J. The third team is Dr. Pritha Chatterjee and Dr. Shaya Chatterjee. Fourth one is Dr. Ambli Shahadev and Dr. Surjana Vishwas. At last though. And the last team is Dr. Gunjan and Dr. Yamuna. Acha, we have our quiz master, the winners of the last year quiz competition, Dr. Dipanjan Chakraborty, Dr. Sujosh. Olokundu will be there to assist them, and I myself is I will be there in the final round, in the buzzer round. ঠিক আছে চলে আচ্ছা সব টিমগুলোকে ডেকে নিছি তো চলে all the contestants are requested to come up, have their seats, come up on the stage and have their seats quickly. আচ্ছা কুইজটা করতে বল
First team, Dr. Reshma Banu and Titasha Pakira. Over here. Next one, Sriya Sinha and Jaya Bhaskar. Over here. Pritha Shah. Next, Ambili Sahadevan and Surjana Vishwas. Over there. And Gunjan and Yamuna.
Audio আছে নাকি? audio নেই। Good afternoon, respected delegates. With your permission, we would like to start now. Start the quiz, sir.
Tanmay.
এইসব নিয়ে হট করে ল্যাপটপ অফ হয়ে গেলে মুশকিল। দেখা তো নিয়েছে কি না, নিয়েছে।
এরকম করছিস কেন ভাই? এরকম কেন করছিস? কি করেছ?
So then we'll start now. Yeah. We'll start by introducing the teams. We'll go clockwise as A, B, C, D, and E. So if you would like to introduce yourselves, Team A, go first. Team A.
Dr. Titasha Pakira. Dr. Reshma Banu.
And mention your colleges.
SSKM Hospital.
Yeah, and whether your PGTs or not.
Dr. Reshma Banu from SSKM Hospital. I am third year PGT.
Yeah, they're Team A. Now Team B.
Dr. Jayabhaskar, third year PGT from National Medical College.
I'm Shreyash Sinha, final year PGT at National Medical College.
Thank you. Team C.
Dr. Shayur Chatterjee, third year PGT, RGCor Medical College and Hospital.
Dr. Pritha Chatterjee, third year PGT, RGCor Medical College.
Thank you. Team D.
Dr. Ambili Sahadevan, ADMO, Central Hospital, Southeastern Railway.
Dr. Surjana Biswas, first year PGT, Central Hospital, Southeastern Railway.
Next, Team C. Team E.
Dr. Yamuna, second year PGT, Command Hospital.
Dr. Gunjan Gehlot, third year PGT, Command Hospital.
Okay, thank you so much. So we'd like to start the ENT quiz mains of the 49th AOIWB conference. Welcome to all the delegates and respected sirs and the participants. So here are the rules. This quiz will have 5 rounds. 5 rounds: otology, rhinology, head neck, general ENT, and a buzzer round. Each question has 10 marks divided among its subparts, and there is a negative marking of 5 for every wrong answer. If you get the subpart wrong, if you get the entire answer wrong, only then we'll give a negative marks. If a subpart is correct, then you won't get a negative mark. You'll get marks for that part. Okay? The marks shall be read out at the end of each round. Each question, you'll get a time of 20 seconds for each question. In the buzzer round, the buzzer shall only be pressed after the quiz master utters the word. You can press your buzzers now, not before that. And if you press the buzzers before that, you would be disqualified from that question. From that question, you would be disqualified from that question. And the answers provided by the quiz master shall be final and unchallengeable. So, all the best to all of you. We'll start now. Acha, so can you connect this? Tech support.
Is it a
connect?
Okay, so good afternoon everyone. I will be your quiz master for the first 2 rounds. So there are 5 rounds as said. So we'll start off with the otology round. We'll proceed with rhinology, then laryngology and head neck, then a general round followed by the final round, that is the buzzer round. Okay? So as said, we will be going clockwise from team A to team E. Is it visible, everyone? Is visible, right? Okay. So, all the best to all of you. And we come to the first question for team A. This is otology. Okay? So, this is a 35-year-old female who presented with pulsatile tinnitus and progressive hearing loss in the right ear, of 3 months duration, and below is the otoendoscopic picture. So the first question is, what is the most likely diagnosis?
Glomus.
Can you be more specific?
Glomus tympanicum.
Okay, 3 points. 3 points. Question. 3 points. Second, enumerate 2 clinical signs that may be seen on otoscopic examination.
Aquinose sign.
And okay, you have 5 more seconds. Okay, third question, name 2 staging systems for the above diagnosis.
Fish staging system.
One more. Achha, theek hai. So, they'll get 3 marks for the first question, they'll get 1 for the second question, and they'll get 2.5 for the last question. Okay, just to, at the end of the question, I will tell you about the marks distribution. The first question carries 3 marks, the second carries 2 marks, and the last one carries 5 marks. So you got the first one right, you got 3 points. Second one you got 1 right, so you get 1 out of 2, and the third one you got 1 right again, so you get 2.5 out of 5. Okay. Okay, anyone from the audience for the second question? 1 sign was mentioned, any other sign? Brown sign, equinose sign, and anything else? Rising sun sign. So these are the 3 signs. You had to name 2. And 2 staging systems? Glascock-Jackson, other than fish. Okay. So we move to the second question for team B. Okay, so there are 4 marked structures that you have to identify. I'll tell you which ones to identify and you keep answering in sequential order, okay? So what is A? Be specific. And you'll get 10 seconds to identify each point. Okay, your time starts now for A. This is the otoendoscopic picture. Okay, you're looking at the middle ear. On the left side. Okay, your time is up. What is E?
Round window.
No, E is like a stapedial tendon.
Not D is stapedial tendon. E is not stapedial tendon.
What is your answer?
Footplate of stapes.
Oh, like D will, like we're going with footplate of stapes.
Oh, no, what is E?
E for E, we are saying footplate of stapes.
No, that is unfortunately not right. That is not footplate of stapes. G?
Sinus tympani. Sinus tympani.
That is correct. So for G, they'll get 2.5. Negative bolchi. And F, what is F?
Round window-ish.
I will give you one more chance.
Ponticulus.
Yes, that is right. So they'll get 2.5 each for the last 2 points of identification. The one you answered as E was wrong, so you'll get negative 2.5 on that. Okay. So once again, okay. For the audience, what is A? To be more specific, this is the horizontal part of the tympanic segment of the facial nerve. Okay. So E is what? D you can see is the stapedius tendon, right? So what should be E? It is pyramid. It is pyramid. G is sinus tympani, yes. So F has to be ponticulus. Okay? Fine. Okay, now the third question is for team C. Okay? Look at the scans, look at the MRIs, and tell me what the diagnosis is. First question, what is the diagnosis?
Vestibular schwannoma.
A bit more specific.
CP angle 2.
Okay, we'll give you 3 points. This had 3 points, we'll give you 3 points. So what is the genetic abnormality? What is the genetic abnormality? Again, look at the scan, you will get the hint from there. Okay, we move to question 3. Any 2 other lesions associated with this genetic abnormality? Okay, they have passed. So, firstly, what is the diagnosis was the question. Yes, it is obviously vestibular schwannoma. What is the genetic abnormality? You can see this is a bilateral vestibular schwannoma. So it is NF2. Okay. So any other lesions? 2 lesions? Exactly. Okay. That was the question. Okay, this was team C. So they'll get 3. Okay, coming to team D. So you just assume that this is the Pierton audiogram of a patient complaining of unilateral hearing loss. This is a left-sided hearing loss that the patient is complaining of. However, the Weber's test is lateralized to the right ear. What is the most likely reason?
No masking was done.
Excellent answer. Very good. I think that deserves a round of applause. That was an excellent answer. Okay, so when should you be masking? Ideally for air conduction testing. Whenever, not pertaining to this case, in general I'm asking you, whenever you're testing for air conduction, what is the point from which you should start masking?
5 dB difference. When the difference is
I'll give you one more chance.
5 to 10 dB.
No, okay. That is unfortunately not the right answer. So, they'll get 5. negative 2.5. So, for the first answer, the division was 5 each. Okay. So, for the first correct answer, you'll get 5 points. And the second answer, incorrect, you'll get a negative of 2.5. So, for the audience, question 2, when should masking ideally be done while testing air conduction? So whenever you are testing for sounds of more than 45 decibel, why? Because of the interoral attenuation. Okay. Coming to team E, for the last question, there are 2 devices you can see side by side. Okay. So you have to identify both devices. That is the first question.
The first device is vibrant sound bridge.
Very good. Second?
Baha. No.
Okay, you will get 5, you'll get 5 plus 5 total 5. 2.5.
So the second.
Okay. Second is?
Is it DACS?
No, it's not. Okay, so it is plus 2.5 and minus 2.5. So you remain where you are. Second, name 1 point of difference between device A and B in terms of implantation technique. The first one you should know, and the second one, the hint is given in the picture itself. In terms of implantation technique. Okay. You'll pass? You'll pass? Okay, fine. So for the audience, device A and B, they have got device A, right? Device B? So this is, it's already written, this is a piezoelectric device, that is envoy steam. Okay, and the point of difference between A and B is what? This is a semi-implantable device. In terms of implantation technique, I told you, this is a semi-implantable device, that is a totally implantable device. You can see the entire thing is inside the ear. Okay, so that is the point of difference. And with that, we come to the end of the otology round, and we'll have the scores.
Team A 6.5, Team B 2.5, Team C 3, Team D 2.5, and Team E 0.
Okay, so now we will proceed with the next round, round 2, that is rhinology round. Okay, we'll start from Team A again, and your question comes now. So these are snapshots of the interior of the sphenoid sinus during an endoscopic sinus surgery procedure. Okay, so you have to, in figure A, identify 1, 2, and 3. This is the interior of the sphenoid sinus of the left side. Identify 1, 2, and 3.
One is carotid canal.
Proceed to. Okay, I'll give you 10 seconds more for the first question.
Three is carotico-optic recess.
That's correct. And 2 is?
Optic.
Final chance. Okay, so you've got part 3 correct. You've got part 3 correct. You've got 1 and 2 wrong. Okay, firstly, okay, I'll go straight to the audience. What is 1? 1 is optic nerve. 2 is? 2 is the impression for the cavernous carotid artery. And 3 you got right, carotico-optic recess. So they'll get +1 -1. Second question is, which segment of structure 1 is being decompressed in figure B? It is a continuation of the same image, okay? This is nothing different. Which segment of structure 1 is being decompressed in figure B?
Cavernous portion.
Okay, that is not right. And what is question 3? What is the relationship between structure I and ophthalmic artery in this segment?
Ophthalmic artery is inferior.
Can you be more specific?
Medial and inferior.
Okay, that is also not completely correct. So, okay, so it's +1, -1.5, -2. That is the final score for this question for team A. ठीक है, noted तो? +1 -2. Okay, so I will read out the answers for this one. So structure I is basically the optic nerve, okay, or 1. Structure 2 is the cavernous carotid and 3 is the carotico-optic recess for figure A. We go to figure B, it is this same optic nerve which is being decompressed, okay. So this is the canalicular segment of the optic nerve that is being decompressed. And in this segment, the most common relationship between the optic nerve and the ophthalmic artery is that ophthalmic artery is most commonly inferolateral to this portion of the optic nerve. However, in 10 to 15% of cases, it can lie inferomedial. So when you are decompressing this segment of the optic nerve, your incision should be restricted to the superomedial quadrant. Okay? Okay, now for team B. Go through the pictures first. This is a picture of an ongoing endoscopic sinus surgery. The surgeon, in the first picture, the surgeon is trying to identify the sphenoid sinus ostium. So what is the anatomy or what is the landmark that is being referred to in order to identify the sphenoid sinus?
So superior turbinate.
Can you repeat?
Superior turbinate.
That is not correct. Not superior turbinate. Okay, we'll come to the answers later. Which approach is being undertaken to locate the sphenoid sinus? The structures have been marked for you, so there should not be any confusion.
Approach. Transethmoid approach.
There are 3 approaches to sphenoid sinus. Which approach is this among the 3? I'm giving you another chance.
No, then we'll pass.
You will pass, okay. What complication has occurred while enlarging the sphenoid sinus and what is its management? You can see in the next 2 pictures marked in green. There's some complication that has occurred while enlarging the sphenoid sinus. What is the complication and what is its management? Okay, last 5 seconds, you'll pass. Okay, so you did not answer the last 2 questions. The first question you've gotten it wrong, so there will be a negative of 2 points. Okay, I will now run you through the answers. Which landmark is being identified? You can see the maxillary sinus very properly here. So what is the landmark? This is maxillary line. So you can see the middle turbinate. There is a superior meatal window that has been created, and we are taking the reference of the maxillary line. So this is intermediate approach to the sphenoid sinus. That is the answer to the second question. And what is the third answer? The surgeon was trying to enlarge the sphenoid sinus where? Inferiorly. See the sphenoid sinus? The surgeon was trying to enlarge the sphenoid sinus inferiorly. So there is an injury to the septal branch of sphenopalatine artery. Okay, that is the complication that has occurred. It's a common complication while trying to enlarge the sphenoid sinus inferiorly. And what is the management? Suction cautery. Okay, so we'll move to the next question, to the next team, team C. So this is your question. A 9-year-old child presenting to you in the emergency with epistaxis. Below are the endoscopic and CT scan pictures of the patient. First question is, what is the provisional diagnosis?
Juvenile nasopharyngeal angiophyte.
Okay, that is correct. So they'll get 3 points for this. Mention the areas involved and the from the CT scan and the Radkowski staging for the same.
The areas involved are obviously the posterior part of the nasal cavity with the sides as well as the nasopharynx.
Yes.
And going to the right side, the pterygopalatine fossa.
Yes. Yes.
Okay. That is right. That is also right. So what is the right stages for this? Pass. Which additional procedure will you perform after tumor removal to prevent recurrence? Drilling of the pterygoid wedge.
Good answer. So that is also correct. So they'll get 3 points for the first question, 2 for the second, and 3 for the third. So 3 plus 2 plus 3. Okay. Coming to the next team, Team D. This is your question. So you have to name this staging system and its speciality. ওটা দেখতে পাচ্ছিস না? সামনে দেখতে অসুবিধা হচ্ছে?
হ্যাঁ।
দেখতে পাচ্ছিস? ঠিক আছে, দেখ যা। The hint is there in the second picture. So
This is staging system. AFRS का staging system.
okay, 5 more seconds.
This is his AFRS staging.
Okay, that was going to be the second question. Okay, you're right. The disease is AFRS, and name 2 features as seen in the CT scan.
Dual density.
Now 1 second.
Erosion of the bone. Erosion of the bone.
Erosion of?
Nasal septum eroded. Bone.
Okay, that is not right. If you're saying AFRS, so erosion is one thing you do not associate with an AFRS. Okay, so they'll get 2 points for the second question, and they will get 1 point for the third question. So they'll get a total of 3 points. So what is the staging system from the audience?
Now can I now I'll say now. Can I say now?
No, you can't. It's over.
Please give one.
You can't. You've been given enough time, so I can't go back. What is the staging system?
Caddish.
This is Cooper-Berg staging. And what is the speciality? This is a post-operative staging system for AFRS. Okay. Disease you know. 2 features, see. Firstly, yes, you have the double density. And what is the obvious feature that is seen here? Expansion of the sinuses. There is expansion and thinning of the sinus walls, not erosion. You do not associate erosion with an allergic fungal rhinosinusitis. Okay? Okay, now going to Team E for the last question of this round. So this picture below shows a segment of endoscopic sinus surgery where anterior and superior most part of the skull base and the sinus is seen with a 0-degree endoscope after completion of the procedure. Every word in this question is important, okay? Anterior and superior most part of the skull base and the sinus is seen at the end of the procedure with a 0-degree endoscope. So what is the procedure that has been done?
Draft 3, sir.
Good answer. That is the correct answer. Draft 3. What are the anterior and posterior limits of this procedure?
Sir, the posterior limit will be the olfactory phylum.
Correct. And the anterior limit?
Anterior table of frontal sign.
Okay. I have to deduct on that one, okay? So 5 plus 2.5 minus 2.5. So you'll get a total of 5 points for this. Okay, so just refer to the picture here. I will tell you. So this is basically the 2 frontal sinuses, right? So the 2 frontal sinuses here opened up, given a median drainage. So this is draft 3. Below and behind you can see the cribriform, isn't it? So the posterior limit is first olfactory neuron, which is seen further below, and the anterior limit is what? The outside skin. Okay, so you have to confirm intraoperatively by ballotment. You have to press the outside skin and you have to confirm whether you have reached the anterior limit of the procedure. Also, you will get some bleeding, which signifies that you are reaching the outside skin, and of course the change of color, right? So those are the anterior and posterior limits of the procedure. So with this we come to the end of the rhinology round, and we'll have the scores.
after the first round and the second round, the team A got 4 points. In the first round, they got 6.5 and second round minus 2.5. Team B 0.5 after first and second round. Team C a total 11 points. Team D 5.5 points after first and second round. Team E total 5 points. So Team E is the highest after first and second round. Team C.
Okay, the next round is the laryngology and the head neck round. It will be conducted by Dr. Olokendu Bose.
Now the first question for team A, identify the structures marked in A, C, E and F. Team A. What is the structure A? Time is going on, please do fast. What is structure C? What is E? What is F? Your time is up. Any guess from the audience side? What is structure A? Yeah, right? Yeah. No, E is submesenteric space and C is pterygomandibular space. Okay. The next question for team A, what is Vincent's angina? I can give you 5 more seconds.
Submandibular abscess?
No, your answer is wrong. Now the next question is, what is the causative organism for Vincent's angina? Sir, I'm giving just chance, that I know.
Staphylococcus aureus.
No, your answer is wrong. You will get a negative point for this. And the next question is, what is the drug of choice for MRSA?
Vancomycin?
Yeah, you will get 2.5 marks for that. So the team A is getting 2.5 for the fourth answer, and they will get a negative mark for third answer, that is plus 2.5 and minus 2.5. Now the next question for team B. Identify the structure, identify C, picture C. The histopathological picture.
So we're guessing like papilloma, so like
I said picture C. Shall I accept this answer or I will give a negative mark? I will give one chance more. Your time is up. Now identify D. Five more seconds.
so we'll guess RRP for this recurrent respiratory papillomatosis.
Okay, you will get 2.5 marks for D, correct answer. Now the next question is, what are the risk factors for D?
So, like exposure to human papillomavirus.
Yeah, correct answer, 2.5. Now, what are the treatment options for D?
It's like CO2 laser ablation.
Yeah.
Um, like cordectomy.
Okay, next, any antiviral, I'm giving you option, any antiviral therapy? Okay, you will get 2 marks for this. So total is 2.5 for second question, 2.5 for third question, and 2 marks for the fourth question. So from the audience, identify C. Any guess? No. Wrong guess. It's caseating necrosis, tuberculosis. Okay, now the next question for team C. Identify the picture. First question. No humming from the audience, please. Team C, hurry up. Your time is up. Next question. What is Woodman's procedure?
Pass.
Next question. What is the incidence of non-recurrent laryngeal nerve on the right and the left side?
%3.
Which side? Please specify the side.
Left side.
Wrong answer. Negative marks for this. Now the next question. The first successful laryngeal transplantation was done on and by whom and where?
Pass.
Okay. Now the audience, what is the picture? Please identify. Yeah, it's correct. It's laryngeal pacemaker. What is Woodman's procedure? Yeah, it's true. It's external arytenoidectomy. Now, what is the incidence of non-recurrent laryngeal nerve on the right side? Now, on the right side is 0.6% and on the left side is 0.04%. Now, the first laryngeal transplantation was done on, it was done on 1998 and it was done by, any guesses? It was done by Marshall Storm in Cleveland. Then next question for team D. A 55-year-old female patient with right neck dissection was performed, left neck dissection was performed in a metastatic cervical lymphadenopathy from carcinoma of larynx. Drain was put and its continued discharge from a discharge of white material was there. So what is the likely diagnosis? First question. Time up. Next question. What is your line of management? You cannot answer. Pardon?
Kylo.
You missed the chance. What is your line of management?
Conservative.
Okay, good. 2.5 marks for that. What is the effective method for controlling the leak? Your hint was there in this answer. What is the effective management method for the control of leak?
Drain.
Pardon? Be louder.
Pass.
Okay. What is the incidence of this complication in neck dissection? Okay. Audience, any guesses? What is the likely diagnosis? Okay. What is your line of management? Perfectly correct. And what is the incidence of this complication in neck dissection? Sir, 1 to 2%. So team D, the scores are 2.5. The next question for team E. Identify the specimen.
Sir, orbital exentration with total maxillectomy.
Yeah, the next one. Figure B.
Sir, adenoid cystic carcinoma with orbital extension and malignancy.
Figure B, I said.
Okay.
Prothome, first question is identify the specimen, figure A and figure B.
So basal cell carcinoma.
Yeah, you are absolutely correct. The first one is orbital exentration, the second one is basal cell CA. Now, you will get 2.5 marks for the first question. The next question is mention the indication for surgical procedure in A.
So, adenoid cystic carcinoma with orbital extension.
Little more specific. Okay, you will get the marks. 2.5. Identify the lesion in B. Okay. What are the other names for B lesion?
Rodent ulcer.
Pardon?
Rodent ulcer, sir.
Yeah. Another one? You will get 2.5, but you can answer. Okay. The another answer is basalioma. Okay. So you will get 10 marks. Very nice. Now the score will be declared by Tanmay.
Team A got 0 points in third round, but total they got 4 points. Team B 7 points in third round and total 7.5 points. Team C minus 2.5 in third round and total 8.5 for all 3 rounds. Team D got 2.5 points in third round and total 8 points. Team E got full marks in this third round. They got 10 points and total 15 points.
Now the general round will be conducted by Dr. Shujas.
So this question is for team A. What is the diagnosis? What is the diagnosis? Look at the hair.
Vendor.
Yeah, go for it.
Vendor.
See, I'll even deduct marks for mispronunciation, right? So, be sure before you answer, or you can pass it. 5 more seconds.
Vendor Hoffen syndrome.
Yeah, pardon, I didn't get you.
Van der Waals syndrome.
What? Really? That is actually a very smart move, though.
Van der Waals syndrome.
Yeah, Wonderberg syndrome. Okay, so mention the genetic abnormality associated with this condition. There are 3 genes which can mutate to cause this condition. I'll give you the full marks if you can name one. Okay, so they have passed it. So in this round, they get 5 marks. Anyone from the audience? The genetic mutation? No, I'm asking about the gene. It has 4 types. The genes are PAX3, MITF, and SOX10. So SOX10 is type 4. PAX3 is the most common. Okay, so we'll now move on to team B, and their marks in this round for team A is 5. It's 5. Now team B, what does the picture show? What does the picture show? I'll give you a small hint. The colors show the vitality of the regions. Now you should be able to answer this. Ten more seconds, team B.
It's like some spectrometry or something.
I'm not asking about the technology. That is the next question. What is the first? What is this? What does the picture show? I think you're done. Your time has passed. So what is the technology used here?
Yeah, so this will say spectrometry.
No, it's not spectrometry. It's confocal laser scanning microscopy, and the specimen is biofilm. It's biofilm. The hint was in the vitality that I said, right? So the score would be -5 in this question, -5. Now the next question for team C. What is the imaging in the given picture called? What is this imaging? What is this imaging?
Functional MRI?
Very good, yeah. The functional MRI, yeah, +5. What is the principle on which it is based?
Pass.
Okay, so anyone from the audience? Bold, yeah. Blood oxygen level dependent principle. The places which are more active, they get lighted up. Okay, so for the next team, team D, this is the question. Name the imaging procedure used here. The next question should be very suggestive.
Stroboscopy.
No. That's not it. That will be a video, right? That will be a video. Okay, so go on to the next question. So -5 for this, -5 for part 1. And go on to the next question. What is the central wavelength of light used in this particular case? That question should have been a hint as to what was the first answer, right? So yeah, do you know the central wavelength? Okay, so this is narrowband imaging, and the central wavelength used here, it is in the blue region, so it's 415. Okay, 415. So -5 in this question. Last question for team E. Identify the person in the picture. See, I'll give you a hint since this is a picture question. This person did extensive work on the histology of various ear pathologies. However, he's famous for something else. He's famous for some other test. Okay, so the test has to do with pressure in the middle ear and its connection with the nasopharynx. Now you should get it.
Is it Pollitt, sir?
Now you have to tell his full name. Do you know his full name?
Sir, no, sir.
Yeah, it's Adam Pollitt, but I'll still give you the marks. Mention one of his contributions. It's pretty easy now. Okay, so +5, +5. The scores in this round, Tanmoy, please.
In the fourth round, Team A got 5 points and total 9 points for Team A. Team B got -5 points for this round and total 2.5 points. Team C got 5 points in this round and they got total 13.5 points in total. Team D got -5 points in this round and they got total 3 points after 4 rounds. Team E got 5 points in this round and they got total 20 points after 4th round.
Yes. Now we would like to call upon Dr. Deobrata Dash to conduct the buzzer round. The marks distribution remains the same. There is also negative marking, and as I said that if you press your buzzers before the examiner says that you can answer your question now, or you can press your buzzers now, you would be disqualified from that round of that particular question. We'll be standing behind you to see who presses the buzzer first. Okay, the three of us.
And we will decide who, we will observe who is the first person to press the buzzer. The decision is ours and that will be the final. So the final round. What is the approach? What is the approach?
Yeah, Team E has pressed.
Sir hasn't said to press.
Yes. You can press your buzzers now.
Should I go to next question?
No. You'll say that you can press your buzzers now. After that, they'll press their buzzers. Okay. Or else you'll be disqualified.
তার আগেই দিয়েছে, but
তার আগে দিয়েছে। They are disqualified now. From this question, from this particular question. Sir, ask from the next question.
আচ্ছা, okay.
Sir, from the next question.
Identify the image. Now we will press the buzzer. Acha.
Team A.
Optical coherence tomography.
Right answer.
Right answer.
শুনতে পাচ্ছ না? এবার শোনা যাচ্ছে। এবার ঠিক আছে না? Can I? আচ্ছা. Okay, +10. So +10. Can I move to a next question?
Yeah, move to next question.
Just 1 second, can I just confirm it's not playing, I think.
Identify the procedure. Now you can press the buzzer.
Procedure.
The question is, what is the procedure? So the question now is to the audience. এটা ছবি যেটা দেওয়া আছে ওটা ড্রাফট মনে হওয়াটাই স্বাভাবিক, কিন্তু আমাদের ফ্রি আর্টস এলিভেটরটা দেওয়া আছে অরবিটের দিকে, ইটস অরবিটাল ডিকম্প্রেশন অরবিটাল ট্রান্সপোজিশন। আইডেন্টিফাই দি ইনস্ট্রুমেন্ট।
নাও বলেনি।
হ্যাঁ হ্যাঁ
একটু ওয়েট করতে হবে, একটু ওয়েট করতে হবে, তাড়াহুড়ো করিস না, জানলেও তাড়াহুড়ো করিস না, একটু ওয়েট কর, বলবে।
মাইনাস করে দিই।
না না ডিসকোয়ালিফাইড ফ্রম দিস রাউন্ড।
না না বলিনি তো।
এবার বলো।
Navigation system?
নেগেটিভ আনসার।
নেগেটিভ ইটস
টিম বি
Piezoelectric device.
নেগেটিভ।
অডিয়েন্স কুসা ক্যাভিট্রন আল্ট্রাসনিক সার্জিক্যাল অ্যাসপিরেটর। আচ্ছা কেন
ওই নাওটা বলে দিও, নাওটা দিয়ে।
আচ্ছা, আইডেন্টিফাই দি অ্যাবনর্মালিটি অ্যান্ড দি ক্লাসিফিকেশন সিস্টেম। ইউ ক্যান প্রেস ইউর বাজার নাও।
Sir, is it a part question? Part.
No, you have to answer.
Yes, it's a part question. First you have to identify the abnormality and then you have to tell the classification system. Can we move on next? Audience. Acha. Negative answer. So it's a posterior glottic stenosis, and the classification is Bogdasarian and Olson classification.
You said just the reverse of what was there. It's a stenosis, you said just the opposite of what was there.
নেক্সট কোশ্চেন।
Identify the set. You can press your buzzer now.
টিম বি
Silentoscopic.
Correct answer.
+10।
Identify the procedure. You can press your buzzer now. Should we pass on to the next question? Acha, to the audience. Yes. It's TORS. It's submucosal minimally invasive lingual excision, but it's a robotic surgery, so you can say it. It's a TORS. Next time আমরা চকলেট রাখবো, এবার সরি চকলেট রাখা হয়নি। আচ্ছা, identify the device. You can press the buzzer now.
Brainstem implant.
Yes, correct answer. So now it's the time for the final score. Tanmoy, scorer. Hold your breaths till the results declared. শেষ So it's the time for the final score. Team A ends with score 14. Team B 2.5. Team C 13.5. Team D 13. And the last one, Team E, is 20. So the first is Team E and the second is Team A. Sir, congratulations. Shengupta sir, congratulations. You are the runner-up. You are the runner-up, sir. The two teams, first one, তোরা উঠে introduce কর নিজেদের microphone নিয়ে. Introduce yourself. All the participants were excellent. Team C, Team C 13.5, very close. মানে 0.5 এর জন্য সেকেন্ড হলো না. আরজিকর এই 3 cheers for আরজিকর. আরে ফার্স্ট সেকেন্ড তো বলে দিলাম. একটু ছেলেগুলোকে একটু না উৎসাহ দিলে. এই বল, introduce yourself. Team A, winners.
Sir, I'm Dr. Gunjan Gehlot, third year PGT from Command Hospital.
Myself Dr. Yamuna, second year PGT from Command Hospital.
তোরা বল.
I'm Reshma Banu, SSKM, third year PGT.
Dr. Titasha Pakira, IPGMER and SSKM Hospital, final year PGT.
So, over to Snehashida.
Thank you all. Now it is time to close our conference, and so we are at the end, and now it is time to call upon. আচ্ছা তোমরা করো, তোমরা নেবে যাও। আচ্ছা ইএনটি কুইজের যারা ফার্স্ট হয়েছে সেকেন্ড হয়েছে তারা প্রাইজ পাবে কিন্তু পরের কনফারেন্সে, ঠিক আছে? তোমরা কেউ চলে যাও না, আমরা একটা গ্রুপ ফটো তুলবো। সাদিকের লোককে বল একটু এখানটা খালি করে দেবে, এখানটা একটু সরিয়ে দেবে। হ্যাঁ ঠিক আছে।
রেশমা বানু, দ্বিতীয় পাখিটা সেকেন্ড,
হ্যাঁ
যমুনা রঙ্গনাথন, গুঞ্জন গেহলট।
ওকে আচ্ছা এই একটু দেবো, একটু বল এগুলো একটু খালি করে দেবে, এগুলো সরিয়ে দেবে। আচ্ছা ভ্যালিডেক্টরি সেশনে আমি ডেকে নেব আমাদের নিউ প্রেসিডেন্ট ডক্টর হারাধন বোরা, our outgoing president Dr. Subhajit Banerjee, and our new president elect Dr. Manos Guho. Manos da koi? I request Dr. A.M. Saha come on the dais. হ্যাঁ করছে। একটু সামনে আসুন, একটু বলবেন, একটা মাইক দাও না। আর এখানে দেবো একটু ডাক না।
Hello. Good afternoon, everybody. On behalf of AOI West Bengal, I welcome, I just thank you all for coming and attending this conference. And we are just concluding the conference. We had some scientific programs, some orations, and I hope all of you enjoyed very much. And especially for the PGDs, I am very thankful that they attended and they took part actively. And I hope this thing will just continue for years to come. Thank you all. I just hand over the mic to my senior and now.
I request Dr. Haradhan Bora to say few words.
At the end of this 49th annual conference, I will give all thanks to all the teachers and all the delegates and all the participants.
হ্যালো, কি বলার কি আছে? সবাই বললো, আমি তো শুনবো। সবাই বলুক, আমি একটু শুনি, তারপর তো আমি বলবো। যাই হোক, খুব সুন্দর কনফারেন্স হলো। টিম আরজিকরকে প্রথমে ধন্যবাদ জানাচ্ছি এত সুন্দরভাবে কনফারেন্সটা কন্ডাক্ট করার জন্য। AOI ওয়েস্ট বেঙ্গলকেও তারপরে ধন্যবাদ, কনগ্রাচুলেট করছি। আর সবাইকে কনগ্রাচুলেট করছি পার্টিসিপেট করে কনফারেন্সটাকে সুন্দর, সর্বাঙ্গ সুন্দর করার জন্য। ঠিক আছে,
I invite Dr. Indranath Kundu, organizing chairman, come on the dash. এখানে একটু খালি করে দাও, এটা দাঁড়িয়ে ফটো হবে না?
বলুন স্যার, দু কথা বলুন।
আজকে আমি বাংলাতেই বলছি। আমি দুদিনের প্রোগ্রাম চালিয়ে অভিভূত। সর্বস্তরে আমরা সহযোগিতা পেয়েছি, অ্যাসোসিয়েশনের দিক দিয়ে, আমাদের লোকাল অ্যাডমিনিস্ট্রেশনের দিক দিয়ে, সকলের দিক দিয়ে। এবং এতজন যে ডেলিগেট আসবে আমি ভাবতেও পারিনি, এত সুন্দর যে প্রোগ্রাম হবে সেটাও ভাবতে পারিনি। তো আমরা অ্যাসোসিয়েশনের কাছে আমি একটু দৈপায়নকে বললাম, পরবর্তীকালে যদি আমাদের আরও কিছু প্রোগ্রাম দেওয়া হয় তাহলে আমরা করতে রাজি আছি, যদি তোমাদের এটুকু পছন্দ হয়ে থাকে। এটাই, এগুলো আমার বক্তব্য শেষ করলাম।
Now I request Dr. Devabrata Das, our energetic young organizing secretary who has done hard job.
আচ্ছা, আমিও বাংলাতেই বলি। আচ্ছা, বাংলায় গান গাইছিলাম, এটা বলার আমি সময় নিচ্ছি একটু। সেটা হচ্ছে প্রথমে ডকুমেন্টারির কথা বলি যে প্রথম যেদিন আমাদের এই কমিটি মিটিং হলো যে রাজ্যসভা হবে, তো আমি কিন্তু মানে স্যারের অনুমতি না নিয়ে বলে দিয়েছিলাম যে আমি জানতাম কনফিডেন্ট যে না মানে স্যার এটাকে প্রম্পটলি সাপোর্ট এবং সেটাও বাস্তবও ছিল তাই। মানে আমি যখন স্যারকে বললাম স্যার আপনার অনুমতি না নিয়ে হ্যাঁ বলে দিয়েছি, স্যার বলেছে কি হয়েছে, খুব ভালো করেছে, তো হবে তো আমাদের। তো দিস ওয়াজ দি ইনিশিয়াল, মানে ইনিশিয়াল মানে স্যারের সাপোর্ট। তারপরে ফ্রম দি বিগিনিং আমার টিম সামনে আরজিকর, সমস্ত পিজিটিগুলো, এসআর, আরএমওস, সবাই একসাথে মোটামুটি খেটে খুঁটে জিনিসটাকে দাঁড় করিয়েছে। স্টার্টিং ফ্রম মানে অল দি ডেলিগেটস, সবাই মিলে এরকমভাবে পার্টিসিপেট না করলে হয়তো জিনিসটা এরকম এতটা ভালো হয়তো হতো না। যারা কন্ট্রিবিউট করেছে আমাদের স্পন্সর্স, প্যাট্রন, সবাই, তারাও হয়তো এরকমভাবে সাপোর্ট না করলে আমরা জিনিসটাকে এরকমভাবে দাঁড় করাতে পারতাম না। আর আমাদের অ্যাসোসিয়েশনের যারা আছেন, যারা আমাদের মাথা, তাদের সাপোর্ট তো সবসময়ই থাকে, অলওয়েজ, ইন অল অ্যাসপেক্টস, স্টার্টিং ফ্রম দি সিনিয়র মেম্বার্স টু দি জুনিয়র মোস্ট, সবার মানে একদম সম্মিলিত প্রচেষ্টায় জিনিসটা আজ দাঁড়িয়েছে। কিছু ভুলচুক হয়তো হয়েছে, আশা করি সার্বিক মূল্যায়নে আমরা হয়তো পাশ করেছি। তার কিছু বাদ গেল কি? তো মনে হচ্ছে সবই বললাম, আর কিছু বাদ গেল ক্ষমা।
আমি দৈপান্দাকেও একটু ডেকে নেব, কারণ হচ্ছে যে দৈপান্দার মানে মাথা অনেকটা কাজ করেছে কনফারেন্স অর্গানাইজ করতে।
অ্যাজ দ্য নেম সাজেস্ট, দৈপায়ন, দৈপায়ন, সেই জন্য।
3 cheers for Arjikor Medical College ENT department. Hip hip, hip hip, hip hip. কোন মানে ভাষা দিয়ে এটা মানে এই প্রশংসার মানে কোনো ভাষা নেই। একটু আগে আমি ইন্দ্রদাকে বলছিলাম যে স্যার যখন ডিসিশনটা হলো যে আরজিকরে হবে, তখন আমরা জানতাম যে হবে, কিন্তু মানে ইন্দ্রদার যে এই আউটপুট, এটা সত্যি কথা বলতে কি আমিও মানে ভাবতে পারিনি। ব্যাপারটা হচ্ছে যে মানে ইন্দ্রদা তো এমনি খুব সাপোর্টিভ, কিন্তু জিনিসটা হচ্ছে যে কোনো জায়গায় এখানে অনেক সময় প্রোগ্রাম অর্গানাইজ করতে গেলে অনেক ছোট ছোট জিনিসগুলো থাকে যেগুলো সাধারণভাবে যারা ডেলিগেট আসেন তাদের চোখে পড়ে না, কারণ সেগুলো ব্যাকড্রপে কারেক্টেড হয়ে যায়। কিন্তু সেই কারেকশানের জন্য যে ফাইন টিউনিং এগুলো যেগুলো লাগে সেগুলো আমাদের করার কোনো ক্ষমতা বা এখতিয়ারই থাকে না, কারণ হচ্ছে যেহেতু আমরাও তো এখানে আউটসাইডার। সেখানে প্রতিটা মুহূর্তে যে কোনো সময় ইন্দ্রদাকে ফোন করলে বা ইন্দ্রদা থেকে বললে মানে প্র্যাকটিক্যালি বলার আগেই কাজগুলো হয়ে গেছে। হ্যাঁ, এটা এনর্মাস এফোর্ট, এবং মানে কনগ্র্যাচুলেশন টু ডক্টর ইন্দ্রনাথ কুন্ডু। মানে এখানকার যে নিয়ে যারা অথরিটি আছেন বা যা আছে তাদের সঙ্গে নিশ্চয়ই ইন্দ্রদার খুব মানে স্মুথ লিয়াজও রয়েছে, সেই জন্য এই ব্যাপারটা করা গেছে। আদারওয়াইজ আমরা কিন্তু স্টেট কনফারেন্স লেভেলের প্রোগ্রাম কোনো মেডিকেল কলেজে করে অভ্যস্ত নই। সেক্ষেত্রে আমার মনে হয় যে এখানে যারা যারা ডেলিগেট এসছেন তাদের কারুর কোনো জায়গায় অসুবিধে হয়েছে বলে আমার মনে হয় না। অন্য আর যে কোনো স্টেট কনফারেন্সের সঙ্গে এটা অ্যাট পার ইন টার্মস অফ এভরিথিং। আর একটা জিনিস আমি বলবো যে স্নেহাশিস বর্মন মানে ডক্টর তরুণ পালিতের পরে, হ্যাঁ, মানে মোস্ট লাইকলি মানে ডিভোটেড টু দ্য অ্যাসোসিয়েশন, বিয়ে করেনি সেই জন্য। হ্যাঁ, মানে যেমন ডক্টর পালিত আজ অব্দি অ্যাসোসিয়েশনকে সার্ভ করছে, আমরা মানে তাই সম্ভবত হবে স্নেহাশিস এরকম লাস্ট ডে অফ দি অ্যাসোসিয়েশনকে সার্ভ করবে। হ্যাঁ, আচ্ছা, কিন্তু হচ্ছে যে হারকিউলিয়ান এফোর্ট মানে ভাবার বাইরে, কারণ হচ্ছে যে ব্যাক অফিস কাজ, এই যে আজকে মানে সুভেনির ছাপা হচ্ছে, কুপন ছাপা হচ্ছে, মানে কমপ্লেন করা খুব ইজি, কিন্তু সেইটা করার জন্য যে কি মানে মানে এক্সট্রাঅর্ডিনারি এফোর্ট লাগে সেটা মানে কেউ ভাবতে পারবে না যে স্নেহাশিস কী পরিমাণ মানে এফোর্ট এবং খাটনি দিয়েছে। আর দ্বিতীয় কথা হচ্ছে যে দেবুর কথা তো অলরেডি বলা হয়েছে। হ্যাঁ, মানে গ্রাউন্ড ওয়ার্কে এই যে আমরা এখন অনেক রিল্যাক্সড হয়ে গেছি, এই আমি সকাল থেকে এদিক ওদিক ঘুরে বেড়াচ্ছি, হ্যাঁ, এগুলো হচ্ছে মানে দেবু। আমি বলতে চাই যে মানে আমাদের যারা সিনিয়র আছেন, হ্যাঁ, তারা নিশ্চয়ই খুব আশ্বস্ত যে আমাদের যারা মানে ইয়াং হ্যান্ডস, অজয় আছে, দেবু আছে, দীপ্তাংশু একটা ফ্যামিলি ইমার্জেন্সির জন্য আসতে পারেনি, দীপ্তাংশু আছে বা সৌমিত্র আছে, এরা এবং স্নেহাশিস রয়েছে সর্বোপরি ওদের সাথে। হ্যাঁ, আমার মনে হয় যে আমাদের অ্যাসোসিয়েশনের ভবিষ্যৎ খুব উজ্জ্বল। দীপাঞ্জন এবার নতুন এক্সিকিউটিভ কমিটিতে।
দীপাঞ্জন নিজেকে ইন্ট্রোডিউস কর। দীপাঞ্জন
না 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 ইন্দ্রদা বলেছে দীপাঞ্জন আজকে কি পুষ্পার মতন হয়ে গেছে।
না, এই জন্যই দীপাঞ্জনকে ইন্ট্রোডিউস করতে বলছি। দীপাঞ্জন যেদিন ইলেকশন হলো সেদিন আসতে পারে।
আমি দীপাঞ্জন, খুবই ইয়াংগেস্ট মেম্বার অ্যাসোসিয়েশনের। এইবারে এক্সিকিউটিভ কমিটি মেম্বার সিলেক্টেড হয়েছি। আমি কালকে আসতে পারিনি, পায়ে ইনজুরি ছিল বলে, বাট আজকে যতটা পেরেছি আই থিঙ্ক আমি করতে পেরেছি এক পায়ে দাঁড়িয়ে।
তাই আশা করি আমাদের অ্যাসোসিয়েশনে, এবং আজকেও যারা আমার মানে আমি আরও একটা কথা বলছিলাম যে এর আগে আমি একদিন এসছিলাম, আমি তো এখানে সবাইকে নামে মুখে চিনি না, কিন্তু মানে দেবু এবং ইন্দ্রদা যারা পিজিটি আছে, এসআর আছে, তাদের সঙ্গে মানে ইন্টারাকশানের সুযোগ হয়েছিল। মানে সবাই মানে ওয়েল চার্জ ছিল আর কি, যে ভালো করে করতেই হবে, এইটাই হচ্ছে আমাদের মানে স্পিরিট। তাই আমার মনে হয় আমাদের যারা সিনিয়ররা আছেন তারা নিশ্চয়ই আশ্বস্ত বোধ করবেন যে মানে অ্যাসোসিয়েশন ইন ফিউচার অলসো উইল বি ইন গুড হ্যান্ড। থ্যাংক ইউ।
আচ্ছা, আমি আরজিগড় টিমকে তাদের সবাইকে বলছি ওপরে উঠে এসো।
চলায় সবাই, চলায় সবাই, প্রিয়াঙ্কা এই ওপর থেকে, উদয় চলায়, জাভেদ চলায়, তন্ময় চলায়, সরস্বতী চলায়, এভরিওয়ান।
আচ্ছা, আমাদের ব্যাক অফিসে যারা কাজ করেছে, মধুশ্রীদি, অর্ণব, আমাদের যারা স্টাফেরা,
রেজিস্ট্রেশন ডেস্ক থেকে ডেকে দিত
বাকিরা, ওরা ওরা অনেক খাটাখাটি করেছে। রাজীব আছে, তারপরে দেবাশিস দাও অনেক আমাদেরকে হেল্প করেছে। উৎপল দা, না উৎপল দা সোমেনদাকে তো উপরে আসতে হবে। এসো এসো। হ্যাঁ, অরুণাবদা, আমি সবাইকে একটু উপরে ডাকছি, আমরা একটা গ্রুপ ফটো করব।
আমি একটা বক্তৃতা দিই। আমি 2020 20th May I was in the deathbed আজকে এখান থেকে উঠে আমি এই কনফারেন্স, the best conference I've seen. Thank you very much. It's a great conference and everybody has cooperated. It's a great endeavor of Snehashi, Doipal, আমাদের ওকে তো বলেন লাভ নেই, ও আমার স্টুডেন্ট, আর ইন্দ্রনাথ। They have done a great job and I am very grateful that I have seen the 49th annual conference with a gala. Thank you.
একটু ওপরে ডাকবো।
না ঠিক আছে।
এই না না ছবি
ডক্টর পূর্ণেন্দু বিকাশ রায়, পিবি রায়, একটু বলতে হবে আর তারপরে ইন্দ্রদাকে একটু, এই দীপঙ্কর মুখার্জিকে দিতে হবে।
স্যার দু এক কথা বলুন না স্যার।
আরে করোনা পিরিয়ডে তো আমরা এসব ব্যাপারটা পুরো ভুলিয়ে গিয়েছিলাম। তো যখন এটা ভাবা হলো যে মানে শুনলাম যে কনফারেন্সটা হবে, তো আমাদের কত রকম ঝামেলাতেও হচ্ছিল যে আবার এই মানে নতুন করে কোন স্ট্রেন, স্ট্রেন, এই ঝামেলা ওই ঝামেলা, কিন্তু আলটিমেটলি সব কিছুকে যে ধাক্কা মেরে সরিয়ে দিয়ে আমরা এত সাকসেসফুলি একটা কনফারেন্স করতে পারলাম। এবং এই কনফারেন্সটা অ্যাটেন্ডেন্সও তো সাংঘাতিক হয়েছে। কত হয়েছে অ্যাটেন্ডেন্স?
300 ক্রস।
হ্যাঁ
300 ক্রস করে গেছে।
ফার্স্ট টাইম বোধহয় আমাদের কোনো স্টেট কনফারেন্সে এত হয়েছে। তো প্লাস মানে সব কিছুই হয়েছে, ইনফ্যাক্ট ভোটিং হয়েছে, মানে একদম না হলে খুব খারাপ লাগতো, অন্তত একটা পোস্টে ভোটিং হয়েছে। এবং আমাদের অল ইন্ডিয়ার বডি থেকে 3 জন এসছে, এগুলো সমস্ত দৈপানের কীর্তি। আমরা এবং অরুণাভ, ইন্দ্রনাথ, এরা ডক্টর এম সাহা, ডক্টর হারাধন ভোড়া, এনাদের এই পাশে থাকাটা, তারপর মানুষ আমাদের নতুন প্রেসিডেন্ট হয়েছে, শুভজিৎ, অসাধারণভাবে হলো। সবার উপর হচ্ছে মানে স্টেটে, নাহলে লংগেস্ট বললে কিন্তু আরেকজন আছে ডিমান্ড করবেন, সে নামটা কি বলবো? আচ্ছা, তো আর কেউ বন্ড লিডার থাকে আমাদের মধ্যে, এখানে যতজন আছে বন্ড লিডার একজনই আছে, কে বলতে পারেন?
আমি বলবো,
বলো।
এই যার পেছনে দাঁড়িয়ে আছিস। আমার আরেকটা যেটা দৈপায়নদা যেটা বললো, আমি জাস্ট একটু অ্যাড করছি। এই যেটা ব্যাক অফিসের কাজ বললো না, আমি মাঝে মধ্যে স্নেহাশিস দাকে দেখি আর ভাবি যে হাউ ইট ইজ পসিবল। ওই যে বললো না যে ব্রেকফাস্টে মানে কুপন থেকে শুরু করে, স্কোর শিট থেকে শুরু করে, ব্যাক স্টেজ থেকে শুরু করে, মানে পুরো যে ফ্রেমওয়ার্ক,
না
এটা একটা অসাধ্য জিনিস।
এটা বলতে যে একটা কনফারেন্সে ছোট একটা জিনিস থাকে,
প্রচুর জিনিস থাকে,
সবকটাকে সুতো দিয়ে বাঁধা
কি করে যে মনে রাখে আমি জানি না।
আরেকটা জিনিস
আমার মনে হয় এটা বলবো, এটা মনের কথা বলছি, আমার মনে হয় এই সেক্রেটারির কোনো বিকল্প নেই।
হ্যাঁ
এক্স্যাক্টলি।
আচ্ছা না
এটা অ্যামেন্ডমেন্ট করা হোক।
আমি আরেকটা বলি, এই কনফারেন্সে একটা জিনিস দেখলাম, কখনো মনে হয়নি যে মানে আমার গলাটা শুকিয়ে গেছে। প্রথম জল তো ছিল, সেটা অনেক ইয়েতেই থাকে, বারবার করে চা কফি নিয়ে ঘুরে যাচ্ছে, এবং তেমন হ্যাঁ কাউকে ডাকতে হচ্ছে না যে এই দিয়ে যাও, প্রত্যেকের কাছে যাচ্ছে। ভীষণ কমফোর্টেবল ছিলাম, ভীষণ ইয়ে করেছি। এবং আবার বলছি, দৈপায়নের কোনো বিকল্প নেই। এবং স্নেহাশিসের জন্য পাত্রী কিন্তু দেখো না, স্নেহাশিস আমাদের হাতছাড়া হয়ে যাবে তাহলে। হ্যাঁ স্নেহাশিসের জন্য পাত্রী দেখো না কেউ, শুনেছি অনেকে চেষ্টা করছে, কিন্তু তাহলে আমাদের স্নেহাশিস হাতছাড়া হয়ে গেলে আমাদের খুব মুশকিল হবে। হ্যাঁ তো যাই হোক আবার বলি, সবাইকে ধন্যবাদ দেওয়ার সঙ্গে সঙ্গে স্পেশাল থ্যাঙ্কস সবসময় থাকবে ওই জোড়া, যেমন ডক্টর শঙ্করমোহন সেন এবং ডক্টর তরুণ পালিত ছিল, দৈপায়ন মুখার্জি এবং স্নেহাশিস বর্মন।
After 2 years of COVID, where online program was going on,
in this offline the conference I have enjoyed too much for the active cooperation between the AOI West Bengal and RGCO team, who are many thanks to RGCO team as well as the AOI West Bengal.
I request Dr. Khageshwar Raut, he is from Odisha, to say a few words.
Hello, good evening. Good evening all, I am Dr. Khageshwar and I am incidentally the organizing secretary of AOIWBCON 2022 to be held at Bhubaneswar. So it is just the man behind my encouragement is Dr. Doipan Mukherjee. So I got this opportunity from this last AOIWBCON held at Kolkata. So people supported me. So that's I could get that because there was a fight between Pune and Jaipur. So, so from the inception of our thinking, we got support from West Bengal and eastern part. So we are going to have this national conference physical form for last 2-3 years. Although we have attended lot of virtual meetings, so it is not that excitement. So I could see this, it is not less than a national conference, I can say. So it is just like any other national conference. I learn a lot. That's why I'm from day one. I couldn't attend yesterday. From my early morning till now, I'm enjoying and I'm just sticking to a seat. Thank you, Doipan Mukherjee, for giving this opportunity, and Dr. Sanasis and entire team. So thank you very much. Do come. We'll have similar celebration. We have academic, all kind of events in our conference. Please do come. We are wholeheartedly waiting you. Thank you very much. Thank you.
দীপঙ্কর দা কিছু বলুন। ও স্যার বলুন।
আমি এতদিন ধরে দেখছি এত ভালো কুইজ প্রোগ্রাম আমি দেখিনি। আমি আরো উত্তেজিত যেহেতু কুইজ প্রোগ্রামের প্রাইজটা আমার বাবার নামে, আমার স্যারের নামে, যার জন্য আমি রোমাঞ্চিত। এক কথা, আমি এক্সিকিউটিভ কমিটিকে একটা রিকোয়েস্ট করতে পারি এই ধরনের কুইজটা যেন হয় এবং এটা আগে হোক। এটা একদম ফ্যাগ এন্ডে প্র্যাকটিক্যালি কেউ নেই আর এটা যদি আরও একটু আগে করা যেত অনেকেই বেনিফিটেড হতো বা ভালো লাগতো। এত কুইজ কম্পিটিশন ভালো আমি দেখিনি। আমি উত্তেজিত আমার বাবার নামটা শোনার জন্যে বা স্যারের নামটা।
দীপঙ্কর দা।
2 বছর পর আবার ফিরে এসেছি কনফারেন্সে, এটাই আমার কাছে সবথেকে বড় পাওনা। থ্যাঙ্কস ন্যাচারালি টু দ্য আরজিকর টিম আর আমাদের এওয়াইয়ের যাদের কথা সবাই বলছে, এ তো বলার কিছু নেই, আমাদেরই তারা। দৈপান, স্নেহাশিস, দেবু ভীষণ এনথুসিয়াস্টিক। দারুণ কনফারেন্স হয়েছে, দারুণ বলতে দারুণ কনফারেন্স হয়েছে। এরকম ঘন ঘন মিট হোক, এত বড় আকারে কনফারেন্স না হলেও ঘন ঘন মিট হোক, সো দ্যাট উই ক্যান অ্যাগেন মিট। 2 বছরের যত বকেয়া পুষিয়ে যাক, ঈশ্বরের কাছে এটাই প্রার্থনা করি আর যেন বাধা না পড়ে। থ্যাংক ইউ।
অমিতাভ দা।
প্রথমত এটা বলার যে সবাই যেটা বলল, কংগ্রেচুলেশনস টু টিম আরজিকর, বিশেষ করে ইন্দ্র আমার খুব ভালো বন্ধু, এবং দেবু আর তার পেছনে যারা পুরো টিম আছে। This is a memorable, extremely memorable conference, not only because of organization but আরেকটা অ্যাসপেক্ট আছে, সেটা হচ্ছে 2 বছর ধরে আমরা যে ওয়েবিনার করতে করতে ঘরের 4 দেয়ালের মধ্যে একটা টায়ার্ড হয়ে পড়েছিলাম। এরপরে যখন কোনো কোম্পানি এসে বলতো আবার এটা ওয়েবিনার, তখন মানে তাড়াতাড়ি পালিয়ে যাওয়ার একটা টেন্ডেন্সি আমাদের হচ্ছিল। অ্যান্ড উই হ্যাভ প্রবাবলি কাম আউট অফ দ্যাট ইন দিস কনফারেন্স। এই কনফারেন্সটা আমাদের ওই কনফিডেন্সটাকে ফেরত আসতে সাহায্য করেছে। এবং সবচেয়ে আরেকটা বড় কথা, যে আমি আমার টিমের অনেক লোকেদের সাথেই কথা বলে দেখলাম যে যারা কোনোদিন স্টেজে প্রেজেন্ট করেনি কিছু নিজেদের কাজ, বন্ধ ঘরের মধ্যে ওয়েবিনারে জুম প্ল্যাটফর্মে প্রেজেন্ট করেছে। সো ইট ইজ নট দ্য সেম। এইখানে বসে একটা ভাইব্রেটিং অডিয়েন্সের মধ্যে প্রেজেন্ট করার মধ্যে যে স্যাটিসফ্যাকশন আছে, ফর দ্য বিগিনার্স, ফর দ্য জুনিয়র্স, সেই জিনিসটা কিন্তু আমরা আবার ফিরে পেলাম। থ্যাঙ্কস টু আরজিকর ফর প্রোভাইডিং দিস প্ল্যাটফর্ম এগেইন অ্যান্ড সবার কনফিডেন্সটা ফেরত দেওয়ার জন্য। থার্ড হচ্ছে, আমার মনে হয় যে নেক্সট ইয়ার আমাদের তো আবার গোল্ডেন জুবিলির প্রোগ্রাম আছে, সেটার জন্যও কনফিডেন্সটা রিবিল্ড করা হলো যে এবারে আমরা আবার ওয়ার্ল্ড ক্লাস কনফারেন্স হয়তো নেক্সট ইয়ারে করতে পারবো। থ্যাংক ইউ এভরিওয়ান ফর মেকিং অলসো আ পার্ট অফ দিস। থ্যাংক ইউ।
এবার সোমেনদাকে কিছু বলতে বলবো, তার আগে একটু এদেরকে ছেড়ে দিই। আমাদের যারা ব্যাক অফিসে কন্টিনিউ কাজ করে গেছে তাদের জন্য একটা বড় হাততালি হোক। অর্ণব কোথায়? অর্ণব, সুবিমল সামনে, মধুশ্রীদি, ধরমবীর, এদের জন্য একটা জোরে হাততালি হোক। এরা কন্টিনিউ কাজ করে গেছে, গত প্রায় 2 সপ্তাহ ধরে রাত জেগে প্রায় কাজ করেছে এরা। আর আমাদের যারা ফটোগ্রাফার আছে, নিত্যানন্দ আমাদের ডেকোরেটরের কাজ করেছে, এসকার ডেকর, আর পারফেক্ট ভিজুয়াল যারা অডিও ভিজুয়ালের কাজ করেছে, সবাইকে অনেক ধন্যবাদ। তোর যা গোছা এবার, হ্যাঁ গোছা। আচ্ছা এবারে
আচ্ছা, আর একটা জিনিস যেটা এখানে এক্ষুনি ডিসকাশন হলো, সবাই থ্যাংক ইউ দিল, এই আমাদের কিন্তু একটা ধন্যবাদ মানে প্রাপ্য হচ্ছে এন্টর টিমের। এই যে রাউন্ড দ্য ক্লক, এই যে ভেতরে চা কফি সার্ভ করা, জল সার্ভ করা, বাইরে রাউন্ড দ্য ক্লক চা কফি সমস্ত কিছু করা, হ্যাঁ ফিশ রোল, হ্যাঁ কোল্ড ড্রিঙ্কস সমস্ত কিছু, এটা কিন্তু এন্টায়ার এন্টর টিম হচ্ছে করেছে, হ্যাঁ তাই ধন্যবাদ তাদের প্রাপ্য।
এবার সোমেনদাকে কিছু বলতে বলবো। আচ্ছা আমাদের কিন্তু এখনো বাকি আছে রেজাল্ট ডিক্লেয়ার করা, সুতরাং আরেকটু ওয়েট করতে হবে সবাইকে।
আমরা গত 2 দিন ধরে দেখলাম আমাদের অ্যাসোসিয়েশন আর আরজি করের পারফেক্ট সিম্ফনি। এটা এই সুর অনেক দিন ধরে আমাদের মধ্যে থাকবে। অসাধারণ অর্গানাইজেশন, এত বছর ধরে আরজি করে ছিলাম, ওই খালপাড়ে ফিরে এলে যে একটা স্মৃতি থাকে তার সাথে আরও একটা স্মৃতি যোগ হয়ে গেল। অসাধারণ, পারফেক্ট সিম্ফনি স্যার।
সৌমিত্র, দেবাংশু, দেবাশিসদা একটু ওপরে এসো। সোমেনদা একটু ওপরে আসতে হবে। অজয়, রাজীব কোথায়? আচ্ছা এবারে আমি রেজাল্টটা ডিক্লেয়ার করছি। রেজাল্টটা ডিক্লেয়ার করছি।
অমিতাভ দা এদিকে এসো।
হ্যাঁ স্যার, মেজর কে কে ঘোষ অ্যাওয়ার্ড, যেটার জন্য সবাই অনেক অপেক্ষা করে। দ্য সেকেন্ড রানার আপ ডক্টর সাবা ইরফান। যদি সামনে থাকো তাহলে ওপরে এসো স্টেজে। ফার্স্ট রানার আপ ডক্টর সৃজনা সাহা। And the winner is, Dr. Muhammad Naqs Kamar. কোথায়? সামনে এসো, স্টেজের সামনে এসো। ডক্টর সাবা ইরফান, সেকেন্ড রানার আপ। ছবি তোলো।
হ্যালো।
Good afternoon, everyone. I'm Sabar Fan, second year PGT from Calcutta National Medical College. I thank the association and the judges for giving me this prize. Thank you, everyone.
Then first runner up Dr. Srijana Saha. তুই ওখানে দাঁড়া সামনে একটু একসাথে।
Good afternoon, everyone. I'm Dr. Srijana Saha. I'm second year PGT from SSKM Hospital. I thank you everyone, the association, the judges, and everyone present here, and our own Shengupta sir, for guiding me. Thank you so much.
And the winner, Dr. Mohammad Naqs Kamar.
Good afternoon, everyone. I thank the association for giving me the opportunity for this, and especially my mentor and guide, Dr. Doipan Mukherjee. I'm very honored and grateful for this. Thank you.
KPC?
KPC Medical College, sir.
Wow. Ek minute. Dr. B.K. Roy Chaudhary Consultant Award. The second runner-up, Dr. Shubhadeep Sardar. First runner-up, Dr. Soikat Samaddar. Soikat Samaddar. And the winner is Dr. Misbaul Haq.
I'm Dr. Shubhadeep Sardar, tutor at Jigar Medical College. Thanks for getting the opportunity after 2 years to present something in front of respected judges, my seniors, and I am also grateful to be a part of the Arjigar family who helped in organizing this AOIWB. Thank you.
Good evening, everyone. I thank all the judges, the members, the faculty, and the audience to be indulged in all of this. I have no words. Though I'm from Medical College and Hospital Kolkata, but my roots are from KPC Medical College, and Doipan sir has always been my guide, my mentor, right from the start, and that has inspired me to take ENT as my postgraduate subject. I thank all of you for giving me this award. Thank you so much.
And now, Dr. Shantanu Banerjee Video Award. The second runner-up, Dr. Divya Sethi. First runner-up, Dr. Shambhavi Shukla. And the winner is Dr. Yamuna Ranganathan.
Good evening, everyone. I'm grateful to the association, my faculty, and Command Hospital for everything that they've given to me, and I'm glad to receive this award. I'm Dr. Divya Sethi. I'm third year PGT from Command Hospital. Thank you.
Dr. Shambhavi Shukla.
Thank you, judges. I'm Dr. Shambhavi from Command Hospital, and I'm grateful for this award.
Hi, good evening. This is Dr. Yamuna from Command Hospital. This is Dr. Yamuna from Command Hospital. Thank you, association, for giving me this opportunity.
And now, E-Poster Award. The second runner-up is Dr. Olokendu Bose.
Hello. Thank you. I am Dr. Olokendu Bose from Arjigar Medical College, and thank everyone, the judges, and my mentor, HOD sir, that is Dr. Kundu sir, and everyone, Debuda and all. Thank you.
The first runner-up is Dr. Debolina Majumdar.
Debolina Majumdar.
And the winner is Dr. Divya Sethi.
Divya Sethi again.
Winner. No.
I'm again grateful to everyone present here for this opportunity, and I'm glad that I participated in all categories possible, and I received an award for the poster. I'm really grateful to everybody present here and all the faculty members, and also my faculty at Command Hospital, and especially Lieutenant Colonel Sunil Goyal, my guide.
And for ENT quiz, the second is Dr. Titasha Pakira and Dr. Reshma Babu. And the winner is Dr. Yamuna Ranganathan and Dr. Gunjan Gehlot.
Thank you so much. I really didn't expect this, but thanks to all my mentors. Special thanks to Dr. Sengupta, Dr. Mukherjee, and that's it. And I would also like to thank my father, who also belongs to this fraternity, Dr. B. Pakira.
Okay, the ENT quiz in the name of Dr. S.N. Chaudhary and Dr. P. Chatterjee. ENT quiz. Okay, now it is time to end our conference. Before that, I request everyone. First announce করলাম। Oh, yes, sir. Sorry, sir.
Good evening, I am Dr. Gunjan Gehlot from Command Hospital.
And myself, Dr. Yamuna from Command Hospital.
We would like to thank the fraternity and association and our faculty for giving us the opportunity. Thank you so much.
Okay. Now I request all to come on the dais for a group photo before ending the conference. তোরা সবাই হ্যাঁ সবাই
ওদেরকে সামনে দে বসে পার না এখানে তোমার দিকে তাহলে আমরাই বসি হ্যাঁ আরে
এই আমি তো আমি
আমাদের দুজনের জায়গা কেউ নিতে পারবে না এবারে পাশে পাশে আমাদের পাশে কে বসবে চলে কেবা এই
করঞ্জয় এসো ওপরে এসো
তোমার ফ্ল্যাশটা একটু কম
এই পেছনে সব ভীম সব লোকজন যায় উঠায় সব উঠায় শুধু অপারেশন চলায় সবাই চলায় এভরিবডি
সামনে চলে যাও
সামনে দুটো টা কেমন চকচক করছে আলো রিফ্লেক্ট করছে
সেই জন্য এখানে
for Scientist Burman, hip hip! Hip hip! Hip hip! 3 cheers for Doipan Mukherjee, hip hip! Hip hip! Hip hip! 3 cheers for all of us, hip hip! Hip hip! Hip hip!
এই এটা ইউটিউব লাইভ হচ্ছে না তো? এই অফ করো।
ওই হাতের জন্য 4টে মুখ ঢেকে গেল।
এই রে
হ্যাঁ বেরিয়ে যাও। এখানে ছবি তোলা হলে সবাইকে ডাকবে।
বেশি দেরি করো না, আর এরকম বসে থাকতে পারবো না।
আমার বন্দোবস্ত হয়ে গেছে।
All done. Thank you.